सर नमस्कार।
हाँ हेलो। हाँ सतीश, कैसे हो?
सर एकदम अच्छे से, मैंने आपको फोन किया था
हाँ,
सर।
आप बिल्कुल वक्त के पाबंद।
आपसे
नहीं।
काम है सर, आपसे काम। और अपने जो इवेंट मैनेजर है प्रकाश जी है, ये
नहीं,
एसपी
अभी
में
आपको नहीं, हाँ, नहीं,
तो ये
नहीं, आप तो अब सीजन हो गए ना।
वो उन्होंने मेरे को मैसेज किया, बोले विजय राठी सर आ रहे हो, तो सब काम छोड़ के आना पड़ा फिर।
बराबर है।
सर लेकिन आज ज्यादा फ्रेश लग रहे हैं आप।
क्या बोल रहे
ज्यादा फ्रेश लग।
हैं? नहीं नहीं, ऐसा कुछ नहीं है। मनीष आ गया
स्टार्ट
क्या?
कर देंगे सब।
हाँ, मनीष आ गया।
वो उसको फोन किया, बस ज्वाइन होने में ही है वो।
अच्छा अच्छा, ये क्या अपना हेल्थ हेल्थ फॉर ऑल नहीं?
हाँ सर, मैंने इसमें आप प्रोमोटिव प्रिवेंटिव क्यूरेटिव तीन एस्पेक्ट ले रहे हैं अपन।
अच्छा, हाँ। नहीं, उसको वो भी आने वाला ना, वो अपना डेंटिस्ट समीर केडिया, वो भी शायद है ना, उसका
हाँ,
नाम देखा मैंने।
वो भी है।
हाँ,
होम्योपैथी आयुर्वेद का भी अपन ने इंक्लूड किया है।
बराबर है, हाँ। और अपना बाबू कहाँ है अभी?
अभी सर बम्बई है कि ये अभी
अच्छा,
आया है,
बम्बई।
वो कॉल कर रहा है।
अच्छा, और बहू बहू भी उधर ही है?
सर नमस्कार।
मॉर्निंग
नमस्कार।
मॉर्निंग
हाँ, मॉर्निंग सर।
मॉर्निंग
हाँ,
सर आलोक गुप्ता सर का परिचय करा दूं। डॉक्टर आलोक गुप्ता जी जयपुर से है, इंटरनेशनल फैकल्टी है।
अच्छा, बराबर।
और सब आपके ऐसे एकदम कम बोलते हैं, सिर्फ मुद्दे की बात करते हैं।
हाँ हाँ।
और अपने को जवाबदारी ये सब कि अगले साल को जिता के लाना आईटी प्रेसिडेंट।
तो ये अनु बाबू कहाँ के है कि नागपुर नहीं?
नहीं, ये आलोक गुप्ता सर जयपुर से है।
अच्छा, जयपुर से है। अच्छा।
और आलोक सर विजय राठी सर है, हमारे पास प्रेसिडेंट है आईटी अमरावती
हाँ
के।
हाँ हाँ। कैसे सर, ठीक है?
बिल्कुल
हाँ
थैंक यू सर।
जी।
अभी आलोक गुप्ता सर ने वहाँ पे 4 सेशन, 4-5 लिए थे सर वहाँ फेडिकॉन में।
अच्छा अच्छा, हाँ
उसमें एक पैनल डिस्कशन में हम पैनलिस्ट थे।
हाँ हाँ। हाँ, ये मैं पूछ रहा था सर जी, लास्ट संडे जो है ना इंस्टॉलेशन, मैं नहीं था यहाँ पे, कैसा अच्छा हुआ?
अच्छा हूँ सर, आपके तो सबने याद किए थे।
हाँ, नहीं मैं क्या उस दिन उधर औरंगाबाद गया था, कुछ वो क्या घरेलू प्रोग्राम था, इसलिए वो रही है।
नहीं,
जो है,
और
वो जो है ना अपने राजू मोहता, वो अपने रिश्ते में आते, कजिन में, यानी नहीं, नॉट कजिन एग्जैक्टली, यानी जो छोटी सिस्टर है उनके रिश्ते में आते हैं
हमारा
राजू।
बेंचमेट, हम लोग हैं जेएमसी में तो आईजीएमसी है।
अच्छा,
और बहुत अच्छा ओरेटर है।
हाँ राजू बहुत अच्छा बात कर
हम्म।
आडोलसन पे ज्यादा है उनका।
हाँ हाँ, और वो प्रैक्टिस भी करता है यूनिवर्सिटी में।
हाँ, प्रैक्टिस करते ना, प्राइवेट में है शायद। अभी कहीं ये तो नहीं है, आईजीएमसी में नहीं है शायद सर।
ठीक है सर। डॉक्टर सचिन वेलकम, अनम्यूट करा।
Oh, sir, thank you. Good morning.
हाँ, गुड मॉर्निंग।
Good morning.
डॉक्टर सचिन, इनका बहुत अच्छा काम है वाटर कंजर्वेशन।
अच्छा, हाँ,
यानी इन्होंने एक मुहिम चला के रखी वाटर कंजर्वेशन पे।
बराबर।
डॉक्टर अर्पिता वेलकम।
हाँ, थैंक यू सर, थैंक यू। कैसे आप, ठीक है?
सचिन त्रियशी बोलत है।
हाँ
ठीक है सर।
हाँ,
आप कैसे हैं सर?
बिल्कुल ठीक है। अपनी ऐसी मुलाकात तो नहीं हुई, लेकिन अब चलो
Yes,
वर्चुअल
yes,
मुलाकात हो रही
yes, sir.
नहीं?
सर मी होतो जॉईन थोड्या वेळात अग्रवाल सर.
हो हो
हो हो हो.
तो इनॉव्हेशन राहशील सचिन.
हो सर.
डॉक्टर अर्पिता वेलकम.
Yes, sir. Thank you. Thank you.
Come.
Dr. Arpita, she'll be the session judge MOC of today's ceremony. A very young talented girl. Dr. Minalji, welcome. Dr. Minal, विजय रेड्डी सर, मिनाल अभी अहमदाबाद से है. इनकी चेन ऑफ हॉस्पिटल्स है.
अच्छा.
लेकिन दिल्ली का हम्बल ग्राउंड लेवल. बहुत अच्छे ओरेटर. आज प्लास्टिक का पॉलिश पे बोलेंगे सर.
बराबर है.
Good morning, everybody. Good morning for kind words. Dr. Satish, hello. Good morning.
And hello.
Hello, sir. Dr. Vijay. Good morning.
Yes.
Good morning, Dr. Minol.
Good morning, sir. Good morning. Good morning.
How are you?
Fine.
Yeah.
Absolutely fine.
ये सर हम लोग है ना एनवायरमेंटल ग्रुप से, मैं मिनाल अमित जी और डॉक्टर आलोक गुप्ता सर, आईपी का एनवायरमेंटल ग्रुप है और बहुत एक्टिव है.
नहीं, सतीश जी भी बहुत एक्टिव हैं. सतीश जी भी बहुत एक्टिव हैं एंड बड़ा मेथोडिक इनका काम है.
डॉक्टर गजानन पाटिल वेलकम.
हाँ सर, गुड मॉर्निंग सर.
डॉक्टर गजानन पाटिल मोर्शी के किंग है. हमारा तालुका प्रेस से मोर्शी का वहां पे तो राज चलता पूरा. And he'll be chairperson for the first half.
सर मी हे मॅडम साठी केलेलं आहे. मी वेगळ्या याच्यावर लॉग इन होतोय. हा त्याच्यामुळे हा डॉक्टर नानिवडेकर हियर.
सर परिचय द्या तुमचं सगळ्यांना माहित असावं.
हॅलो.
हा आवाज येते सर, पण यू आर नॉट विजिबल.
हा त्याने हॅलो, मी हे मॅडम साठी केलेलं आहे. त्या त्यांना याच्यामध्ये राहू देत, अटेंडिंग मध्ये राहू देत. मी वेगळ्या ठिकाणी 2 मिनिटात लॉग इन होतोय. सर मी हे
It's Dr. Nadan Naniwadikar from Kolhapur. He is executive board member of Central IP this time, consecutively second time.
सर मेरा वॉइस आ रहा है क्या?
आ रहा है.
चेहरा भी एकदम सुंदर लग रहा है.
Yeah.
थैंक यू.
Dr. Jayant Pandikar is IPP Maharashtra State Branch. He'll be joining very soon. So we'll start at 9:45 sharp and we'll finish up by 10 o'clock so that we can start the scientific agenda.
ओके.
Perfect.
So the inauguration now 9:45. Yeah.
Welcome, Dr. Samir ji. Welcome.
Thank you. Thank you, sir. Good morning, sir. Good morning, Vijay, sir.
Hello. Good morning to all.
जॉईन झालं. Good morning, everyone. Satish sir.
Good morning, sir.
Good morning, sir. Alok bhai, good morning.
Good morning, sir.
Good morning.
जैन ठीक है सगळं?
एकदम मजेत sir.
हा.
9:45 झाले. Should we start with the inauguration?
Yes, sir.
Yeah.
Dr. Arpita,
Yes, sir. Yes, sir.
Alok sir, with permission of all, we start with the inauguration.
Yes, sir. Good morning and welcome to all esteemed faculties, dignitaries, and delegates for the most awaited CME of IIP Amravati branch, CME, which is Health for All. And I would like to welcome, we have on dais Dr. Vijay Rathi sir, President of Dr. Vijay Rathi, then we have past President of IIP Amravati. Past President of IIP Amravati. Thank you so much, sir, for being with us here. Then we have Dr. Naresh Taide, sir, President of IIP Amravati. And then we have Dr. Alok Gupta, sir, with us. And then we have
Pandrikar sir.
yeah, then we have Dr. Jayant Pandrikar, sir, IVP, immediate past president of Maharashtra State IIP. I request him to say a few words.
May I start? Supposed to start, Dr. Arpita?
Yeah, just a few words from you, sir.
Okay.
Before starting.
Thank you very much, Dr. Arpita. Very good evening and a warm welcome to one and all on the dais and off the dais on behalf of Amravati IIP. Today's guest of honor, Dr. Vijay Rathi sir. Then our esteemed faculties, respected Dr. Alok Gupta sir. Then we have Dr. Satish Agrawal, who is a backbone of all this event and whole CME. And we all know Dr. Satish sir, who is very, very enthusiastic in organizing every event, whether it is for the common public or whether it is for public forum and everything. Every time is all the time interested in organizing academic activities. Dr. Satish Agrawal. We have Dr. Naresh Taide, President of Amravati IIP, and Dr. Gajanan Patilji, Dr. Amol Aminji, then Dr. Minal Aminji. Then we have Dr. Sachin Agrawal, Dr. Narendra Nanimadekar, who is the Executive Board Member of Central IIP. Then we have Dr. Amit Nimborkar as a faculty. So very good evening to one and all. First of all, let me congratulate Dr. Satish sir and team Amravati IIP for organizing such a unique event, in the sense that this event was basically what Satish sir told me. It was organized for the to celebrate the World Health Day, which we celebrate every year on the 7th April. But because we had already preoccupied events like installation ceremony of Amravati branch and other events, so we had to postpone this event to the 17th. And the unique feature of this program is that this time we have included all the three parties like homeopathic view and Ayurvedic faculty also. So in true sense, we want to achieve the health for all, everywhere, for every person. So once again, on behalf of Amravati IIP, I welcome and thank Satish sir and organizing team. Thank you very much.
Dr. Naresh sir, IIP President.
Good morning, sir.
Yes, Naresh sir, opening remarks.
Yeah. Thank you, Dr. Satish sir. On behalf of IIP Amravati, I welcome all the guests who come here for deliver their important talk on health for all. This CME is conducted as a part of celebration of World Health Day program, and this year's theme for World Health Day is Our Planet, Our Health. We have purposefully included all the topics which are dealing with the preventive and treatment and promotive aspect of health in this CME. I request all the delegates to please enjoy this CME, and if they have any queries, they can ask our estimated panelists their answers. Again, I welcome all and thanks them on the behalf of IIP Amravati. Thank you.
Yeah, I request Dr. Vijay Rathi sir to say a few words and begin with the CME.
I'm Dr. Vijay Rathi from Amravati. I welcome all of you for this seminar, Health for All.
Hello.
So I welcome all of you and enjoy all this seminar for today's day. Thank you.
Vijay Rathi sir is past IIP president, and thank you so much, sir, for the. Let's begin up with the CME now.
But we have got a few minutes. So Dr. Narendra Andiwadekar, executive board member, is with us.
Yes, sir. Yes, sir.
We request him to say a few words.
Yeah.
Yeah. Good morning, everyone, and thank you for calling me as a faculty. And it gives me great pleasure to inaugurate this function. And I can see the whole structure of this CME is such that it is not only involving the curative aspect, but it is also going to talk about the environmental health. It is also going to talk about the preventive as well as promotive health. So when we say health for all, health is a comprehensive package. It's not just few medicines given here and there. So today's CME will definitely be helpful for all the delegates who are going to attend this. And I welcome all, and I wish this CME a great success. Thank you.
Dr. Arpita, we have Alok Gupta sir with us.
Yes, sir.
His voice will be very useful, valuable to us.
Yes, sir. So I request Dr. Alok Gupta sir to say a few words.
Thank you, IIP Amravati branch, for organizing this special one-day conference CME, and thank you, Dr. Naresh Saide, Dr. Sushil Rajput, Dr. Prithuraj Deshmukh, Dr. Satish Agarwal, Dr. Vijay Rathi, Dr. Jayant Pandekar, and all the other members of the IIP Amravati branch, as well as the faculty and the delegates, for making this, crafting out this program very intelligently and very diligently to cover most of the aspects which deal with our day-to-day life. So I'm sure even the faculties will benefit from each other, because learning is a continuous process, and definitely the delegates also will be more learned after all this, and we expect the delegates to be interactive, to give suggestions, to ask questions, so that their views also come to us, and it becomes an interactive sessions. Thank you so much, IIP Amravati.
So if everybody permits, we start with the CME. Dr. Arpita. Unmute yourself. Arpita, you are mute.
Yes, sir. Yes, sir. Yes. Just a second. Today we have an opportunity to hear you all, and this is surely going to encourage us throughout the CME. So I once again welcome and thank to all the dignitaries to being here and I request now to start with the CME. As we are finishing up with the inauguration ceremony and starting up with the scientific agenda of our today's CME. And first of all, I would like to welcome, just a second. I would like to welcome Dr. Gajanan Patil, sir, and he's senior pediatrician at Morshi, and I would like to.
Thank you, madam. Thank you. Thank you.
Hello. I would like Dr. Gajanan Patil, sir, to start off with the CME.
Okay. Thank you, madam. First of all, I would like to thank President IIP Amravati, Dr. Satish Agrawal, sir. Sir, do you hear me?
Yes, very well audible.
Okay. Thank you, madam. First of all, I would like to thank IIP President IIP Amravati, Secretary Dr. Rajput and Dr. Satish Agrawal, sir, for giving me the opportunity to be a part of this educational program. Without wasting much of the time, we will start with the sessions. So our first guest speaker is Dr. Trupti Zawade, madam. She is from our hometown. She has done an MD in internal medicine and presently working as a consultant physician, diabetologist, and thyroid disorder specialist at Mahalakshmi Netralaya, Mahalakshmi Hospital for Diabetic Advanced Care and Research Center at Amravati. She has also done a PG diploma in diabetes from Royal College of Physicians, UK. She has also done a certificate course in evidence-based diabetic management from Dr. Mohan's Diabetic Academy, Chennai. She had also done a fellowship in HIV medicine and antiretroviral therapy from Infectious Disease Training and Research Center, CMC Vellore. She's now a leading practitioner from our hometown, Amravati. Dr. Trupti Zawade, madam, please.
It seems Dr. Jawad has not logged in now.
No, I think so.
Dr. Ma'am, you're there? I see if Dr. Jawad is there in the attendance.
Nice, sir.
Also, Dr. Kaustubh Deshmukh.
That can I request? We have Dr. Manish Rathi, I'm a president with us.
Oh, yes, join. Huh. So we request Dr. Manish Rathi, who is the chief guest for today's function, to say a few words. Dr. Manish Rathi.
Thank you, Satish sir. A very good morning to all of you. With people like Satish Agrawal sir and Jayan Pandrikar sir in backing with the IIP Amravati, I think these two stalwarts are more than enough to take IIP Amravati to great heights. Both are very multifaceted personalities, ready to help in any given job allotted to them. And I'm very happy that they both are my IIP Amravati members and are very active members
throughout the so many years that I have seen them. I welcome you all to this CME, Health for All. This year's WHO theme also was Our Planet, Our Health. Our planet is the mainstay of our human life. Without it, our life is not possible. We do not need only money to be healthy. We need our planet to be healthy too. Health is the most basic human right and one of the most important indicators of sustainable development throughout. Today, situation has come, our planet Earth needs us because of the multi-pronged increase in pollution on our planet in last few decades, causing great harm to our Mother Earth. We rely on healthy ecosystems to support healthy communities and societies. So without wasting much of your time, I hand over the mic to the Master of Ceremony, and I once again congratulate Satish Agrawal sir, Jayant Pandrikar sir, and the entire IAP team Amravati for conducting this fantastic CME Health for All. Thank you.
Hello.
Master of Ceremony, please take over.
Dr. Arpita. If Dr. Trupti or Dr. Kaustubh are there.
Yeah. So I'd like to welcome Dr. Kaustubh Deshmukh, sir.
Is he there? Trupti Jawade madam is there. Prakash.
Okay.
Okay.
Jawade madam is there in the panelist list, attendees list.
So should I introduce her again?
No. Now she will start with the presentation.
Okay.
I welcome Dr. Trupti Zawadi, ma'am. If she's there, so we can start up with her.
Prakash.
Madam has joined. Dr. Trupti madam, please start with your presentation.
Yeah.
Presentation.
Yes, Dr. Trupti Zawadi, ma'am. Please start up with your presentation.
Unmute yourself, Dr. Trupti madam.
Yes, sir. Just a second.
Because we finished inaugural function very short time.
True, very true.
So are my slides visible, sir?
Yeah, madam, please go ahead.
Make it full screen, ma'am.
Yes, sir.
And we take the opportunity to wish Dr. Trupti ma'am happy birthday.
Wish you a very happy birthday, ma'am.
Thanks a lot. Thanks a lot.
Madam, it's at the bottom. You may press Control F5.
It's not getting clicked only.
click on slideshow.
Extend now.
कर्सर खाली करा सगळ्यात कॉर्नरला खाली नाही खाली खाली पूर्ण खाली हे झूमच्या बाजूला इथे 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 वरती वरती बाजूला इकडे 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 कॉर्नरला मॅडम जिथे झूमचा आहेत ना 89% लिहिलेलं आहे वरती वरती हे झूम नाही मॅडम स्लाइड शो आपण जे झूम करतो ना खाली आहे मॅडम कर्सर खाली करा पूर्ण कॉर्नरला करा कॉर्नरला हा या खाली आहे हा इथे वरती बघा थोडं वरती थोडं वरती साईडने बघा लेफ्ट साईडला का नाही तिथे नाही बाजूला बाजूला लेफ्ट साईडला का हा हा बाजूला ते बाजूला 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 त्याच्या बाजूला त्या बाजूला हा ते करा स्लाइड प्लीज मेक इट
Is it visible, sir?
Yes, ma'am. Yeah.
Good morning, everyone. I am very much thankful to Satish Agrawal, sir, to give me this opportunity to stand before you and share my experience of my diabetology and the complications in the newborn and infants also, and the impact of diabetes on fetus. Maternal hyperglycemia and fetal hyperinsulinemia are most common problems that are faced in day-to-day OPD basis in our clinical practice. Now, as you all know, Acharya Chanakya, he was a very great philosopher. And he has said a long time back, that was during his tenure, he said, when a life is seeded in mother's womb, its age, deeds, wealth, education, death, all are derived right in the womb. So again, Dr. David Barker, he conceptualized the body susceptibility of lifestyle disease was programmed intrauterine, that is fetal origin of the diseases. Dr. Shisha from Chennai, he is like father of GDM in India. So Dr. Shisha said that GDM is mother of all non-communicable diseases, and the womb is more important than the home. Diabetes is a major medical problem of pregnancy associated with increased risk of maternal and perinatal morbidity as well as mortality. It complicates 1 in 20% of all pregnancies worldwide. In the year 2019, diabetes affected and estimated 223 million of people worldwide between the age of 20 and 79. And by 2045, this number is expected to rise to 343 millions. Prior to the advent of insulin, it was unheard of type 1 diabetes to have a normal life, even more rare to complete pregnancy successfully before insulin. Now it's exactly 100 years of development of insulin. So before 100 years, there was no treatment only for type 1 diabetes. People used to die. Or type 1 diabetes, there was no treatment, there was no insulin. And type 2 diabetes women did conceive, but they delivered with higher maternal as well as fetal complications. The effects on female fertility also, it's like irregular menstrual cycle is noted. Polycystic ovarian disease are common with diabetes with decreased fertility, and fertility is lower in women with diabetes in spite of even good diabetic management, good diabetes control. It is little difficult to conceive for such mothers. So as you know, diabetes is classified into gestational diabetes, type 1 diabetes, type 2 diabetes. There are other specific type also like pancreatitis, cystic fibrosis, endocrinopathies, pheochromocytomas, and other reasons. The woman is transferred from physiological point of view by nutritional demands of the fetus as well as the metabolic changes in the mother. Hence, pregnancy is known as a diabetogenic trait. Here I have tried to show the maternal and fetal nutritional transport. You can see from the placenta is there in between, and glucose, amino acids, ketones, triglycerides, they all transfer from mother to the fetus. And insulin, it does not cross the human placenta, but can affect fetus indirectly through the effect on maternal nutrition. So this is a maternal fetal nutrition transport. Maternal influx deficiency leads to increased catabolism and increases nutrient flux across the placenta, stimulating the secretion of insulin and the placenta and the fetal pancreas, leading to macrosomia. So when a diabetic mother delivers, the baby is almost macrosomia with a huge body weight. And the fetal growth is stimulated because the mother, in mother, the increased elevated plasma glucose, amino acids, and lipids, these all cross the placenta and they all contribute to mixed nutrition, leading to raised insulin, raised growth, and so the fetus that we see is macrosomia. This is again a small picture showing about the gestational diabetes and the baby leading to extra weight gain. So let's see the effects of fetal hyperinsulinemia. The effects of fetal hyperinsulinemia are macrosomia, as I showed the slide, increased deposition of adipose tissue, hemoglobin accelerated skeletal maturation, increased hepatic glycogen content, delayed pulmonary maturation leading to impaired surfactant production, delay in switch from fetal hemoglobin to adult hemoglobin, polycythemia, stillbirths due to poor metabolic control, and neonatal hypoglycemia due to increased fetal insulin secretion in response to the maternal hypoglycemia. And the anomalies that are seen with the timing of lesion and the post-conception period. So skeletal anomaly, caudal regression, and spina bifida, they are seen at third week and 6th week. Then neural anomalies like anencephaly, myocele, hydrocephalus, they are seen during the 4th and 5th week. Then cardiovascular problems, dextrocardia at the 4th week, conus arteriosus defect at the 5th week, and ventricular septal defect at the 6th week. Renal agenesis and hypoplasia at 6 weeks. Effects of diabetes on neonate: hypoglycemia, respiratory distress syndrome, hyperbilirubinemia, hypocalcemia, polycythemia, traumatic deliveries, hyaline membrane disease, and apnea and bradycardia. The long-term effects of diabetes on offspring are obesity, hyperinsulinemia, hyperglycemia. And the complications, as you know, toxemia of pregnancy, acidosis, vascular complications, infections, urinary, vaginal infections, and hyperglycemia can lead to coma also. So these are the effects of diabetes on pregnant women. So polyhydramnios, preeclampsia, preterm labor, postpartum bleeding, spontaneous abortion, retinopathy, hypertension and IHD, nephropathies, and autoimmune neuropathies. This will all contribute on the fetus naturally. So what happens in gestational diabetes is actually there is increased insulin resistance due to increased maternal hormones such as human placenta lactogen, progesterone, prolactin, and cortisol. There occurs increased insulin resistance, and due to the compensating insulin resistance, a hyperplasia of beta cells occur, leading to hyperinsulinemia. And due to increased glucose clearance, increased fasting insulin, and a decreased hepatic output, leading to a change in fasting plasma glucose levels. So gestational diabetes is defined as the intolerance of carbohydrate, that is glucose intolerance, in any degree with onset of first recognition during pregnancy. Worldwide prevalence range varies from 1% to 15% in all pregnancy. In India, prevalence rate has gone very high, that is 2% in 1982 to more than 16% by 2002. And in a multi-center study by Dr. Sisha sir, it was found that GDM was found in Kashmir highest and in Tamil Nadu. So pregnancy is a diabetogenic state. In normal pregnancy, there is resistance and diabetogenic stress are countered by the various factors, and increase in insulin is seen, which is adequate and appropriate. And when the compensation is inadequate, the GDM develops. Women with GDM are unable to increase insulin levels because there is insulin resistance. And so this resistance occurs usually in the second trimester. And so there is increased human placental lactogen, prolactin, cortisol, and the other various hormones. And therefore GDM sets up into 24th and 28th week of gestation in almost all the cases. There is a contra-insulin effect. The placenta supplies the growing fetus with nutrients and as well as provides variety of hormones to maintain pregnancy. And of these hormones, estrogen, cortisol, and HPL, placenta lactogen, have a blocking effect on insulin. This is called contra-insulin effect, which usually begins about 20 to 24th week in the pregnancy. And gestational diabetes results when this insulin produces insufficient to overcome the effect on the placental hormones. Symptoms of diabetes are the patient always feels thirsty, there is blurry vision, wounds that don't heal, vaginal infection, patient is always hungry, always a lethargic, tired feeling. There are sexual problems, numbness or tingling in hands and feet, frequent urination, and there is weight loss. So again, the risk factors for development of gestational diabetes are same as positive family history, bad obstetric history, previous IUD, previous or concurrent PIH, hydramnios, like elderly primary, obesity, multipara, twin gestation, previous big baby, and congenital pregnancy, congenital anomalies. So when and how and whom to screen? So the American Diabetic Association has given selective screening because their pattern is different. Screening undiagnosed type 2 diabetes at first perinatal visit using standard diagnostic tool and criteria. In women who are screened negative at first visit, perform 75 grams of oral glucose tolerance test at 24 weeks and interpret using the criteria recommended by the International Association of Diabetes in Pregnancy Study Group. And in Indian scenario, it's like universal screening. You have to screen all the mothers coming to the clinic for the first time visit also. Hence, it's like all pregnant women should be screened for diabetes. So screening test, everyone knows, 75 grams of glucose is given in 200 ml of water and consumed over a period of 15 minutes. And then the venous blood sample is taken at 2 hours. So the fasting blood glucose is more than 92, 1 hour is more than 180, and more than 2 hours it's 150 according to ADA. Whereas the DIPSI, diabetes in study group, says that it's just one-step procedure, and the diagnosis is also subtle, that more than 200 mg per DL, it is diabetes. And 140 to 99, it is gestational diabetes. More than 120, it is decreased glucose tolerance. If negative, then you have to repeat it again after 24 to 28 weeks of gestation. So management, it's pre-pregnancy counseling. Like counseling plays an important role, as a lot of education is needed for the mother. If she is very well educated, and if she is even counseled very well from our side, then it helps a lot in the outcome, and we can stop this maternal-fetal transmission also. Then control during pregnancy and post-pregnancy control. These are the important aspects in GDM management. So pre-pregnancy diabetic clinic, you have to educate and obtain maximum cooperation from both the partners, optimal diabetes control before conception, encourage health and hygiene of the patient, check immune status. As everyone knows, rubella and CMV and adenovirus and mumps and certain viruses are associated with cell destruction, implicated in inducing the disease again. Understanding the risk factors, what is diabetic pregnancy involves, and other nutritional supplements are important aspect of pre-pregnancy counseling. Actually, the mother, when we tell the diagnosis of diabetes, she is in a state of denial, anger, acceptance is very low, and many a times they go in depression also. So you have to handle that emotional level of mother as well. Initial evaluation of pregnant women with diabetes is, as I told about the self-monitoring and education. SMBG plays an important role. Adjusting insulin regimes if necessary and checking on the diet, which is very important. She has to consume all low glycemic index foods till total entire 9 months period. So preconception target is also preparendial. Your blood glucose should be 90 mg per dl and postparendial blood glucose should be 120 mg per dl. HbA1c in non-diabetic range. So the management approach in GDM is diet, exercise, blood glucose determination, intensive insulin regimes. These are the 4 main pillars which stand for controlling sugar in gestational diabetes. Diet, as you all know, has to be low carb diet, Mediterranean diet, DASH diet, vegan diet, fiber diet, and low fat diets, non-nutritive sweeteners. You have to select according to the BMI of patient and as her needs, whether she's vegetarian or a non-veg person. And so you can select the diet accordingly. So medical nutrition therapy plays an important role in GDM mothers. Exercise is again a very important aspect. Patient should be given exercise as per her stature, her BMI, not weightlifting and all, but still she can continue her walking, slow jogging, and yoga exercises. Some meditation is also important. Now, glucose monitoring is SMBG, that is reliable and used worldwide. Urine glucose is less reliable because of low threshold, and urine ketones, calorie intake insufficiency, carbohydrate intake is important. HbA1c can serve as an indicator for almost approximately a period of 3 months. But up till 28 weeks, lab monitoring done once a month. From 28 to 32 weeks, it is done once in 2 weeks, and from 32 week onwards you have to do once every week. So frequent monitoring is very important in gestational diabetes pregnancy. So obstetric management, it is again, you have to keep on charting all the things very well. You have to see weight as well as diet, BP, then HbA1c, KFT, creatine clearance, daily protein excretion. A baseline ophthalmic examination is also important. Congenital risk counseling is important, and sonography for fetal anomalies is important. That is done in sonographies are important during the 2nd and 3rd trimester. And treatment, the only best medicine available till now is insulin. It is a miraculous drug. There is no drug like insulin. Insulin requirement is calculated as per the trimester. That's in first trimesters it is less, but in 2nd and 3rd it increases. So best is insulin. Now, when to initiate insulin? Insulin, even after 2nd week of MNT, after giving medical nutrition therapy to your patient, after 2 complete weeks, the majority of SMBG readings, if they are more than 90 in fasting and more than 120 in post meal, then you can initiate insulin. Measurement of 2-hour postprandial is recommended, whereas others offer the option of testing it at 1 hour only. Frederick Banting, as rightly quoted, insulin is not a cure for diabetes, but it is the treatment part of diabetes. So insulin regimes are like simple rapid acting regular insulins are given in morning and evening time. Premix insulin 30-70, 50-50, regular isofin and regular are given in divided doses. Glycemic target in pregnancy, fasting should be almost 90 and postprandial should be 120.
Ma'am, I'm sorry, but this is just a reminder. Time is getting exceeded.
So maternal hyperglycemia and fetal hyperinsulinemia are key of pregnancy metabolism. And as I told, the womb is more important than home. So we have to concentrate during conception period, whether if there is GDM, then you have to keep on tracking all the things very well so as to avoid all the complications of fetus and neonate. Otherwise, this GDM is a home for type 2 diabetes in future and all the other non-communicable diseases. Complications, as everyone can see, there are various complications in pregnancies, in diabetes, sorry. Yeah. And managing a case of GDM is a multidisciplinary approach. It needs a diabetologist, a continuous intensivist, obstetric team good to manage the complications, then even a neonatologist. And for fetal anomaly scanning, you need a good expert hand. So it's like a multidisciplinary approach to manage gestational diabetes. Thank you.
Thank you so much, ma'am, for enlightening us, and wish you a very happy birthday once again. Indeed, it is a well said term that health is like money, and if we don't value it, then that is a wrong way. Until we should value it until we lose it. So you proved it right, and it was very informative.
Thank you, madam. Madam has elaborated nicely on gestational diabetes and its impact on fetus. Now I think the next lecture is from Dr. Kaustup Deshmukh, but he's not able to join. So we can go ahead with the Dr. Nina Vadekar sir's lecture. Okay.
Yes, sir, I'm around. Shall I share the screen?
Prakash, his slide. Introductory slide. Prakash.
You welcome Dr. Nandan Nanivedkar, sir. The topic is irrational drug combination when addition actually subtracts. So I request sir to start with the topic.
So Dr. Nanivedkar sir is sir, welcome.
Thanks.
His introduction, introduction.
Sir, welcome. So Dr. Nanivedkar sir is MD DNB DCH Pediatrics. He's practicing pediatrician and neonatologist at Nirmaya Pediatric Nursing Home and Aster Other Hospital. He's a national convener for IIP Pulse module for the year 2021-22. He is also currently an executive board member for Central IIP. He has also received awards, particularly for his case series in neonatal multisystem inflammatory syndrome associated with perinatal maternal SARS-CoV-2 infection. He has also published an update on recent guidelines during update on resuscitation guidelines during COVID-19 pandemic. Dr. Nina Nanivedkar, sir, please.
Yes. Thank you. Thank you at the outset for allowing me to present my presentation at Amravati. I especially thank Dr. Satish Agarwal, Dr. Pandrikar, who have been my friend since last few years, and this gives me a great opportunity. Thank you very much. Is my screen visible?
Yes.
Yeah. I'm going to talk slightly on a different subject today. Irrational drug combinations when addition actually subtracts. So let us quickly go through a few case scenarios which we usually see in a routine day-to-day practice. This is a 1-year-old child who has come with loose motions, watery with no blood, vomiting for a day, which has now stopped. He is afebrile.
Screen share
There is
करा
some dehydration.
सर screen share करता है क्या?
Oh yes, just a moment. I thought I have shared the screen. Is it visible now?
Yes, sir.
Yes, sir.
Just a moment. Is it visible now?
Yes, sir.
Yeah.
Make full screen.
So, yeah, this has already been done. Are you able to see the full screen?
Yes, yes.
No, sir. So make it full screen.
Yeah, it is already made full screen over here. I'll do it again. Is it seen as a full screen?
Yes.
No.
I'll go again. Are you able to see?
Yes, sir. Yes.
Yeah.
Is it, sir, full screen is not.
Just a moment. Give me a minute. There's some issue. Are you able to see now?
Yes, sir.
Are you able to see?
Yes, sir. Yes.
Yeah, fine. Thanks. Sorry, let us not waste time. So we are going to talk about the irrational drug combinations. So this is a 1-year-old male child came with loose motions, watery with no blood mucus, vomiting for a day, now which is stopped. On examination is afebrile. There is some dehydration. This child is well nourished otherwise, and the abdomen is soft. The peristalsis is normal. The diagnosis is acute gastroenteritis. The treatment which was offered to him was a combination of ofloxacin and metronidazole. For fever, paracetamol and mefenamic acid, and a combination of racecadotril with Saccharomyces boulardii. And for pain, he was given cyclopam. Then there was a case, a 7-month-old child, male, fever, cough, breathlessness, no vomiting or refusal to feed. On examination is febrile, respiratory rate of 60 per minute with some distress and a pulse rate of 140 per minute. He's got bilateral Krebs and bronchi. The diagnosis is bronchiolitis. This child was put on ceftriaxone, clavulanic acid, ibuprofen, paracetamol, and a bronchodilator and mucolytic combination.
Adendra, sir.
Yes.
Sorry to interrupt. The slides are not moving. The first slide only is visible, the title slide.
Oh, I don't know what is gone wrong. I'll just stop sharing and do it again.
Prakash ji, can you help, sir? फक्त पहिली स्लाइड दिसत आहे टायटल स्लाइड.
आता दिसते का?
हाँ सर, आता आहे.
आता दिसतंय सर.
Okay, fine. So I'll move this next slide so that we will come to know. Is it visible now?
Yes, sir. Yes, sir.
Yeah. So this child was put on ceftriaxone and clavulanic acid, ibuprofen, paracetamol, bronchodilator and mucolytic combination. The third case, 1.5-year-old child, fever, breathlessness, grunt, and he was febrile, toxic, was having bronchial breathing in the right side and reduced air entry. The diagnosis was lobar pneumonia. This child was put on ceftriaxone and vancomycin as a single injection and other supportive line of treatment. And a case 4, child who has got fever, child has got skin eruption over body, pruritus, there's excessive perspiration, and the findings are suggestive of fungal infection. This child has been put on some cream which contains clobetasol, neomycin, and miconazole. And a fifth case where the child has got fever for 10 days, poor appetite, abdominal pain, is febrile, toxic, there's a palpable spleen, the diagnosis is enteric fever. Put on a combination of cefixime and ofloxacin for fever, paracetamol, and aceclofenac. And sixth child, who is 1-year-old male child with a cough, cold, fever. His febrile throat is normal, RACVS is normal. He is put on syrup combination Febrex plus 5 ml TID. So what is the common factor? What is peculiar in each case? And what is the rationale for the drugs which have been used in each case? What is correct and what is not? This is what we are going to discuss today. Let us not go into the details of each rationality of each treatment, because that itself is a separate topic. But for gastroenteritis, if you see rationally, usually it is viral diarrhea, which is self-limiting. ORS, zinc, and SOS IV fluids in the child is intake is not good. That is a treatment. What is happening over here is this child is put on ofloxacin plus metronidazole for so-called mixed diarrhea. There are issues regarding the frequency of medication which is being used and the dosages. So what is it? First of all, there is no such thing as mixed diarrhea. Amoebiasis and bacterial diarrhea rarely coexist. And the drug of choice in dysentery or bacterial diarrhea is cefixime. Usually ofloxacin, or for that matter any quinolone, is not to be used below 6 years of age, as it yet not been considered safe. And if at all it is to be given, it is to be given twice a day, whereas a metronidazole is used 3 times a day because of the half-life. Second thing, amoebiasis is rare in pediatric population, more so in a child who is 1 year old. So this child is getting 2 antibiotics when they are not indicated, and only one of the drugs of combination will be effective and the other would be useless. Case 2, bronchiolitis, again self-limiting condition, hydration, antipyretics, nasal suction, nebulizer, oxygen, IV fluids, that would be the management goal. If you add a antibiotic that's not indicated, and of all, cephalosporin plus clavulanic acid and paracetamol with ibuprofen. As we talk, bronchiolitis is a viral infection, so combining cephalosporin with clavulanic acid has got no pharmacological basis. Clavulanate is used with amoxicillin for the beta-lactam effect. And second thing is paracetamol half-life is different from ibuprofen half-life. Plus ibuprofen itself can cause bronchospasm, like those who are sensitive to aspirin. So this is going to make the things more complicated, and the antibiotic is used when it is not indicated. Then the case 3 of pneumonia. Ceftriaxone has a longer half-life than vancomycin, and it is to be used once or twice a day. Vancomycin is used 3 to 4 times in a day. Combining them in a single injection is irrational, and I'm not sure whether this combination is going to be efficacious, because the efficacy of drug, whether it is hampered, there are no studies. Then a usual story, a topical triple cream, which contains an antibiotic, antifungal, and a steroid. Usually the steroids will mask the inflammatory process and will make the diagnosis difficult. And most important, there is an emergence of resistant fungi. We are seeing that usual clotrimazole or miconazole is not working. People are going for the higher antifungals for local fungal infection also. And why this is used? This is used chiefly on the principles that isme se ek to kaam karega. So that is not a correct way of starting. First of all, we do not require these 3 drugs added together. If it is a fungal infection with secondary eczematization, maybe a mild steroid to come down the inflammatory process and an antifungal chiefly. And if it is infective, then usually antibiotic alone should be more than sufficient. Now regarding enteric fever, the drug of choice is cefixime or ceftriaxone, depending on whether you want oral or injectable. Adding ofloxacillin is not indicated, and combining the drug as a single medicine has got no rationale. Again, when we use a drug combination of paracetamol with chlorpheniramine maleate and phenylephrine, usually paracetamol needs to be given every 4 to 6 hours depending on the fever, and chlorpheniramine maleate is usually given 2 to 3 times in a day. So this combination also doesn't make a great idea. This is used for so-called convenience, forgetting that many times when the child is running only fever, the child receives this kind of medicine when there is not an indication for the medicine for cold. And in that case, the child is having cold, then the child is receiving paracetamol for no reasons. So let us see what these fixed drug combinations are. The fixed drug combinations are the combinations of two or more active drugs used in a single dosage form. And a combination product is a product composed of any combination of a drug and a device. Either it's a biological product or a drug and a device. Ideally, one should be using drugs mostly as a single compounds, but there are few areas where fixed drug combination products need to be used. And they are acceptable only when the dosage of each ingredient meets the requirement of a defined population group. And the combination has proven advantage over single compound administered separately in therapeutic effects, safety, and or compliance. What is the pharmacological principle of combining two drugs? The drugs in the combination should be acting by different mechanisms. The pharmacokinetics must not be widely different, and the combination should not have supra-additive toxicity of the ingredients. The advantage by using fixed drug combination is there is a convenience in drug dose schedule and better compliance, and it has got an effect of enhanced effect of combination. For example, estrogen and progesterone for the first convenience of dosage schedule, chiefly in the anti-COX treatment and the anti-HIV treatment, where the combination, because patient has to take multiple tablets or multiple medications. And of course, minimizing the side effects, for example, levodopa and carbidopa. So these are the common examples of rational drug combinations. All of us know trimethoprim with sulfamethoxazole, amoxicillin, clavulanic acid, ampicillin, sulbactam, ferrous salts with folic acid, anti-COX, levodopa, carbidopa, and injectables. We can use the piperacillin and tazobactam, which are definitely of synergistic effect. But the problems of combination we have to keep in mind. The dosage alteration of one drug is not possible without alteration of the other drug. Differing pharmacokinetics of constituent drugs pose more problem of frequency of administration of the formulation. And of course, logically, it increases the chances of adverse drug effects and drug interactions compared with both drugs given individually. About the first point, I can just quote, if you see a combination of montelukast with levocetirizine, all this combination has got each 5 ml of 4 milligram of montelukast and 2.5 milligram of levocetirizine. Usually the patient is prescribed this medicine 5 ml twice a day. So a 1-year-old child receives 8 milligrams of montelukast instead of 4 milligram of montelukast. And nobody gives a thought to this process. Why these FDCs are popular? Usually we are seeing that in Indian pharmaceutical market, they are very, very popular and have been flourishing in the last few years. They are made popular by the representatives by highlighting the double benefits without discussing the pharmacokinetics or pharmacodynamics. And doctors do rely more on the representatives than the textbooks and journals. And there are multiple reasons. Either there is a lack of information related to indications or safety of drugs. There is a faulty and inadequate training and education of medical graduates. There's poor communication between the health professional and the patient. There's a lack of diagnostic facility at times. That's the reason why these two drugs are used, where I'm not sure whether I'm dealing with an amoebic dysentery or I'm dealing with a bacterial diarrhea. Then there is a demand of patient, doctor, do dawai mat likho, ek hi dawai likho. There are defective drug supply systems and ineffective drug regulations, which is the situation in India. And the promotional activities of pharmaceutical industries, much can be talked about it. The flip side of this FDC is the adverse reactions, emergence of resistant microorganism, financial complications, masking, confusing, and delaying the correct diagnosis. At times, the titration of dose of medicine that we have already talked about, and FDCs increase the price of medication if unnecessary drugs are included. For example, ibuprofen, paracetamol, caffeine. This caffeine is not needed over here. At the same time, one of the drugs in the combination may be superfluous or may be wasteful, like multivitamin, where a small dose of iron is added, which is not going to have any effect on the patient. Plus, we have to keep in mind the dangers which can create. For example, antihistaminic and antidiarrheal is a dangerous combination because antihistaminic action may mask the other symptoms and make accurate diagnosis and treatment difficult, and at the same time, if there is some adverse reaction, it will be difficult to know which medicine has caused the adverse effect. The ADRs or the adverse reactions, previously in yesteryears, there was a combination of nimesulide plus paracetamol, which is even doing rounds in the market today. Nimesulide alone is more antipyretic than paracetamol, more anti-inflammatory than aspirin, and is equivalent in analgesia to any of the NSAIDs alone. But the efficacy gains are unlikely with added paracetamol. Of course, it's a different story that we have stopped using nimesulide since last almost 20 years because we have seen lots of hepatotoxicity. We have seen a lot of thrombocytopenia associated with nimesulide. The same can be talked about the combination of paracetamol with mefenamic acid, where mefenamic acid is more antipyretic, but it is to be used 8 to 12 hourly. But whatever can be achieved by paracetamol, there is no need to add mefenamic acid. Plus, the risk of nephrotoxicity is more with mefenamic acid. Plus, other example, this is not my field because pediatric, we hardly use diclofenac and serratiopeptidase, but there are combinations which are available. They do not offer any particular advantage over the individual drugs, despite the claim that serratiopeptidase promotes more rapid resolution of inflammation. But the patient is more exposed to risk of GI irritation and serious bleeding from unsuspected give. This is another yet irrational combination, quinolone plus nitroimidazole, that is norfloxacin plus metronidazole, ciproflox with tinidazole, oflox with ornidazole. They have not been recommended in any of the standard books, yet they continue to be used in practice for GI infections, pelvic inflammatory disease, dental infection. Usually they cover up for the diagnostic imprecision and the lack of access to laboratory facilities. If we are pinpointing the diagnosis, either usage of only one drug would be more than sufficient. The use of an antibiotic with metronidazole is justified only in cases of peritonitis or a surgical condition where there is intra-abdominal infection, where there definitely superadded infection or the co-infection of both anaerobic as well as the gram-negative bacteria is likely to be positive. Then there are combinations of analgesics with antispasmodics. They are not only irrational, are also dangerous. The antipyretic drug promotes sweating and thereby will help in heat dissipation. An anticholinergic will inhibit sweating. Combination can lead to dangerous elevation of body temperature. Now most of these drugs are getting banned. So in India, we see a drug is sold as two when none may be needed or only one may be needed. Combined milks pills are marketed with slogans like ibuprofen for pain, paracetamol for fever, brufen for peripheral action, paracetamol for central action, and usually the medical fraternity falls prey to such gimmicks. And at the same time, we have to keep in mind the patient is paying more for this. So addition of the drug, addition is going to make an addition to the patient's bill, but it is not adding to the benefit, it is subtracting the benefit. The gullible patient has to pay for doctor's complaisance in terms of extra cost and extra adverse effects. Addition of drug does not add to the cost equivalent to 1:1. It may be going beyond that. Instead of having ek ke upar ek free, you end up paying more for the things you may not require. Add to it the adverse reactions which are going to create more morbidity and at times even mortality. Plus, we have to keep in mind the medical legal aspects. It is known that medical practitioners who usually patronize such combinations could be center of controversy when subjected to litigation in consumer forums, as these combinations do not find mention in standard text or reference books and reputed medical journals. And pharmaceutical manufacturers, they continue to reap the benefits of huge scales, so continue to promote this combination, and it's a give and take cycle. More prescriptions, more companies join the race, and the more sales are increased because somebody is creating a combination of one irrational drug, the other company joins the fray. So now the time has come for all practitioners as well as consumers to raise this matter vociferously to all possible avenues. Drug regulatory bodies should take urgent action to mitigate the free flow of these irrational FDCs. And as a doctor, when such a new drug is given, I think it's a time of Google. Google ka zamana hai. You can just go and check on Google whether these combinations make rationality, whether these are rational combination, they are compatible pharmacokinetically or pharmacodynamically. If you see, there are few combinations like this which are good and they make an impact. And they, however, there are these which are not very good combinations. And it's O2, CO2 today, don't be surprised to see H2O3 and H2SO4s tomorrow. This also is okay in the restaurant, but not in medicine. Thank you.
So thank you.
Am I supposed to take questions right now, or we are supposed to take it later?
Dr. Gajana, is Dr. Kaustuv
Sir, are we going to give take question answer session?
Yes, yes, give me.
Okay. We need to unmute the participant.
Just put in the chat box, Dr. Gajana. There is a question for Dr. Trupti Javade madam in the chat box. Dr. Trupti ma'am, are you there?
Yes, sir. Yes, sir.
Dr. Kirti Basatwa, she has asked the role of metformin in GDL.
Yes, sir. Actually, in recent years, metformin has gained acceptance as safe, effective, and rational in reducing insulin resistance in pregnancy and also in type 2 diabetes GDM cases, polycystic ovarian syndromes. And it is benefited in obese non-diabetic women also during pregnancy. But the effect of insulin on the fetus is not yet known, and so not yet well studied also. So better to shift patient on insulin as far as treatment approach is concerned.
Excellent. Dr. Nazir, sir.
Yes, sir.
Sir, a very often asked question, which is the ideal cough suppressant or cough expectorant? Because as you said, we get a lot of combinations. Yeah. And the question becomes relevant in the age of less than 6 months, where there are no bronchial muscle development, so no role of bronchodilators and no role of cough suppressant. What is your opinion, sir?
First of all, if you see commonly below 6 months of age, you don't see a child who has come with a dry cough who requires a cough to be suppressed. Usually that cough is secondary to bronchiolitis, which is going to be which can be taken care by just giving him humidification. You give him oxygen if required, and that will take care. Usually the dry cough comes up little later, and majority of the times if you see a cough suppressant which is required, most of the times dextromethorphan alone should work, and that gives relief to the patient, but that should be used on an SOS basis, because at one time you have to keep in mind that cough is body's mechanism of throwing out something. When the cough is coming from the upper airway, usually it is irritation, and that's the irritation which we want to suppress. When it is coming from the lower airways, usually it is secondary to bronchospasm, where nebulization is or inhalation therapy is going to help this child. And over there too, at times the nighttime cough usually irritates the child. So only an SOS use of medicine should be done. As far as possible, combination of this bronchodilator mucolytic should be avoided. Although it's a major controversy, if you are talk to any pulmonologist, people end up giving something or the other, but that is usually to soothe the patient, because the patient has to be satisfied that something is to be given. But personally, if you ask, then try to treat the primary cause. Usually nowadays we are seeing more of an allergic cough where your inhalation therapy is going to work for the patient. And of course, you add the demulcents like honey and water, which is definitely proven to be a good antitussive.
Excellent. And a role of cetirizine in such respiratory tract infections, because most of them they are being prescribed.
Yeah, the thing is, if you see the role of, if you see the antihistaminics which are to be used, then usually upper respiratory airways, the first generation antihistaminics are preferred over the second generation. Second generation are the ones which are used for allergic rhinitis, which is also a common condition nowadays. So as a child who comes with fever and cold, my first choice would be a combination of chlorpheniramine and phenylephrine. That too, again, like paracetamol, should best be used as an SOS basis. If the child is having a runny nose, it's irritating him, that's the time when we should be using them, not as a round medication. Cetirizine preferably over for the allergic rhinitis.
Excellent.
Sir, are there any questions?
Dr. Gayan sir, any other question?
No, sir. Sir, I want to ask one question. What is your opinion about promethazine as a cough suppressant? Can we use it in low dose?
I have not used it. I won't be able to answer this correctly, but usually it's a very potent sedative. So by this action itself, it can cause some cough suppression because the child sleeps deeply, but then it will have its flip side also. Because the child with respiratory distress, if you sedate such a child, then his respiratory drive may be going, and even if the dose goes slightly more, then it can create more problem. So on an OPD basis, it will be not, I won't be recommending promethazine as a first antitussive. Usually dextromethorphan is the thing. Although if we see the antitussive action, the codeine has got a more better action, but that also is not safe in OPD practice.
The recent guidelines from the government of India is that we should not use dextromethorphan below less than 4 years.
Yeah, that's true. But if you see the usual practice, that is the reason behind is because there are no studies which have been done. But as I said, usually we do not require these cough suppressants in a slight child who is less than 4 years of age. Majority of the times on day 1 or day 2, you require to use these cough suppressant where the dextromethorphan is safe.
Okay, sir. So thank you very much. Dr. Nani Wadekar sir has described routine pediatric conditions which we come across in day-to-day OPD practice, where number of irrational antibiotics combinations are prescribed. Sir has given a very good guidelines so that we can avoid prescribing such irrational drug combinations, particularly an antibiotic combinations in the future. Sir, thank you. I think Dr. Kaustubh Deshmukh is still not been able to join this session. So we can move for the next session. Dr. Arpita, madam, please.
Thank you, sir, for enlightening us with this wonderful knowledge. This quote is definitely there, that happiness begins with good health. I would like to thank Dr. Gajanan Patil, sir, for being there. And now I would like to welcome and introduce the chairperson for our next session, Dr. Richa Wankhede, ma'am. I would like to hand over the session to Dr. Richa Wankhede, ma'am, who is MD Pathology at GMC Aurangabad and is SR at LTMMC Sion Hospital and Kasturba Hospital, Mumbai, and practicing currently at Pinnacle Pathology Lab, Amravati. Very good morning to you, ma'am, and welcome to you. Now I hand over the session to begin the session to Richa Wankhede, ma'am. Thank you. Ma'am, are you there? Dr. Richa Wankhede, ma'am, are you there? It seems ma'am is not there, so.
So she's there. Dr. Richa. Dr. Richa. Okay, so Dr. Arpita, you introduce the first speaker.
Okay, just a second. So the first speaker for the topic is Emotional Health by Dr. Manjusha Giri ma'am. So Manjusha Giri ma'am is the chairperson of AHA Nagpur, and presently she is a director at MHA Institute of Science and Commerce, executive committee member, Nagpur. I would like Dr. Manjusha Giri ma'am, are you there? Dr. Manjusha Giri ma'am, are you there?
Good morning. Am I audible?
Yeah. She is Dr. Richa,
Yes, sir.
the chairperson for this session. Prakash is very long. Dr. Richa.
Yes. Thank you, sir. Good morning to you all. First of all, thank our organizers for giving me a chance to be here. And without further wasting any time, I'll introduce our next speaker, Dr. Manjusha Giri. She's a chairperson of Adolescent Health Academy of IIT Nagpur. She's also a co-chairperson of Save Girl Child Initiative of IMA Nagpur.
Dr. Richard, let me interrupt. Dr.
Yes, sir.
Richard, the speaker has been introduced, but I'm taking some time. So we move on to the next speaker.
Okay, sir.
The next speaker is Dr. Sachin Agiwal, sir. Dr. Prakash is the next speaker. Dr.
Yes.
Richard.
Yes.
Go ahead.
Our next speaker is Dr. Sachin Agiwal. BIA and MD in Swasthavritta. He is ex-vice vice principal and principal investigator for sponsored research project in Shri Gurudev Ayurved College, Tivsa. He is also HOD and AP at Swasthavritta department of the same college. He'll talk on the topic Ayurveda, the way to life. Sir, Dr. Sachin Agiwal.
Dr. Sachin, sir.
Yes. Thank you, sir.
Welcome. So you may start sharing your screen.
Okay. Thank you, madam, for a wonderful introduction. I am thankful to the IAP. I am thankful to IAP for this wonderful opportunity. Today, I am giving the I will put my some points on the Ayurveda, the way to live life in a way of Rutucharya. Rutucharya is seasonal regime for healthy living. What we will learn in this lecture, we will see the 6 seasons, status of doshik, status in each season, food and lifestyle recommendation for each season as a promotive health, summary and keynote out points for each session. Ayurveda has divided a year in two kal, that is Adan kal and Visarga kal. All of us known as Uttarayan and Dakshinayan. Adan kal is a taking away and Visarga kal is a giving back to environment. Division of the year is done based on the position of the sun. the Adankal period when sun sucks out or absorbs the energy from the earth, and opposite the Visargakal, that period when the sun gives out energy to the earth. So this is the Shad Rutus as explained in the Ayurveda. That is a Hemant Rutu, Shishir Ritu, Vasant Rutu, Grishma Ritu, Varsha Rutu, and Sharad Rutu. India is a country blessed with the 6 different Ritus, and some countries has only one, that is winter. Some has 2 winter and rainy season, but we have 6 seasons in our India. The reason behind different seasons on earth is in the picture. Season change and our eating habits, lifestyle, physical activity, and everything else needs to change accordingly. Simply because our body is built in such a way that it responds to every season in a unique fashion. And we need to aid our body in doing so by adopting according to the needs of the season. When we fall to do so, that is when disease come knocking. These are the 6 seasons which are come according to the English months, that January, February. It starts from the Vasant Rutu. Vasant Rutu starts from the Gudi Padwa. These are the status of rasa and bala during the year. There are the 6 rasas in Ayurveda, that is the tikta, bitter ras, kashai, katu, amla, lavan, and madhu. So we start from the Hemant Rutu, that is a early winter. Early winter is when temperature begins dropping and chill in the air increases. The weather starts getting pleasant and we start feeling cold. This is the Hemant Rutu. And this is the part of the Visarga Kal, when the sun is giving out energy to the earth. So we get all energy from the sun. So in this season, we have to change our some food habits. The digestive capacity of the body is pretty good in this season, and Ayurveda recommends taking heavy foods in this season. One should prefer sweet, sour, and salty tastes. These tastes and heavy food can help keep vata in control. There are the three doshas theory in Ayurveda, principles of tridosh theory, vat, pitta, kapha. According to that, this rutu uh, is important for to control vat. So we are eating madhur ras, we are eating sweet, sour, and salty. Wine is recommended to keep the body warm during this season. Food to be taken, that is a heavy food, heavy non-veg preparations, snigdha dravyas, means with oils, madhur ras, amla ras, lavan ras, wine, madhu, that is honey. It is very important to take in this season. Milk and ikshu, that is a sugarcane products. So we have to change up lifestyle recommendation. Try to keep yourself warm by wearing the warm clothes. Massage your body regularly with warm oils and cover your head and ears when walking out during the early winter. This is a very important thing. With that, we can prevent the most of the uh, infectious diseases. Get adequate exposure to sunlight. Food not to be taken, that is a lahu, that is a light food, that is a mung dal. Ruksha, that is a without oil. That type of the food should not be taken in this season. Activities: oil massaging, application of oil over head, sun bath, reducing in warm underground chamber, residing in a warm underground chamber, wearing of heavy woolen clothes, use of thick blankets, unlimited indulgence into sexual activities. These are recommended in this Rutu. Now we will move to the Shishir Rutu. After the Hemant Rutu, it comes, so it's a late winter. Shishir Rutu is when temperature drops significantly and the atmosphere is quite cold and windy. The earth gets filled with snow and the weather outside become extremely chilly. So in this scenario, our digestive fire or agni is at its best during the winter season. Ayurveda recommends sweet, sour, and salty tasty during these seasons. Diwali is also coming in this season. Since our appetite is heavy during this season, Ayurveda allows us to consume rich foods and even slightly oily foods that can help keep the body warm. Some lifestyle recommendations: indulging in exercises that can help cause sweating is strongly recommended in this season, that is a Shishir Rutu, which is a winter, later winter. Warm clothes and sweaters are practiced. Regular body massage with warm oils are recommended during the season. Adequate exposure to sunlight is also extremely important. Now, next Rutu is Vasant Rutu. With passing time, the winter season comes to an end and the sun begins to rise again. Flowers start blooming as the weather starts getting warmer. This signifies the start of spring season. An aggressive and frozen kapha dosha starts melting in this season, and that in turn results in diminished agni or digestive fire. So our digestive capacity drops significantly during the spring season. Food to be taken: light and easily digestible foods, barley, godhum. In non-veg, light cooked meat, mild alcoholic beverages, shunthi, that is a dry ginger, warm water, honey should be taken in this season. Avoid the sweet, salty, or oily foods as they tend to increase kapha. So most of the diseases are occurred in the Vasant Rutu is a cough, and so we recommend a woman in this season. Food not to be taken that is heavy, sour, and sweet food should not be taken. Activities should like a emesis, that is known as a woman, as a panchakarma in Ayurveda, dry massage, more physical activity, garglings are more important to reduce the cough in our body. It is strictly prohibited to sleep in the afternoon during this season. It is strictly prohibited to sleep in the afternoon during the season, which is going to end sometimes. Next Rutu is the Grishma Rutu. It will come after 10 to 15 days, but environmental changes shown some signs and symptoms of the Grishma Rutu. Once the spring season comes to an end, the cough that had melted in the body begins to stop. It comes out of the body. The increasing summer heat dries up that cough, and the two dosas that get aggravated during the summer season are Pitta and Vata. Pitta, being fire, naturally gets aggravated during the summer season, and dryness and lightness in the weather also aggravates the Vata dosha. So, dietary recommendation during this.
Thank you, sir. Very enlightening talk indeed. As rightly said, old is gold. Ayurveda is an ancient science and is indeed the best way for life. So our next speaker is Dr. Amit Nimborkar. He is practicing homeopathy since 15 years. He has completed BHMS from Shri Kamakshi Devi Homeopathy College, Goa. He is associate professor in Department of Medicine at Takatmal Medical Homeopathic Medical College, Amravati. He is a life member of Liga Medicorum Homeopathica Internationalis. He has presented many scientific papers in international conferences like Dubai and Paris, where he was recognized as youngest chairman of scientific committee and in many national conferences as well. Dr. Amit Nimburkar. Is sir available?
Yes, sir. We are seeing the Grishma Ritu. The two doshas get activated, which we have known as the and Vata. So dietary recommendation for the Grishma Ritu are the since the energy is being extracted by the sun during the summer season, we feel weak and debilitated, and our appetite also goes down as our digestive fire or Agni is.
Dr. Amit sir, you may share your screen.
Definitely.
So food not to be taken, that is alcoholic beverages.
Sir, am I audible?
Yes.
Richa ma'am, can I start with my presentation or should I wait for Rajwal sir to finish?
Yes, finish. You may start, Amit sir.
Okay, sir. First of all, a very good afternoon to everyone. I thank IIP Amravati branch to giving me this opportunity to present my views on homeopathy and overview. As we all know that World Health Day was celebrated on 7th of April, and this time the WHO theme was of 2022 was Our Planet, Our Health, and theme for today's CME is Health for All. Dr. Samuel Hahnemann, the founder of homeopathy, has correctly said in his Organon of Medicine, that is Bible of Homeopathy, what we say, the physician's high and only mission is to restore the sick to health, to cure, as it is termed. As per WHO, homeopathy is the second largest medicine stream and is used by over 500 million people. 10th April, we celebrate as World Homeopathic Day. Dr. Samuel Hahnemann himself was MD, and then he founded the new branch of therapeutics, that is homeopathy. Homeopathic system of medicine founded on a definite law, that is similia similibus curantur, like. The homeopathy word itself is a Greek word. Homeos means similar and pathos means suffer or disease. It is a therapeutic method of symptom similarity. Hippocrates had sensed the possibility of law of similia, and it was founded in Vedic system also. A substance that causes a certain set of symptoms in a healthy person will have a curative effect when given to a sick person who's displaying the similar symptoms. This is what law of similia says. In homeopathy, we treat patient as a whole and not the disease individual. We treat person in whom the disease prevails. So that's why when we prescribe medicine to a patient, we take into consideration his mental state, his physical generals, and the pathological state, what he's suffering from. And that's what the medicine, what comes up, we call it as a similimum. So now homeopathy in pediatrics, because we have very sweet pills, children take it very easily. There are no surgical interventions. We boost up immunity of the child, and we stop the recurrent tendency of the disease, which is the hallmark, I would say. Now let's talk on the scope of homeopathic medicines used in pediatric cases. If we just take a simple condition, Nicnanthus is one of the remedy which we usually use it for obstinate constipation in children. Now, Nicnanthus is made from a parijat flowers. Now, when we see into the homeopathic aspect, we have constipation. If you can see the below slide, I mean at the bottom of the slide, we have 69 medicines for constipation in children. Now we have to select one of the remedy to give it to the child. So Nicnanthus is one of the remedy for obstinate constipation. Second remedy is causticum, which when the patient passes stools only in standing position, then we prescribe causticum. When a child have a soft stool and it is passed with difficulty, then we prescribe alumina. When the stools are hard, difficult, small, we prescribe lycopodium. When the patient says that stools comes down, but it expels or it when it is partly expelled, it recedes back, we prescribe silica. Why I'm telling you all this is because we have individualization in the homeopathy. Constipation, if the child comes with constipation, we see to it that which symptoms are fitting into which remedy, and that remedy we prescribe. So individualization. No two persons with same disease will be prescribed same homeopathic medicine. It has to be an individualistic approach. Second is xerophyllum. One of the remedy we give it for concentration difficulty in studies. We see very, very commonly nowadays because of this too much of screen use in this last 2 years. Dullness, misspells common words. He writes last letter first, that is now he will spell it as 1, and dermatitis, especially around the knees. That is, he writes last letters first. We say it as a learning disability. Xerophyllum is also very good remedy for ADD, attention deficit disorder. So vast clinical provings are there in our books. Drug proving is mostly done in homeopathy on healthy individuals. Let me take up a case, a small case. Master AK, 6 years old boy, consulted us for recurrent eruptions on hands and leg, more on joints since childhood. Eruptions are crusty, thick, itching, and it bleeds easily. Recurrent fever, hard stools, and urine he has to strain. Past history, he had measles. Mentally, the child was very cooperative and matured in behavior. He used to feel very bad as he could not attend his school because of those eruptions on the joints. So, why I showed you this is we take into consideration all the mental state of the child, all the physical generals, his aversion, desires, stools, urine, everything. And then the case was diagnosed case of epidermolysis bullosa, which is supposed to be a genetic disorder. He was a known case of epidermolysis bullosa simplex. These are the pictures on the joints. And this is an old case, but I'm showing it now because one of my first cases. So we take into consideration all the eruptions, crusty, thick, bleeding, itching, pustules, and then we prescribe a remedy which comes up as a mesarium remedy. Mesarium we gave, and slightly eruptions were better. And these are the follow-up pictures. He did not get cured completely, as we all know that it's a genetic disorder, so it cannot be cured completely, but he was managed very well. And he started going to school. So look, you can look at his smiling face. He started going to school. He started mixing in the people. Children started telling him to come and sit next to him because of the eruptions, they could not allow him. One of the case I would tell you, because of we take into consideration dreams also. A female of 15 years, she had involuntary urination in sleep, that is nocturnal enuresis, after seeing dreams of urination. Patient used to get dreams of passing urine in public places, in open ground. She feels very conscious. She tries to put up pressure in order to empty her bladder quickly, and she passes urination in the sleep. This was a dream, and she had severe headache before menses. So on the basis of this dream, we prescribed her creosote, and her dream stopped, and her nocturnal enuresis stopped. Asthmatic child, one more case. Asthmatic child, she came in acute exacerbation state. She was very breathless, heaviness in chest, aggravation on slight exertion, and she was better by rapid walking, which was a very peculiar symptom that she couldn't walk a step, but when she used to walk fast, she used to feel better. Her respiratory rate was 30 beats per minute, breaths per minute. She was prescribed Lobelia inflata in water, and within say 15 minutes, she was little better. Next 15 minutes, she was able to walk, and she went home. So that's why I'm telling you this case is because homeopathy is said to work in chronic conditions. Yes, it works very well in chronic diseases, but in acute also, it works. Recently, we are doing a proving on mobile phone radiation. That is our medicine made from mobile phone radiations. First proving was done in 1999. A 10-year child came with complaint of chronic headache more when using mobile. Child was so sensitive that if someone is using mobile in his surrounding, he is to start getting attacks of headache. He consulted a neurophysician. MRI brain was normal, no specs. In clinical trials, we found that mobile phone, we gave her a dose, we gave him a dose of mobile phone 30, a single dose, and her headache, his headache reduced drastically. It is usually mostly in pain in head and ear, when the child is irritable, when there are noise in the ear and with the deafness, especially in elder patients, and concentration difficulty in studies and work. Children have more need of models than of critics. That's what I usually tell my parents or tell my colleagues. And parenting is one of the key factor. We have to look and do parenting very properly. That is how you can keep your new generation away from the screen, and you can motivate them to go into the ground and play and become healthy. Scope of homeopathic medicines in pediatric cases. Few of the cases which gets referred to us, so I'm just giving a list of it. Atopic dermatitis, molluscum contagiosum and warts, pigmentation disorders and vitiligo, allergies, nocturnal enuresis, alopecia areata and totalis, adenotonsillitis, delayed milestones. We have very good remedies for those. ADD, ADHD, OCD, learning disabilities, autism spectrum disorders. Autism can be very well managed. Cerebral palsy, which cannot be cured definitely, but the spasticity of muscles and everything, we can make it little less. All the anxiety, examination funk, and my favorite is behavioral disorders in children. I usually deal with those people more, those child more. If you see into the pathological this thing, PCOS, hypothyroid, juvenile arthritis, which cannot be cured definitely, but can be managed. Growth disorders, fibroadenoma of breast in very young girls, very recurrent. They remove it and again it starts growing. Recurrent ARI, recurrent UTI, renal calculi, again recurrently. What are the limitations of homeopathy? See, each and every pathy has scope and limitations. It is not like all the pathies can do everything. Absolute surgical cases, we cannot cure. Irreversible pathology, definitely we cannot help. We don't have contraceptives in homeopathy. We don't have anesthetic agents in homeopathy. And we don't have direct supplementation therapy. That is, we don't have direct B12 or vitamin D3 drops and all that. So we do have calcium, but we don't have few of the vitamins. So these are the limitations of homeopathy. So today's takeaway message from my side is, health is like a guitar, pull the strings rhythmically. That is, integrated health approach is necessary to tune life into a beautiful song. And the 6 strings of guitars are allopathy, homeopathy, Ayurvedic, physiotherapy, psychotherapy, and nutrition. This is what I feel. I know psychotherapy and nutrition is not one of the therapeutic streams, but they are very important as we have to manage the patient completely and holistically. So a synergistic approach is very necessary when it is needed. When in acute case, we refer patients to allopaths, allopathic, my seniors, my colleagues, they manage the case very well. When it comes to chronic, we manage it with homeopathy. When it comes to when there is a need of physiotherapy, I think our painkillers won't work, but then the exercise and with that patient can be cured completely or they can be managed. Psychotherapy, definitely psychotherapy and counseling is much needed nowadays, and definitely a nutrition, a healthy diet is very, very necessary for all the disease conditions. That's all from my side. Thank you very much, IIP Amravati branch, Dr. Naresh Taide sir, Dr. Rajput sir. Special thanks to Dr. Jayan Pandrikar sir and Dr. Satish Agrawal sir for giving me this opportunity and to present my views in front of August gathering. It was my pleasure to be here. Thank you so much. That's all from my side.
Dr. Rucha, unmute yourself. You're mute.
Thank you, Dr. Nimborkar, sir. It was indeed a wholesome overview of homeopathy, and an integrated approach is absolutely needed. Now I think Dr. Manjusha Giri madam is back. She's already been introduced by Dr. Arpita madam. Please, madam.
Prakash,
May I question, sir?
you have to stop sharing screen.
Naresh sir, we have got 5 minutes for question answer. If you can withhold for 5 minutes.
Am I audible?
Yes, ma'am.
Yes, ma'am.
And my screen is visible?
Yes, madam.
Slideshow. Yes, it's moving.
Yes, madam.
Thank you. Thank you so much. Good morning, one and all. First of all, I want to thank Dr. Naresh Taide sir, President IIP Amravati, Dr. Sushil Rajput sir, Honorary Secretary Amravati Nagpur, then Dr. Rituraj Deshmukh sir, Treasurer IIP Amravati, and last but not the least, Dr. Satish Agrawal sir, who is convener and guiding force for us and IIP Amravati. Good morning to all delegates, chairpersons, faculties, and today's my topic is emotional health, a success mantra, a key to success mantra. First of all, we have to understand what is emotion. Something puts us in motion. It is internal conscious states that we infer in ourselves and others. We can see smiley, they have different emotions. Overall, there are 9 major emotions and more than 3,000 emotions are there. Emotion, it is if there is a significant life event, then emotions are seen. It has 4 components which we have to understand so that we can manage our emotions properly. It has feelings, bodily arousal, it has sense of purpose and social expressions. For feelings consist of, it is subjective to everyone. Each and everyone, they have different types of feelings. They vary in intensity, they vary in quality. It gives rise to affective responses. Suppose मुझे बुरा लगा, मैं रोऊंगी, या मैं अपने ककून में चली जाऊंगी, मैं लोगों को अवॉइड करूंगी. Then it shows pleasure and displeasure. Then meaningful and personal significance are there for feelings. Then after feelings, it comes with bodily arousal, biological activation, autonomic and hormonal system response. अभी अपने पहले जो लेक्चर हुआ था, sir has said कि psychotherapy is very important. And yes, sir, it is very important in nowadays scenario. and for every disease control mechanism, patient psychology should be handled properly. Third bodily arousal component is we have to prepare and activate adaptive coping. Suppose there is some unwanted situation, then we have to go backwards. Okay, so we have to prepare and activate adaptive coping mechanism, and body is prepared for that action. After bodily arousal, there is a sense of purpose. It gives goal-directed force, motivates to take action, cope with circumstances, and social and evolutionary advantages. And fourth component is social expressions. It is through our posture, our gesture, our vocalization. हम कौन सी चीज किस तरीके से कहते हैं, जैसे एक सिंपल वर्ड है that differs, vocalization. Then practical expressions, and it helps to interpret situations. So ये एक slide पे भी पूरा topic पूरा 1 घंटा चल सकता है. I am covering it very fast. So why the current trend of interest in emotional intelligence? I am taking 2 examples. Raj is a more and more frustrated with his assignment. He is 10th standard student. He is frustrated with his assignment. It is very lengthy, unable to complete in a given time. He stands up, yells out, and tears the book in frustration. This is not a way of acting to that situation. And उसने अपना खुद का ही नुकसान कर लिया. Then in a college or workplace or family, ये कहीं पे भी हो सकता है. XYZ had people gossiping behind her or him. She or he just never responded. करो, gossip करना है करो, मैं respond नहीं करूंगा या नहीं करूंगी. And pretended she didn't know. मुझे कुछ पता नहीं है, मेरा एक गोल है, मुझे वो अचीव करना है, आपको जो करना है करो. और हो सकता है ये लोग हमें फ्यूचर में भी काम में आ सकते हैं. She knew these people would be useful later in her life or his life, and she just stopped talking to them. For time being आप उनसे बात करना बंद कर सकते हैं, कम्युनिकेशन कम कर सकते हैं, लेकिन हमें अपने रिलेशंस खराब नहीं करने हैं. These are 2 examples. एक ने अपना ही असाइनमेंट फाड़ दिया और एक ने वो सिचुएशन वाइजली हैंडल की. So continue. In at least 20% of people experience some form of illness. हमारा जो वर्ल्ड है या हमारी जो दुनिया है उसमें 20% लोग either depression, mood disturbances, substance abuse, committing violent crimes, suicidal behaviors, or eating disorders, sleeping disorders. There are many disorders which people are facing, many psychological disorders. So these components, they hamper their emotional state and they hamper their work output. So who nurtures emotional intelligence? There are parents, teachers, and self. There are 3 core components who nurtures our emotional intelligence. And as Daniel Goleman said, Daniel Goleman जो है वो हम कहते हैं ना हरि भक्त परायण, जो जिन्होंने इमोशनल इंटेलिजेंस का वर्ड कॉइन किया या उसका जो पूरा स्टडी किया है, he is Daniel Goleman. Then he says family life is our first school for emotional learning. First is parents, family life, then school, then teachers, and most important is we ourselves who nurtures our emotional intelligence. So there are situations like success, achievement, happiness, satisfaction in life, or professional and personal level. So what is more important, EQ or IQ? According to me, developing EQ is a key to success. Why? You can see this iceberg. IQ is only tip of iceberg and EQ is part below that tip of iceberg in the sea, which holds us and which directs us to our success or achievement or our happiness or our professional and personal satisfaction. So again, Saint Daniel Goleman for me, he says success in life can be attributed only 20% to your IQ. It is tip of iceberg, but 80% to other factors like EQ, SQ, and all. So by teaching people to tune into their emotions with intelligence and expand their circles of caring, इंटेलिजेंटली हमें बिहेव करना है और हमारा जो केयरिंग का सर्कल है, हमें जो चाहने वाले हैं या हमारी जो रक्षा करने वाले हैं या हमें जो रास्ता दिखाने वाले हैं, ऐसे लोगों का सर्कल अगर हम बढ़ाते हैं, then we can transform organizations from the inside out and make a positive difference in our world. So emotional intelligence is a very important phenomena and very important part of our life. So what is emotional intelligence? Emotional intelligence is a social intelligence, which is way of recognizing, pehchano, understanding, samjho, and choosing how we think, feel, and act. It shapes our understanding and our interactions with others. So हमें पहचानना है, it is social intelligence. So out of control emotions can make smart people stupid. So we have to be very intelligent at emotional level. IQ is an intelligence quotient, it does matter. EQ is an emotional quotient, it matters a lot. EQ is a decency quotient. अगर emotional quotient हमारा proper नहीं रहेगा, तो नीचे का quotient जो है decency quotient and social quotient, it will get affected, which does matter in our success, in our life, in our achievement. So there are 4 important domains of emotional intelligence. One is intrapersonal and another is interpersonal. In intrapersonal domain, it's a self-awareness, then self-management. अगर मैं खुद को नहीं जानूंगी तो मैं खुद को कैसे मैनेज कर पाऊंगी, है ना? और अगर हम खुद को ही नहीं जान पाएंगे, हम खुद को ही मैनेज नहीं कर पाएंगे, then our interpersonal level will get affected, which is social awareness, which is empathy, and relationship management, that is social skills. And if these components are strong, these domains are strong in our life, then we will succeed, we will achieve our goals. So this is a busy slide. I will take one by one. First is personal component, and recognition of personal component is self-awareness. It improves our self-confidence, that is self-esteem. It makes you aware about your own emotional states. It helps you recognize how your behavior impacts others, and it helps to pay attention to how others influence your emotional state. So this is personal component, that is regulation. And then another personal component with regulation is self-management. You have become self-aware, then you have to manage yourself by getting along well with others, handling conflicts effectively. Whatever conflicts are there, you have to handle them effectively and clearly express your ideas and information. You have to be firm in your sound and your vision. Then using sensitivity to another person's feeling, that is empathy, which is very important part, and to manage interaction successfully. If you are empathetic to person, if you are empathetic to that situation, then you can manage these emotions properly. Then social component is recognition, then social awareness. हमने self awareness कर लिया. Now it is our turn to do social awareness, or then picking up on the mood in the room. अगर हम कहीं जा रहे हैं और वहाँ पे क्या discussions हो रहे हैं, then how should be your body language and your responses. You have to first listen to them. You have to sense what's happening. Then caring about others are going through. क्या हो रहा है उन लोगों के साथ, and hearing what the other person is really saying. So our listening capacity, our listening skill should be well developed. So for social awareness and for social competence regulation, relationship management, which is the crux of this topic. So getting along with others, handling conflicts effectively, clearly expressing ideas, information, same as personal feelings. So why emotional intelligence is so important? If you recognize your own emotions, you can manage your own emotions, you recognize others' emotion, you manage your others' emotions, then you will be very effectively, you will take charge of your life and you can manage emotional reactions of a day-to-day life properly. It will reduce stress and worry and increase productivity and manage priorities more effectively. It will build confidence, self-esteem, and better self-esteem with better interaction with others, which in turn helps in making decisions and objectively evaluating various options. And it will maintain motivation to focus energy on what can be influenced or controlled. There are multiple problems and which you have to tackle first. अगर हम इमोशनली इंटेलिजेंट रहेंगे, इमोशनली स्टेबल रहेंगे, हेल्दी रहेंगे, तो ही हम प्रॉपरली पहचान पाएंगे और टैकल कर पाएंगे. It helps in gaining self-control to communicate more effectively in conflict situation. It will improve ability to innovate. अगर हम सही मायने में हेल्दी रहे इमोशनली, तो इनोवेटिव आइडियाज आएंगे. We can think out of box and make one more flexible and acceptant of change. We have to develop empathy and we can develop with a emotional healthy lifestyle. Then happy to manage relationships, helps to manage relationships more effectively, more positively, and we can become popular and socially secure, as we human beings are social animals. We are animals, but we are social persons and we can manage our emotions. So we can manage our relationship and contributes to overall happiness. Less chances of drug, alcohol addiction. If you are emotionally healthy, you are happy, you are creative, then there is no need of any substance abuse, and it is a predictor of success, that is high grades, higher achievements. And so what are the indicators of poor emotional health? How you can find out if some person is suffering from poor emotional health? It has low energy, isolation from family, friends, and society, prefers to stay alone. There are sleep disturbances, there are eating disturbances or eating disorders. Then racing thoughts are there. They jump from one idea to another and they हम देखते हैं कि कोई बंदा होता है कि जो एक बिजनेस से दूसरे बिजनेस, दूसरे से तीसरे बिजनेस और हर जगह अनसक्सेसफुल रहता है. There might be some reason behind that, like emotional intelligence की कमी हो सकती है. Racing thoughts, then low performance at work, increased interpersonal conflicts, झगड़े होना, then feeling of irritation, guilt, fear, helplessness, and neglecting personal care and hygiene. कैसे भी घूमेंगे उनका ध्यान नहीं रहता है. And what are the characteristics of emotionally healthy person? They are with positive self-esteem, productive, happy, satisfied, contented, can conduct day-to-day activities efficiently and nurture him or herself properly, thrive in challenging environments. कोई भी situation हो, वो उसमें से निकल सकते हैं. And they learn new things, enjoy life, express oneself in an appropriate manner. They are more productive. They realize their potential. क्योंकि वो खुद को ही जानते हैं ना, वो खुद को जानेंगे तो भी तो potential जानेंगे. Then work in coordination with others. Then contribute towards family and society and maintain physical health. So these are the signs of healthy person. what are the benefits of a high emotional intelligence in healthcare? Improved communication. देखिए आप साइकिल पे भी देखेंगे तो दिल गाड़ी चला रहा है, दिमाग पीछे बैठा हुआ है. So improved communication and teamwork, ability to respond well under pressure, increase empathy, better quality of care, and greater career satisfaction. These are the signs of a emotionally healthy healthcare workers and their productivity. So can EQ be developed? First, we have to see emotional intelligence or emotional health is dependent on biological factors, biopsychosocial model. Biological, that is physical health, proper sleep, proper diet, proper exercise. Psychological factors, self-care, positive attitude, self-aware, training, then coping skills, great coping skills, and stable behavioral pattern. Then social factors, family, friends, and social atmosphere. SQ is better than relationship management, interactions, and economic status will be better. So EQ is dependent on biopsychosocial model. So if we work on these factors, then EQ can be increased or emotional health can be increased. What are the ways to achieve good emotional health? We can maintain mood journal. It is not necessary for daily, लेकिन जब भी हमारा mood swing होता है, that time we have to write down what was the preceding factor and what was your reaction. ठीक है? Then we can maintain emotional diary. महीने में कितनी बार हो रहा है, हफ्ते में कितनी बार हो रहा है, then साल में कितनी बार हो रहा है, हमारे किसी से conflicts तो नहीं हो रहे, that we have to maintain in a diary. Then we have to understand and work on 3 strong feelings, that is stress, unhappiness, and anger. And basics like proper diet, sleep, and exercise and healthy habits should be maintained. We have to stay connected. एक दूसरे से मिलते रहना है, and we have to avoid substance use or abuse, which we can see more in our healthcare professional also. So we have to practice self-awareness, self-management, goal setting, relationship skills, responsible decision making. We have to take responsibility of our decisions. हम क्या करते हैं, दूसरे पे डाल देते हैं, ये ऐसा हुआ था इसलिए मैंने ऐसा किया. नो, मैंने ऐसा किया, ये मेरी रिस्पॉन्सिबिलिटी है. Then we have to develop resilience. कोई भी सिचुएशन हो, हमें काम करना है, हमें आगे बढ़ना है. Coping skill mechanisms and problem solving skills should be worked on. We have to improve our adversity quotient. Adverse condition में हमें कैसे behave करना है, and try to meet demands of life. So we have to be mindful and proactive. And most important is, अगर हम डायरी मेंटेन करेंगे तो हमें पता चलेगा कि हमारे इमोशनल मूड स्विंग्स कितनी बार हो रहे हैं, और अगर हमारे ज्यादा बार हो रहा है तो we have to take help of a counselor. And we can learn emotions from our surroundings also. Glue teaches us to stay emotionally connected to self and others. Elastic teaches you to reduce stress and avoid emotional overload. The pulley teaches you to attract and hold attention of others. And the ladder teaches you to rise above life's difficulties. So we are not born with emotions and social skills. We have to stimulate these skills. We have to inculcate those skills in ourselves. होता क्या है, we are looking for managers. बहुत गुस्सा आ रहा है, बच्चे को गुस्सा आ रहा है, उसको मोती की अंगूठी पहना दो, उसको ये माला पहना दो, उसकी ये पूजा करा दो. We are not working on our emotional skills. कोई अंगूठी या कोई माला पहनाने से गुस्सा कम नहीं होता है या मूड्स चेंज नहीं होते हैं. So it is not a one-day seminar जिससे आपको फायदा होगा. We have to practice it regularly. self-awareness followed by impulse control, persistence, then self-motivation, empathy, and social agility. We can lead to emotional. If we success practice in this manner, then definitely एक emotional intelligent बंदा आपको दिखाई देगा. We can use the ruler program. Recognize emotions in self and others. Understand cause and consequences of emotions. Label emotions accurately. Express emotions appropriately, and regulate emotions effectively. So we should not forget ruler. To summarize, emotion has two components: intrapersonal, interpersonal. All are interlinked. Then emotion, self-awareness, social awareness. If you are self-aware, self-management, self-performance. If you are socially aware, relationship management and people's performance. So where you are staying in society or at workplace, it affects your performance as well as that institute's performance also. So we have to be emotionally healthy. Thank you. Thank you all. Good luck in developing and strengthening emotional intelligence. And I'm giving thought, feeling, and behavior model of cognitive behavior therapy, which we can work on it for emotional health management. At the end, I will say, नजर को बदलो तो नजारे बदल जाते हैं. नजर को बदलो तो नजारे बदल जाते हैं. सोच को बदलो तो सितारे बदल जाते हैं. कश्तियां बदलने की जरूरत नहीं है. कश्तियां बदलने की जरूरत नहीं. दिशा को बदलो तो किनारे खुद ब खुद बदल जाते हैं. Thank you all.
Dr. Rucha, Dr. Naresh Tadi sir was asking some questions. Dr. Rucha madam, unmute yourself. Dr. Rucha madam, unmute yourself. This question from Dr. Naresh Tadi to Dr. Amit Nimborkar sir. Dr. Naresh Tadi.
First of all, congratulate all for excellent presentation today. And this is also for the allopathy and homeopathy both. If they think there should be more randomized controls trial or clinical studies, so that there should generate lot of research evidence and we can know exactly if this is a statistically proven that they are helping the children, because our aim should be the health of the person. Which pathy is going to help? If the both pathy, if required help of the other pathy also, we should take, not afraid of taking health of the other pathy. But before that, we should have generate scientific evidence that there should be some, definitely some benefit. Their comment on this.
Yes, sir. If I have to say, we are doing nowadays a lot of randomized control trial on efficacy of homeopathic medicines, especially in pediatric age group patients. And the only difficulty what we face is that in homeopathy, we have individualization. So as I told you in my presentation, that if a same diagnosis patient comes, we have to differ with the medicines, like constipation जो मैंने आपको बताया था. So there is no definite medicine, one medicine for one diagnosis. That is one of the most difficulty which we face. But definitely you're very correct that we have to do RCT, and we are trying to do it, and we are trying to collect the evidence-based medicine documents for that.
Thank you, sir. Ayurvedic, sir, want to talk on this?
Sorry, sir.
Dr. Sachin Agrawal sir is there. He doesn't seem to be pierced.
Friday sir has asked one more question that what about predictive homeopathy? He had asked, I guess. They are all the names and the way they practice homeopathy. The basic homeopathy is Samuel Hahnemannian homeopathy, which is the basic of all. These are all the modern homeopathy, classical homeopathy, predictive homeopathy. They all have been given names, nothing else. I hope I answered your question, sir.
Yeah, thank you, sir. Thank you.
Dr. Uchet, there is a question for Dr. Manjusha Gill, ma'am, from Dr. Kamlakar Devgare, sir. Dr. Kamlakar Devgare, sir, are you there? Manjusha, ma'am, he has asked, if suppose EQ is less, the chances of depression are more. How far is it correct?
Yes, sir, it is correct. But if EQ of any person is less, then is he more prone to go in depression? Please explain the relationship between less EQ and depression. EQ is less, emotional stability is less. That means person's self-esteem is less, problem-solving capacity is less, and then there are more chances of depression in these patients. It's proportional to EQ. Depression and EQ are directly proportional. Indirectly proportional, sorry. Less EQ, more chances of depression.
Sir, I hope Dr. Kamlakar Devgare, sir, your query has been answered. If there are any queries, they may be put in the chat box. And if not, then we move to the next session.
Thank you, everyone. Now I'll hand over to Dr. Arpita, madam, for next session.
Ma'am, you have beautifully presented and shown all the aspects of health in different fields. As Franklin Lippmann said, health is more than merely the absence of disease. It is total state of physical, mental, spiritual, emotional, and social well-being. So it is indeed true. And I would like to thank Dr. Richa Wankhede, ma'am. After that, now I would like to welcome and introduce our next chairperson for the next session, respected Dr. Sagar Sonawne, sir, who is MBBS, DCH, DNP Pediatrics, Professor, Department of Pediatrics at Dr. Vasantrao Pawar Medical College Hospital and Research Center, Nashik. So I would like to tell Sagar sir to take over the session.
Yeah. Thank you, madam, for the kind introduction. So should I, anybody there to call for speakers?
Prakash, just show the slides. Slide to Sagar sir, you have to introduce the speaker.
Yeah. So, first lecture is on dental health by Dr. Samir Kedia. So he is reader at Department of Periodontology, Dental College of Amravati, and practicing on in Amravati since 9 years. And he has been past state vice president and president-elect of Amravati branch, and also past assistant governor in the Rotary. So I will request Dr. Samir Kedia to continue with his talk.
Thank you very much, Dr. Sagar sir. Very warm good afternoon to all of you. Sir, may I share my screen?
Yes.
Yeah, thank you, sir. President of IAP, Dr. Naresh sir, Secretary, Dr. Sushil sir, Rituraj sir, Treasurer, Convener of today's program, Dr. Satish sir, our guest, Dr. Manish Rathi sir and Dr. Vijay Rathi sir, all the chairpersons, delegates, and the panelists. The topic of today's discussion is oral health, why to neglect? Being this presentation made in a pediatric association, I have labeled it as different ages, different stages. Not because I'm presenting over here, but really it is a fact that for a parents in a parent's life, pediatrician is the most important person. And the reason why it is, Sagar sir will definitely agree with me, because babies, they do not come with the owner's manual. So for a parent, pediatrician is the only doctor. Most of the times he's the first doctor, and many of the times he's the only doctor to whom they concern whenever there is any issue with the babies. And that is why today's discussion is important, because we will be discussing about some of the dental issues which might be brought to your attention as a treating physician of the newborn children. So moving ahead with it, oral health, you cannot separate it from general or mental health. In the last presentation, we have seen the importance of mental health also. So oral health is an integral part of the general health. At one point of time where oral health, it depends on various different aspects, right from the personal environment, economic priorities, diet, and general health, mental health. At the same time, oral health, it affects many different body parts and organs. Like periodontitis, it has been directly associated with diabetes, arthritis, heart diseases. So it is a two-way combination, oral health and general health. So when we neglect the child's teeth, or when the child's oral health is neglected, there are n number of things that can happen. As you can see, the list: caries, gum diseases, pain, infection, all those things are there. But the most important oral disease which a child or children in general encounters are caries. And as we all know, how does caries occur? It's a very simple formula, that there is plaque which contains bacteria, and if there is long lasting sugar content in the oral cavity, then those bacteria, it acts with the sugar and they form acid, which decays the tooth, and the children get caries, or anybody get caries. So how do we take care of the children's teeth? This I am showing to you because many of the times, or it happens that because the parents ask you how to brush the teeth, how to take care of oral cavity, how to we use the toothpaste and brush. So that is why it's a brief introduction about pediatric dentistry to our esteemed delegates. So first thing is brushing. 2 for 2 is what you do. That means we ask the parents that they should brush for 2 minutes twice daily for their children. If the teeth are not yet erupted, still they can use, as there is shown in the first diagram, they can use a cotton cloth or gauze piece. They can wrap it around the finger and they can clean the oral cavity. The gums can be cleaned, or there are some finger brushes available. Manual toothbrushes are available, specially designed for the children, and power toothbrushes that they can also be used. For toothpaste, we don't recommend toothpaste until the patient or until the child is able to spit it out. If the children is not able to spit it out, we can just use plain water and clean the teeth. But out of these things, we have to use some of the vehicle to clean it. Then second point in taking care of child's teeth is fluoride. As we know that fluoride is a very important component, and we are lucky enough that whatever tap water we are getting, it contains almost 1 ppm fluoride, which is sufficient enough for our oral cavity or general oral health. Still, if there is need, we can prescribe some toothpaste to children which contains around 500 ppm of fluoride. But again, the condition is that the patient should be able to spit. He should not swallow it, and we recommend just a pea-size toothpaste for the children to use. And even if the children are not getting enough fluoride by these also, then as third picture shows, we have some professional fluoride applications also that can be done for the children. This we all know that about good dental snacking. This is what you as a pediatrician always recommend to the children, that you should eat more fruits and vegetables, more grains and milk products should be there. And cheese, it is one of the very important and major factor in controlling oral diseases. It has been proven through the trials that cheese reduces the incident of caries in oral cavity. But children are children, वो तो हमारे बोलने पे नहीं खाएंगे. What they eat is chips or other sticky foods, candies and chocolates and sugary drinks. So what we generally recommend that अब बच्चे नहीं खाएंगे चॉकलेट तो फिर कौन खाएगा? So they might be allowed to have chocolates or other sticky foods in a reasonable quantity, provided that we take care that they rinse the oral cavity at least, if not brush, after having those sticky foods. Regarding the soft drinks or some sugary liquids, they are better to be avoided because we generally don't tend to tend to drink water after those things, and that creates a layer of plaque in the oral cavity. So good dental snacking is very important while taking care of the children. And the last thing is preventing injury. When the child is small, we can use these corner guards, or we can use mouth guards when the child is moving ahead or starts walking. And if he is playing any sports, we can mouth guards can be used. We should always recommend that children should not put anything in the oral cavity, and they should not run, otherwise they are more prone to injury. So these are about the how we should take care of the children's teeth. So coming to our next part, that is different ages, different stages. We know the eruption chart. The first teeth erupts in the oral cavity as soon as 6 months of the age, whereas this is the chart for the deciduous teeth, whereas the first permanent tooth, it erupts in the oral cavity as soon as 6 years of age. So from birth to 6 months, during pregnancy, if the mother is suffering from periodontitis, they can suffer from preterm low birth weight babies, and smoking or alcohol during the pregnancy may lead to cleft lip and cleft palate. So during pregnancy also, we get many references from gynecologists for scaling for the oral cavity. There are natal teeth which are present by birth, congenital teeth or neonatal teeth might be there in the children, which erupts within 30 days after the birth. If these teeth are present and the child is not able to suck properly, then these teeth has to be extracted. Then from 6 to 24 months of the age, this is the very crucial time because teething is there. So while the teeth is coming into the oral cavity, children may experience drooling, irritability, sore or swollen gums, loss of appetite, rashes, showing a need of chew on things. But high fever, diarrhea, and vomiting, these are not the symptoms of teething. It might happen that because children are having that need of chewing on something, they put anything that they get into the oral cavity, their soiled hands or the infected things, and because of these things, it may lead to fever and other infectious diseases. But teething itself as such doesn't lead to all these things. Now, how do we help children teething? We can give them teether which contains plain water. It should be cooled and given to the children, or we can use plain cotton napkins which should be damp and cooled and given to the children to chew on it. But we should avoid using teething gel or some gels which helps in teething, because ultimately it is medicine which will go inside patients' stomach, which is not useful anyway. And we should not give them anything to eat directly to chew on, like the biscuits or some cucumber or something like that, because it might choke themselves. And if they're eating biscuits, so it ultimately increases the sugar content. So these things should be avoided. Teether or plain cloth can be given to help them in teething. The first dental visit should be planned when the first tooth erupts in the oral cavity, that is at around 6 years of age. That is what we recommend. And as the pediatrician, you are also requested that you recommend the parents that when the first teeth erupts in the oral cavity, they should plan their first dental visit. Then there is something called as early childhood caries, which encompasses nursing bottle caries and rampant caries. This is a very severe issue, but it is treatable. Many a times you get patients who are suffering from these kind of caries. Most of the time, the reason is nursing bottles, or the children, they are not able to maintain proper oral hygiene. So we have already talked about oral hygiene habits for children. Regarding the bottles, once the child is able to sit, we can shift from bottle to cup or a mug, and we can give them a feed by the spoon. So bottles should be weaned around at the age of 12 to 14 months. At the same time, there is one more thing to remember, that nursing bottles should never be given to children as a pacifiers, because more the passive they have the contact with the oral cavity, more sugar content and plaque deposition is there. So it is better to avoid nursing bottles or shift to cup and mug as early as possible. Then from 2 years to 5 years of age, the home care should continue brushing twice daily, especially before the bedtime, using fluoridated toothpaste. Again, if the child is able to spit. If the child is not able to spit, there is absolutely no need to use toothpaste at all. And if the toothpaste is being used, a pea-sized toothpaste should be used. And regular dental visits are very important, because these nursing bottle caries or these rampant caries, what we have seen just in the previous slide, they grow very fast. It is a progressive disease and a cumulative disease. Once the caries happens, then इतना जल्दी grow होता है कि we don't get enough time. वो 2-3 हफ्ते के बाद में it spreads in the other teeth also. So every 6 months, or as recommended by the dentist, children should visit the dentist. There is one habit, thumb sucking or tongue thrusting habit. This also might be reported to you as a pediatrician many times by the parents, that ये बच्चा अंगूठा चूसता है, या मुंह में पेंसिल डालता है, या वो tongue thrusting करता है. So this usually stops at the age of 4 to 5 years. But if it doesn't stop, then we can be of help. We have some habit breaking appliances which are given to the children. They are either removable or fixed appliances according to the need of the children, to break these habits of tongue thrusting and thumb sucking. So this can be of use during this age group. Then from 6 years to 12 years of the age, this is the age where the children might have wiggly tooth, दांत हिलने लगते हैं, and they experience their first, shedding of the tooth. So even if the teeth are wiggly, the oral hygiene should continue as usual. Twice brushing should not be hampered, क्योंकि दांत हिल रहे हैं तो बच्चा ब्रश नहीं कर रहा है. This should not happen. And this is the age group, but जब बच्चे बहुत सारी चीजें खाना शुरू कर देते हैं and they get carious tooth. So if the tooth is carious, like we do root canal treatments or fillings in the adults, there are pulpectomy and pulpotomy treatments for children also, and they also can their teeth can also be capped, because these deciduous teeth are important for them to maintain the space for the permanent teeth as well as for chewing ability. If at all we cannot save these teeth by root canals or other therapy, if we have to extract them, we have something like this, that is space maintenance, so that it maintains the space for the permanent tooth to erupt. At this age, there is one more very important factor to note, that 6-year molar, that is the first permanent molar. The first permanent molar, and they are number 4 in number, they erupt at the age of around 6 years. The important and interesting fact is that the first permanent molar will erupt distally to the last deciduous molar. It will not replace any deciduous tooth. So usually the parents tend to think that ये तो अभी दूध का दांत है, ये अभी गिरने वाला है. So it is our duty, our job to explain them कि now the permanent teeth are starting to erupt in the oral cavity, and it is the time when you pay more attention towards the child's oral hygiene. Then there might be complaints that ugly duckling stage, इसके दांत बहुत आड़े टेढ़े आ रहे हैं, सीधे नहीं आ रहे हैं, and there is a period of mixed dentition when there is either crowding or overlapping of the tooth. So what as a dentist we suggest to our patient is that they should just keep calm until all the permanent teeth are erupted. Most of the time, these ugly duckling stages or overwritten deciduous tooth, they will correct themselves, or as the child's jaw grows, the crowding will also correct itself. And if it doesn't correct, then we are there to help. And lastly, 12-year onwards, if malalignment and crowding is there, then those children what you screen at a initial stage can be referred for orthodontic treatment, and we are having a range of orthodontic treatments right from the metal braces to the clear aligners which even cannot be seen that the patient is having a dental treatment. So I guess this is a brief timeline of the pediatric patients who might have different type of diseases, and there are different type of remedies over here. Lastly, I would request you that if a child tells you that their teeth hurt, please remember that we are there to help the children. I thank Indian Academy of Pediatrics and all of you for the patience listening. Thank you very much. Over to you, Sagar sir. Sir, you are muted, sir.
Okay. Thank you, Dr. Samir, for your nice elaboration, and you have highlighted the importance of oral and dental health, which is actually an integral part of general health or overall health. The dental health is directly related to general health, as from your slides and from your evidences. Other thing which you mentioned is brushing and fluoride and the snacks, the healthy tea snacks. So those things were very important, and they were the important in preventing the dental caries or any future dental problems that we got to know. Other thing which you highlighted is antenatal care. The dental hygiene of the mother is as much as important as a child's dental, because you have said that the dental caries in mother also predisposes to many other problems in the fetus. And the most important thing is you have highlighted about care while teething. At each and every step of teething, what care should be taken by parents, by doctor, and by dentist also, and by pediatricians also. And timely referral will definitely help these children to have their better teeth health as well as their general health. Thank you, doctor. Thank you, Dr. Samir. Next, I would like to call Dr. Pallavi. She will be talking on skin care in summer. So everybody now, we know that in summer we have many problems of skin with children as there is humid and dry weather, and heat or sunstroke also can lead to many skin problems. So Dr. Pallavi Murke is undergraduate from JJ Hospital, Mumbai, and she is a gold medalist at every step of her study, that is 12th MBBS as well as in post-graduation. She is a consultant dermatologist and cosmetologist and practicing in Amravati. She has been practicing advanced cosmetology and laser in Amravati. She has been writing regularly about public awareness in newspapers, and she has been, I think, awarded a state level award, Dr. Suresh Nadkarni Mitra Mandal Award, which is a state level award. And this award she has got for her social awareness. Thank you, madam. And I welcome you for your talk on skin care in summer. Hello, madam.
Yeah, hello.
Yeah.
A very pleasant good afternoon to everyone. Hello, everyone. Firstly, I extend my sincere gratitude towards IIP Amravati for giving me an opportunity to share my views on this very important topic in these hot summer days. Due to global warming, every coming summer is harsher than the previous year. And more importantly, this year summer is also important as since last 2 years, maximum people were indoors during summertime in view of corona and lockdown. This year, fortunately, we are spared from the corona, but because we are exposed to the summer again for longer time, let's talk about the summer skincare which has to be taken. We will start from head to toe. Hairs. Hairs get oily and sweaty in summer. They need frequent washing to prevent sweat and dust accumulation. Dandruff or itchy scalp is common in summertime. Use of anti-dandruff shampoo regularly will help prevent further fungal infections of scalp and hair. Keeping hairs tight during exercise and summertime keeps them away from further damage. In pediatric population, in summer season we see tinea, fungal infection, carrion, or nits, lice in their hair, which can further cause them irritation. Also, in pediatric population, we see boils, furunculosis, folliculitis in the scalp. So that also can be prevented with the help of regular hair washing, frequent hair washing, and use of anti-dandruff shampoo. Face. The most common affected area in summer is face. Aggravation of acne is seen in summers due to sweating and increased in oiliness of the skin. Frequent washing of face and using oil-free products for daily maintenance help in preventing it. Harsh rubbing of the sweat which has come on the face has to be prevented. Use of soft tissue, soft cotton handkerchiefs is good so that it can prevent your facial skin from getting damaged. Sun tanning is very common in Indian skin. Indian skin has a propensity to tan more rather than burn. Unlike Western skin, where sunburns are common in Indian skin, we encounter darkening and tanning of the skin. But if sun exposure is very prolonged, then sunburns are also seen in the form of red, itchy rash and sometimes blisters as well. Skin pigmentation is another major cosmetic concern. Though I am telling it as a cosmetic concern, but it is a matter of mental and physical well-being as well. Melasma and other skin pigmentation conditions like freckles, lentigens, uneven skin tone aggravate in summer due to unprotected sun exposure, causing lot of concern and stress to the affected individuals. They are desperate to get rid of it, and it's a sort of social embarrassment for them. But this can be prevented and the person can get a good mental quality of life with the help of use of sunscreens and further summer skincare tips. Now let's see how summer and sweating creates other skin issues. Malaria or ghamorrhea or prickly heat, very commonly seen due to inflammation of the sweat glands, seen as red itchy bumps on skin, especially on face, back, neck. Malaria is also seen in newborn and infants and also in adults. It's quite distressing in terms of itching and discomfort. Treatment of malaria is to lower the inflammation of sweat glands by use of cooling agents like calamine lotion, antihistamines, and in rare cases topical other treatments. Another issue which is sun allergies are also very common in summer season, like polymorphic light eruption, which can present as tiny itchy papules to large patches. It is because of the sensitization of the skin to the sunlight and can be treated adequately with the help of antihistamines and other treatment modalities. The best important thing is to prevent sun exposure by using physical protection. Next. Another issue which is aggravating in the summer is tinea corporis or fungal infection. Fungal infections of the skin is a burning issue nowadays. It's very common in groin area, in underarms or in sweaty areas and is extremely itchy. India is suffering from epidemic of fungal infection. It has become a burning question. Due to inadequate treatment and use of steroid mixed creams, fungal infection has worsened and has become difficult to treat. Initially, in dermatology, fungal infection was supposed to be one of the easiest disease to be treated. But Nowadays, because of rampant use of inadequate antifungal medicines here and use of steroid mixed creams, which are easily available over the counter, the thing has become worsened and it is really getting difficult to treat. Now it has become a dermatologist nightmare. So prevention is to wear loose cotton clothes, avoid synthetic clothes, take regular bath twice a day, and use dusting powders to soak up excessive sweat. On this August platform, I urge you all to avoid the use of steroid mixed creams for fungal infection in your day-to-day patients. Steroid mixed creams have created an havoc in treatment of simple diseases like tinea and has aggravated it to a very bad level. So I take this opportunity to tell you all that please do not use steroid mixed creams for your simple tinea patients. You can use plain antifungals and treat accordingly. Next is sunburns. Sunburns due to sun exposure are also very common. They are itchy, they give red rashes and sometimes can cause blisters as well. Now we will see the skincare tips during this summer. Wear lightweight sunscreens play a very important role in preventing sun tanning and protecting skin from sun allergies. Ideal sunscreen during summer should be lightweight, gel-based, 30 to 50 SPF sunscreen, water resistant preferably. It has to be applied every 4 hours for adequate protection. Use of talcum powder or makeup can be done over it for better cosmetic appearance as per the situation. Sunscreens are equally important even in indoors to help prevent photo skin aging and dull saggy skin. They help protect the skin from infrared rays from household appliances. The key to get optimum result from sunscreen is to use it continuously and regularly, irrespective of month, season, or time. Apply broad spectrum sunscreen with 30 plus SPF every 3 to 4 hours. Wear protective clothing such as long sleeve dresses, shirts, trousers. Use of umbrella hats is advisable to physically protect your face, hair, neck. And wearing sunglasses to prevent damage to sensitive skin around the eyes is very important. Always seek shade whenever possible. The sun rays are stronger between 10 to 4. So stay indoors during this period if possible. And if at all you have to venture out, take adequate physical protection with the help of clothing umbrella. Another important aspect of summer skincare is hydration. Dehydration in summer, apart from causing all other medical and pediatric problems regarding skin, we will talk. It causes dull, dry skin. Luster of the skin is lost, and hairs become dull, dry. They become frizzy. So, not to forget how important is the role of hydration in summer. One has to drink at least 4 liters of water daily, plenty of juices, fruits, vegetables. Many skin conditions like acne, sunburns, bacterial infection, boils, bumps aggravate in summertime. So this can be prevented by maintaining proper hygiene and sanitation and taking proper care. Also, the diet during summer should be light and simple, less oily, so that the body doesn't have to go towards digesting the food and rather than taking care of itself in the sun and keeping the temperature of the body low. So let's face the bright, glorious summer ahead, all geared up with proper skincare tips and enjoy it to the fullest. Have fun in the sun. Stay hydrated and glowing this summer. Thank you. I am really thankful to Dr. Satish Agrawal sir and team IIP President and Secretary for this opportunity given to me on this platform. Thank you. Happy summer ahead.
Thank you, Dr. Pallavi. In a short speak, you have actually highlighted various skin problems in summer and given us important tips for preventing those problems which arise out of the summer season. And one point which actually you have highlighted is to avoid the use of steroids or mixed tubes in case of simple tinea infections. We'll remember that. some tendency of many general practitioners is to use a cream mixed with steroids along with antifungal or maybe along with antibiotics. But your tip is very important, and all will follow it. And importance of hydration also you have highlighted. That is, even children usually don't aware of how much to drink and when to drink. They are busy in schools and playing. So we have to be very careful about their hydration, and for us also. So thank you, madam. Next, I will invite Dr. Minal Amin. He will be speaking on the topic plastic pollution, how far we are responsible. So he has been very active in Central IIP. He was executive board member of IIP Gujarat in 2019, and he has been faculty at various state, zonal, and national level pediatric conferences. His topics of interest are asthma, nutrition, vaccines, perinatology, and impact of environment on child health. So he'll be speaking on his topic of interest. So I request Dr. Minal, please, to continue with his lecture on plastic pollution. Dr. Minal, over to you.
Yeah, please give me a sec, please, to share the slides.
Yeah.
Yes. Can you see my slides?
Yeah, they are visible.
Okay.
Okay.
Yes. So first of all, warm regards from Ahmedabad. Actually, I'm very thankful to the organizing convener, Dr. Satish Agrawal, and president of Amravati branch and the secretary of Amravati branch. And thanks for the kind introduction, Dr. Sagar Sonwade. So I would like to start my presentation on the impact of plastic pollution in the human health. So we have already talked about health as a part of the physical, mental, and social perspective, as well as the emotional perspective so far by a very nice lecture previously. And today we'll be discussing effect of environment on our health. So plastic pollution is basically accumulation of the subjects and particles like plastic bottles, bags, and microbeads into the Earth's environment that adversely affect the humans and wildlife and their habitat. Plastic that acts as a pollutants are categorized basically into size like micro, meso, or micro debris. They are inexpensive and durable, and they are resistant to many processes of the degradation. As a result, they are slow to degrade. And together, these two factors allow large volume of plastic to enter the environment as a mismanaged waste and for it to persist in the ecosystem. So if you see how the actually plastic enters the environment, global primary plastic production is around 270 million tons per year. And out of that, more than that actually is prevailing into the environment because previous year's production is added into that. And if you see the coastal plastic waste production, it is around 99.5 million tons per year. And out of this, approximately 1/3 part is mismanaged coastal plastic because more than 2 billion people are living within the 50-kilometer of coastline. So plastic inputs to the ocean becomes around 8 million tons per year. So if we see the causes of plastic waste into the environment, then we can see that there is 90% is a post-consumer. This study was done in 2018 and more than 343 million tons of plastic waste was generated. 90% was post-consumer like industrial, agriculture, commercial, and municipal plastic waste. And 10% was pre-consumer from production itself and manufacturing of resin production. Large proportion of this consists of plastic packaging like plastic bottles, sports tubs, trays, plastic films, bags, wraps, plastic wraps, etc. And we have different sectors which actually generates the plastic waste like agriculture, construction sector, transport sector, and e-waste, and of course our pharmaceutical and healthcare waste. So if we see the types of the plastic debris that enters our environment, it is basically micro, macro, and mega plastics. Micro is 2 to 5 millimeter in size. But any plastic which is into the environment, whether it is a macro or meso, it can actually become later on breaks into the small particles, which is also referred as the nurdles. And these nurdles and scrubbers, they get actually into the environment and then ending up into the ocean waters, the rivers and streams. And Ocean Conservancy reported that China, Indonesia, Philippines, Thailand, and Vietnam, these are the countries that dump more plastic in the sea than all the other countries are combined. So this microplastics can accumulate in the ocean and allow for the accumulation of persistent bioaccumulating toxins such as BPA, that is your bisphenol A, polystyrene, DDT, and PCB. So this can adversely affect the health. Macro debris like plastic bags are example of macro debris. Usually the size is more than 20 millimeter size. They are found in the ocean waters and can have serious impact on the native organisms. Fishing nets are prime example. And even after they have been abandoned, they continue to trap marine organisms for a long, long time. And it has been said that globally, more than 100,000 marine animals die because of result of the plastic pollution. So if you see the decomposition rate, now your fishing line takes around 600 years to decompose. Plastic bottles and even the disposable diapers, they take around 450 years of to get decomposed, and your plastic cans take around 400 years. So they take very, very long time to get decomposed, and meanwhile they pollute the marines, pollute the land, and pollute the environment, and ultimately affects our health. There are also persistent organic pollutants, and this has led to the transport of persistent organic pollutant, also known as the POPs, and this has been linked to the increased distribution of the algae associated with the red tides we see. Then there are commercial pollutants. So there was a study in 2019, a group Break Free from the Plastic organized over 70,000 volunteers in 51 countries to collect and identify the plastic waste. And they collected a huge number of plastic bags, 59,000, 53,000 sachets, and 29,000 plastic bottles. And half of them were actually identified by the consumer brands. And the most common brands were Coca-Cola, Nestle, and Pepsi. So these are the things which you regularly day in and out consuming. So according to the global campaign coordinator for the project Emma Priest plan in 2020, the only way to solve the problem is stopping production of the single-use plastic and using reusable plastic products instead. China is biggest consumer of single-use plastic. If you see, United States is the world leader in generating the plastic waste, producing annual 42 million metric tons of plastic waste, more than all of the countries of European Union combined. But if you see mismanaged share of the plastic waste, then Southeast Asian country and your African country leads. And even if you see the per capita mismanaged plastic waste, and again your Southeast Asian country and the African countries leads. So this is what we are contributing. And this was 12 mismanaged plastic waste polluters led by China, Indonesia, Philippines, Vietnam, and Sri Lanka, and we were last among the list. And there was also a study produced by the Environmental Science and Technology. This calculated that 10 rivers, 2 in Africa, that is Nile and Niger, and 8 in Asia, our own Ganges, Indus, Yellow, Yangtze, Pearl, Mekong, and Amur. This transport more than 90% of the global plastic load into the sea. So we have the effect of this plastic pollution in the environment. Particularly if you see the marine life, then the wind and ocean currents, coastline geography, urban areas, and trade routes, this affects the effect of this plastic pollution into the environment. And basically, it serves as a means of distribution of organisms to remote coasts that are not their native environments. Plastic can also be used for vectors for chemical contaminants such as persistent organic pollutants and heavy metals. It has negatively affected our environment in such a manner that plastic debris can be found even in the most remote coastal areas and in every marine habitat. In January 2022, or recently, scientists defined a planetary boundary for novel entities, particularly the plastic pollution, and they found that it has already been exceeded. There has been 50-fold increase in the production of chemicals since 1950, and it gets expected to triple by 2050. So out of this, like 50,000 artificial chemicals, 10,000 chemicals are there in the plastic, and it creates large problems. If we talk about the marine environment, it causes entanglement of the species, toxicological effects via ingestion, suffocation, starvation, dispersal, and rafting of the organisms, provision of the new habitats, and introduction of the invasive species. So degradation and modification of marine systems are associated with loss of ecosystem services, and this affects the socio-economic aspects through negative impacts on your tourism, fishery, shipping, and human health. If we see plastic pollution as a cause of the environmental change, in 2019, a new report, Plastic and Climate, was published. And according to the report, in 2019, incineration and production of the plastic will contribute greenhouse gases in the equivalent of 850 million tons of carbon dioxide to the atmosphere. If this trend continues, this will grow up to 1.34 billion tons by 2030, 56 billion tons by 2050, and 260 billion tons by 2100, which will be more than half of the carbon budget. And this is only from the production, transportation, and incineration, but there are also releases of the methane gas and effect on the phytoplankton. So the effect on the global warming and the greenhouse gas emission is immense. Now, if we see the effect of the plastic on the land, basically plastic pollution on the land poses threats to the plants and animals and humans who are based on the land. Plastic concentration on the land is much higher, 4 to 23 times that of the ocean, and it is more concentrated and greater than in the water. Mismanaged plastic waste ranges from 60% in East Asia and Pacific to 1% in North America. And out of this, 30 to 50% gets into the oceans and becomes a marine debris. So if you see the effect of the flooding by plastic pollution, because of the clogging clogging the storm drains and all that, it can increase the flood damage, particularly into the urban areas. So this was a very interesting study done on the tap water. In 2017, a study found that 83% of the tap water samples taken around the world contained plastic pollutants, and this was the first study to focus on global drinking water pollution. United States with a rate of 94%, followed by Lebanon and India were the highest, and European countries like UK, Germany, and France had the lowest, but still it was as high as 72%. And that means people may be ingesting between 3,000 to 4,000 microparticles of the plastic from tap water per year. Usually the size is more than 2.5 micron in size. So currently it's not clear whether this can affect the human health. But if water is also found to be contained in nanoparticles, this could have adverse impact on the human well-being. Now, if we talk about plastic pollution on the terrestrial ecosystems, basically it ends up into soil, then it enters the subsoil, and then this can find their way to the plants and animals. Effluents and sludge, now the wastewater treatment plant do not have any process to remove this microplastic from the effluents, and then if it is applied to the land for agricultural purposes, it can affect the soil fertility. It can affect the soil biophysical properties, which affect the quality of the soil, and ultimately it affects the plant health. So microplastics in the soil alter the plant's growth, decreases the seeding germination, affects the number of the leaves, stem diameter, and chlorophyll content in this plant. So this also is a risk to the food safety and the human health. Now, if you see the impact of the individual component or the chemicals which are present in the plastic, so this is one ubiquitous content which is called as phthalate. This is a plasticizer used to increase the flexibility, transparency, and durability of plastic. It is detrimental to human health. It is mainly used to soften the PVC, but also if you see your deos and your sprays, you will find the phthalate in that. So if you see the effect of the phthalate, there is a consistent association between the ADHD in children, and the decrease in the sperm quality in an adult male. And also there is an inconsistent association between the phthalate and the intelligent performance in children, diabetes, thyroid disease, kidney disease. In female, precocious puberty and endometriosis, and male, decrease in the anogenetic distance, and again, obesity, respiratory disease, and cardiovascular disease. So it can have a huge impact on the human health. One more ubiquitous chemical which is present in the plastic, which is used by people every day, it is BPA, that is bisphenol A. Now, it is present in some water bottles, baby bottles, dental fillings, your safety equipment, CDs, household electronic items, and sports equipment. And it also occurs inside the epoxy resin, which coats your cans and food and drink cans. Also, your thermal prints like boarding passes and petrol bills and receipts, which are printed by thermal printer, they have a huge amount of bisphenol A. So it can enter the body by skin contact, inhalation, or ingestion, gas metabolized in liver and excreted by the kidney. So it has got negative impacts on the reproductive disorders. It can affect the egg maturation in the human. 2015 study also found that it can interfere with the endocrine function involving the hypothalamus and the pituitary gland. Researchers also suggest that this type of action can affect the puberty and ovulation and may lead to infertility. And also this kind of effects can be lifelong, and also it can be a transgenerational. So that is very important to note that it can be lifelong and transgenerational. Also, it was found that if there is a high level exposure, it may increase the risk of erectile dysfunction and problem with the sexual desire and ejaculation. Also, BPA exposure has been linked with the coronary artery disease, angina, heart attack, hypertension, and peripheral vascular disease. Again, it is associated with type 2 diabetes by impacting the insulin resistance. It has been responsible for the weight gain, as also called as obesogen, and also responsible for the metabolic syndrome. It has been said that if your developing brain is exposed to BPA, then it can lead to the impact the fetal brain development also. Now, BPA has got estrogen-like behavior, so it could increase the risk of the breast cancer, prostate cancer, and other cancers in people who have experienced exposure to the chemical in the womb. And also, it was studied that exposure to the BPA before birth could have a long-term effect on the carcinogenesis in certain organ. This in turn could lead to the development of hormone-related cancers. In 2009, scientists reported that it could also interfere with the effectiveness of chemotherapy in the breast cancer. Again, BPA exposure in the womb is associated with later on wheezing or asthma, increased chances of facing this kind of disorders. Now, one more molecule which is also ubiquitously present is your PBD, that is a polybrominated diphenyl ether, and it is present into the. It is used as a flame retardant. So it is used in the building material, electronics, furnishings, motor vehicles, airplanes, etc. And this has been one of the most common environmental pollutants in water, soil, air, dust, and animal and human tissue. Primary route of exposure diet like fish, meat, and dairy products, and indoor environment, there is dust. Now, infants and toddlers have the highest body burden because of the exposure to maternal milk and to the house dust. Three types are identified mainly: tetra, penta, and hexabidies, and they actually have a negative impact on the thyroid homeostasis function, neurodevelopmental deficits, and reproductive changes, and even sometimes cancer. So we have to reduce the use of the plastic, promote the plastic recycling, and reduce the mismanaged plastic waste. So reduction is in the consumption of the virgin plastic material, along with the internationally coordinated strategy for waste management, such as banning export of the plastic waste unless it leads to the better recycling. Now, if you go to supermarkets, they will charge the customer for the plastic bag, and otherwise they would give you more reusable bags or bags made of biodegradable materials. Many communities and businesses have put ban on some commonly used plastic items such as boiled bottled water in the plastic bag. NGOs have been giving certificates as eco-friendly if you are not using the plastics. And again, there was a global alliance to end plastic waste. This was created by companies in the plastic industry. Now, this aims to recycle the plastic and clean the environment by existing waste and increase the recycling. But it does not actually mention reduction in the plastic production as one of its targets. Very recently, on 2nd March in Nairobi, representative of 175 countries met, and they had a intergovernmental negotiating committee created, and they addressed the full life cycle of plastic and proposed alternative, including the reusability. So this decision was actually called as a triumph by the planet Earth over single-use plastics. You can also use biodegradable plastics But this is again a new type of plastic, so better not to use rather than to introduce now some new kind of plastics. There are some organisms which are breaking down the plastics, but their contribution is so minimalistic that it cannot be having a meaningful amount of breaking down. Incineration. Now we are in our medical fraternity, we have been used to incinerate our biomedical disposal waste, and up to 60% is incinerated rather than deposited in the landfill as a precautionary measure to lessen the transmission of disease. And this has allowed for large decrease in the annual plastic waste that stems from the medical equipment and the medical services. Also, there are waste to energy plants with where this kind of things can provide a useful fuel. And approximately 12% of the total produced plastic in the world has been incinerated on a year-on-year basis. But we have to see the gases emissions from these incineration processes. So if they are not done in the designated process houses, then it can release the dioxin, furans, mercury, and polychlorinated biphenyls into the air. So you just cannot burn your plastics outside your home or your farm. You have to send it to the designated process facilities. Now there are certain policies which world over the governments are making, like Canada, US, and European Union. BP has been banned into corporated into production of the baby bottles and the children's cups. There have been taxes like landfill taxes. So it is rather better to use recyclable plastic rather than to fill them in the land. Then again, they have standards for the compostability. Clean Ocean Initiative was established in 2018, and here they agreed to invest a huge sum of 2 billion euro. And mainly the initiative was reducing pollution discharge into the ocean, particular focus on the plastics. Now, let us see what actually India is doing. So Himachal Pradesh has been doing it since very long time. They say no to polythene, sign NACO. Government of India decided in 2nd October 2019 to ban the single-use plastic and take a number of measures to recycle and reuse plastic. Ministry of Drinking Water Sanitation, Government of India has requested various departments to not to use plastic bottles and use other alternative arrangements. State of Sikkim has restricted the use of plastic water bottles. Bihar has also banned the use of plastic water bottles in government meetings. 2015 National Games of India was organized in Thiruvananthapuram, and they didn't use plastic bottles, and they provided the flask and reusable tableware and stainless steel tumblers. And by these practices, they stopped the generation of 120 tons of disposable plastics. City of Bangalore also in 2016 banned the plastic for all purposes. And of course, the state of Maharashtra has provided an example because they affected the Maharashtra plastic and thermocol products since 23rd June 2018, and subjecting the plastic users to fines. And if they are repeat offenders, it can even have a potential imprisonment. And just recently, before a week, they have reinforced the policy. So these are the different measures our states are taking to reduce the plastic pollution into the environment. There are different days for creating awareness, like Earth Day on 22nd April since 1970, and World Environment Day, 5th June. So these are to create the awareness for the pollution, particularly the plastic pollution, how it does affect the environment. Now, when we are talking of pediatrics, we have to know that how exactly our kids are being exposed to the plastic. So there are obvious ones, but some might surprise you. Like we have drinking bottles, like reusable and single-use bottles. Canned foods, they are lined with the plastic for BPA. Soft drink cans, baby formula tins, food packaging, food storage containers, lunch boxes, your bottle, dummies, and teething rings. Say, just in a previous lecture, somebody was mentioning the teethers. Now we have to see what kind of material the teethers are made of. Otherwise, it is not advisable to use even the teethers. Then toys, whatever blocks and dolls and small cars or even bike toys are used, we have to see the type of the plastic and we have to limit the plastic. Dental materials also have sealants and these things which may contain plastic. So we have to see the quality and acceptability of these plastic materials. And cash register receipts that contains BPA that lingers into your system. So you have to train your kids how to deal with the receipts and if possible to avoid these receipts. So no matter what is their age, your child is probably being exposed to plastics on a regular basis. Now, what are the small things which we can do day in and out? Say, make sure you are not heating your food or drinks into the plastic. So whenever you put your hot food straight into the plastic, this toxic chemical can leach into your food. And either it is better to transfer the food from ceramic glass container first. You also want to let food cool before putting it in the plastic. Same goes for water. Say your plastic bottle you left in your car, it is so hot And now after some time, if you drink it, it is enough to leach plastic in your drinks. So rather switch to stainless steel bottle, the glass water bottles. Reduce your use of canned foods. So tin foods are known as to contain the BPA. So try to reduce the intake of tin foods, more with the acidic food like tin tomatoes. Reduce packaged food and increase the fresh food. So if you have a supermarket, you are more likely to use plastics. If you are going to a local farmers market, you are less likely to use the plastics. So it is better to take fresh foods from the farmers market rather than taking it from the supermarket. Avoid receipts wherever possible. So whenever you can, skip printing out or accepting a receipt. It is better option for environment and for health reasons. When you have little ones in the trolley, don't handle them the receipts you play with. If you have older kids who works in supermarket or store, you might want to talk to them about the protein problem with the handling receipts, particularly with the thermal printers, which contains BPA. This is very important. You know your numbers. So at the end of the day, you have to use plastic somewhere, at least even if you do a minimalistic approach. So you have to pick your plastics. So on every plastic bottle item, you will at the bottom of the item, you will find a triangle with a number in it. Now these numbers, which include the endocrine disturbing properties, are 1, 3, 6, and 7. And so you should avoid this triangles containing 1, 3, 6, and 7. And number 2, 4, and 5 are less of concern. So while it is best to limit them, but if you need to use them, then I think using the items with number 2, 4, and 5 are less of concern. So they are less detrimental to your health. So ultimately, I would say take-home message is try to limit as much as plastic in your day-to-day use. This way you can contribute to improve the environmental health. Don't use plastic bottles for waters. Don't use plastic polythene bags, single-use plastics into your day in and out use. Take your cotton clothes or anything. Don't use hot waters and hot food into the plastic items. So your food can be polluted with the plastic. And these are the things which in day and out we try to limit the plastic as much as possible. Also, disposing them into the proper channel will be more important. So if you want to get it recycle and reusable, and these are the most important things we can do for our environment. Thank you.
Thank you. Thank you, Dr. Minol. Your lecture was an eye-opener. Those like me who think that the plastic only pollutes the water. But what I came to know from we came to know from your lecture is that plastic pollution is, I think, the biggest challenge in India as the plastic use has been increased. And you have highlighted on various types of plastic to what they contain and they affect from a simple animal health or plant health to global warming. So plastic pollution has a widespread impact on health of everybody on the planet, I will say. And you also highlighted the ways to tackle the plastic pollution. Hope we will be aware of this and will be telling others not to use at least single-use plastic. And with the help of other NGOs, we can actually teach the people to avoid the use of plastics. Thank you, Dr. Minol.
Thank you.
If anybody have any question, either in the chat box or one can add directly to Dr. Minol, sir. Sagar sir, you will continue.
Yeah. Now, next is the dialogue, interaction. We have stalwarts of our IIP, Dr. Satish Agrawal sir and Dr. Alok Gupta. Actually, both of them, they don't need any introduction, but still I know that both are humble person. Dr. Satish Agrawal is a good human, best human being I met. Very nice, always very nice to talk with him, and he is very supportive. He's been active in all the IIPs, I'll say. He will be active in IIP Amravati, Maharashtra State IIP, as well as in Central IIP. He is a social pediatrician, I'll say, and he is really concerned for the children, for the association from his heart. So he has been recently awarded fellowship of IIP at Pedicon, Noida. I think most all of us know it, but still I feel that is the award which is recently given to him. I congratulate sir for this award. He has been president of Amravati IIP, and he's been chairman of many organizing. He's been organizing chairman of many conferences, including Mahapedicon. Dr. Alok Gupta is also a senior and respected pediatrician. He is also a pediatrician as well as environmentalist and a counselor. Sir has been at many posts in Central IIP, including the election commissioner into 2014 and 17. Then he has been member of IIP Finance Committee in 2000. Is still member of IIP Finance Committee till 2023, and sir is also a social pediatrician, active senior member of an IIP. So all of us know both of them very well. So I will request both of them to continue their dialogues on air pollution and impact on child health. Please, sir.
Thank you, Dr. Sagar sir. And basically, I am privileged to have Dr. Alok Gupta sir with me. And as you say, he doesn't need any introduction. Because whenever Dr. Alok Gupta word comes, the sir automatically gets suffix to it. So he's such a respectable person. And as you say, he's very humble, down to earth person. So sir, we welcome on behalf of IP. And a very basic purpose, because all throughout we were having a monologue and the presentation. So it was a suggestion like we should utilize an international faculty like Dr. Alok Gupta sir in a dialogue session, where sir will be answering the questions put forth by the audience when they were asked the questions. And as we have seen Dr. Minol sir said, plastic pollution, it affects not only human health, but the health of the whole planet. And sir, being the environmental activist, we have chosen the subject air pollution and child health. Friends, as the saying goes, Kshitijal Pavak Gagan Samira Pancha Rachit Adhama Sarira. Means our body, one of the constituents of body is air. So it is so important. The environment in which we live, we breathe air, exhale air. So all throughout we are exposed to air, and we think that air should be clean. Unfortunately, the strategists go the other way around. They say the air is so much polluted that over 93% all over the world, children, they breathe polluted air. And it not only affects the human health, it affects the whole of the planet. It affects the unborn child and whole spectrum of life of the humans. So we have Dr. Alok Gupta sir with us. Sir, the first thing, the very first basic question, what is polluted air? Because we are breathing air, so we don't know what actually constitutes polluted air. Sir, unmute yourself, sir. Sir, it's muted. Yes.
See, we were talking about what is a polluted air. See, unpolluted air is basically nitrogen, nearly 75 to 80%, 20% approximately is oxygen, and rest 1% is other harmless gases. Now, what is the pollution, air pollution? The primary air pollutants are from fossil fuel burning, carbon monoxide is produced, sulfur dioxide is produced, volatile organic compounds are thrown into air, nitric oxide, ammonia, nitrogen dioxide, and particulate matter, the PM10, which is bigger particle size, PM 2.5, which are small particle size. These are considered to be the main primary pollutants.
So basically, we assume, sir, it's both in solid as well as the gaseous form. So various gaseous, you said, the toxic gases, they have a deleterious effect on the human health as well as the particulate matter, which one inhales may cause harm to the body.
Right.
Sir, when we read these subjects, the two terms come: indoor air pollution and outdoor air pollution.
Before that, I would these are primary pollutants. They react with the air, water, and soil, and there are another set of pollutants which form. They are known as secondary pollutants. Where sulfur dioxide, nitric acid. There is disturbance in the.
Mute everybody else. Yes, sir.
Hydrogen peroxide is produced, sulfuric acid, ammonia, ozone, and particulate matter disintegrate. The PM10 disintegrate into smaller pieces, convert into PM 2.5. So the primary pollutants are present. They convert also into secondary pollutants, which are even more harmful. And the air basically is the most essential thing we need, gets polluted.
So I'm coming back to the question. Okay, two terminologies. The pollution may go either external or internal. So we label it as either indoor air pollution or the outdoor air pollution.
Yes.
So what's the difference between two and which one is more dangerous?
Both are dangerous. Both are dangerous depending of the concentration they are present in the air we breathe in. And that means in what situation we are in. Suppose we are at a bus stand where so many buses are running, and we are in a house where cooking is being done by burning fossil fuel like cow dung and wood. So they're equally dangerous. Now, if we come to all these, mostly the particles, all this what I talked about, the primary pollutants, they were in the outdoor airs. And the main sources of indoor pollutions is kitchen where cooking is done, one thing. It depends upon the type of fuel we are using. The worst is the cow dung and animal waste. Then comes the wood, the charcoal. Then comes the natural gases, what we are using, CNGs and cooking gas. So these are harmful. Living room, if we come into, then there is, if you've got pets, the hair dust and dander comes into air. Tobacco smoke, if there is a smoker in the house, the tobacco dust directly affects the smoker. Second-hand smoke affects the people around them immediately. And there is another thing called third-hand smoke, where the particulate matter and the chemicals get deposited in the linen and the wall surface, roof surfaces, like small particles of smoke, which were laden with nitrous oxide, sulfuric acids, and all the emissions of the tobacco smoke, which are cancerous. And they keep on coming into the living room air and the household air as and when there is a movement. Like if we shake the curtain, they will fall down and get airborne again. So they are even more harmful, the third-hand smoke. Then air conditioning units are a source of air pollution. In bathroom, molds, mildews, odors, and other microbial pathogens get airborne, and they become a source of pollution in the air. volatile organic compounds from plastics and other chemicals we use, like aerosols, the perfumes, body deodorants, fragrances, paints, what we use on the furniture, walls, they contain organic matter, including lead, which gets airborne, the dust which settles in the household contains a lot of pollutants, including lead, which movement like sweeping or putting on the fan or walking, they become airborne as particulate matters and they get inhaled. Laundry rooms. So all these the particles and volatile gases and substances, chemicals, they get airborne, keep on getting airborne, mixing with the air which we breathe in, and become air pollutant and a risk to us.
So the question was because one of our members, he asked the thing, because indoor there is scope for movement. So person is scope for more time to the pollutants. So the probably the consequences will be more severe rather than outdoor. How far is it true?
Perfectly all right. It's perfectly right. And this basically depends on what the indoor air quality is. In general, in the low middle income population, maximum mostly in India, we are still using cow dung, wood as fuel, kerosene, which are very dangerous, and they keep accumulating, and most harm is done to the lady of the house who's cooking, which is a mother or grandmother or wife or daughter. So they get more exposed. Then the small children who are near the ladies of the house, they get more exposed. So, and because the height of the children is less, and these gases are more towards the bottom of towards the floor rather than the roof, so they are more exposed to the pollutants. And definitely, if the household doesn't have a good ventilation, free flowing air, the people in the house of whatever age, they will be affected by the polluted indoor air more while being inside than outside.
So as you said, it all depends on various factors, the quality of air, the underlying disease, the various risk factors you said. So for the information of audience, India is 20 of the most polluted city out of the world's 31.
Right.
It's a record to be boasted, should be proud of it.
So
Sir,
I would like to list out those countries just for our knowledge.
Yes, sir.
Number 1 comes Bhiwadi. Second is Ghaziabad. On third number is Bhutan in China. Fourth number is Delhi in India. Jaunpur, India. Faisalabad, Pakistan. Noida, India. Bhavalpur, Pakistan. Peshawar, Pakistan. Bagpat, India. Hisar, India. Faridabad, India. Then Greater Noida, India, we were there for a week or so. Rohtak, India. Lahore, India. Lucknow, Jind, Gurgaon. Then there is a city, Kashgar in China. Kanpur, Muzaffarpur, Varanasi. Then Saiwal in Pakistan, Bulandshahr, Meerut, Kadura in India, Patna, Dhaka, Bangladesh. Then on number 13 is Dehradun. So these are 30 countries which I just saw the list. And well, 90% of the cities, most polluted cities, are in India. And in the first 50, most of the pollutant cities are in the 4 countries, India, China, Pakistan, and Bangladesh. So this is a major air pollution hub, we can say, these four countries.
They say that the pollution level is more than 10 times what the WHO of the agencies recommend.
Yes.
So now the next question, coming to the title of our discussion, air pollution, child health. As you said, children, they are more susceptible for the consequences of air pollution.
Yes.
Why?
See, air pollution has been found to be the fourth leading risk factor for early deaths worldwide by WHO. It has contributed to nearly 5 lakh infant deaths globally in 2019 report. It has caused 17 lakh premature deaths in India in 2019. The burden is higher in low and middle income countries and caused 91% of the premature deaths. Economic loss in India due to air pollution was about 1.3 percent of the GDP. Air pollution is known to be an invisible killer because 36% of deaths from lung cancer, 24% deaths from stroke, 27% of deaths from heart disease occur due to air pollution, and they start affecting the fetus. The fetus becomes the nidus, and these effect of air pollution goes on continuing, and they may present at a later stage wherever, in early childhood, late childhood, adolescent, young adults, older children, older people. We have seen that young adults getting heart attacks, heart disease, strokes, lung cancers. So these all these things started in the childhood, and all these things started in household air pollution mainly, and outdoor air pollution in major metro cities like what we have named few of them.
So this
93% of the children under 15 years globally breathe the highly polluted air daily. They are at a greater risk due to behavioral, environmental, physiological factors. They are more susceptible as their lungs, brains, and immune system are still maturing. Respiratory tract is more permeable to the noxious gases and particulate matter. Children breathe more air per kg body weight as compared to adults because their respiratory rate is 2 to 3 times that of the adult. And consequences of inhalation and ingestion, as well as while in utero, lead to illnesses and other lifetime health burdens later in the life. And they are the future of mankind. So their health is of utmost importance. They are more important than our health. We are at the last quarter of our life, but the health of the children is important because the burden to carry on the mankind and the countries lie on them. So their health is very important.
So, sir, we presume that air pollution affects the health of all adults as well as children. But children's health is more important as compared to adults because they have to live a longer life. So their mortality and more so important is morbidity is to be prevented. So the next question is because it is said the system gets affected whichever is exposed to. Like if eyes are exposed to irritants, it gets eyes. Skin is exposed to one gets the skin irritants. And as air is to be inhaled, so it goes to respiratory tract. So most of the times the consequences are the respiratory tract.
So air pollution, it accounts for almost 1 in 10 deaths in children under 5 years. Air pollution is cause of more than 50% of acute lower respiratory infection in children under 5 years in low and middle income countries. India is one of them. it leads to asthma, childhood cancers, chronic diseases, poor lung functions, pneumonia, and acute respiratory infections in children. And every third child in Delhi has impaired lung function due to high level of air pollutants. So these are the more important effects on the respiratory system of children, which are immediate.
So basically, when one inhales the air, it goes to the airways and later to parenchyma. So airway disorders as well as the parenchyma, like you said about the various types of pneumonia, lung cancers, and the airway diseases like asthma and respiratory tract infections are related to air pollution.
Right.
While initially you said that apart from the respiratory, there are other NSAID non-chemical diseases like stroke or heart diseases. They're also related to air pollution.
Yes.
So how does it contribute to them?
In pregnancy, the effect of air pollution, it affects the mother, and all these toxic gases get absorbed and they get into circulation, and through the placenta, it affects the growing fetus also. Because placenta is the lung for the fetus, any pollutant affecting the placenta will affect the circulation of the child. So 20% of neonatal deaths from all causes can be attributed to air pollution. Then air pollution has a direct effect on neurodevelopment. And it has been, recent studies have been showing the direct association of air pollution and developmental delay at 3 years, and later psychological and behavioral problems occur due to high levels of air pollutants in the inhaled air, which may be ambient or outdoor air pollution, or the indoor air pollution or household air pollution. Many causes of symptoms in the, even they cause autism spectrum disorders have been labeled to environment and air pollution. ADHD, attention deficit hyperactivity disorders, anxiety, depression in children, they are attributable to air pollution. It affects the child's learning process. If the air pollution is affecting the child's respiratory system, he will get sick every now and then. He'll be asthmatic, and then he will be fatigued easily. He will not be able to go to the school regularly. His teaching and learning process will get affected, and he will get attention deficit disorders also. So basically, the irregular schooling and irregular learning happens, and the child's neurodevelopment gets affected.
As a situation as of today, so we can think of what will happen after 20 or 50 years when the pollution level will go on. And such that is the beginning, we are more worried about the children's health because they are the future custodians or the responsible citizens of the country. We are all seeing the increase in the symptoms of ADHD, like attention deficit hyperactivity syndrome, or such as learning disabilities. Most of them we don't know what is the reason. And when explored, it may be attributed to the air pollution. So it signifies the importance of this subject. And the studies that show that after malnutrition, air pollution is the second highest risk factor in India, for accounting for 10% of the disease burden.
Right.
So it is such a neglected aspect where we don't pay attention. As the sir said, okay, it is all around, whether external, indoor air pollution, everywhere it is there.
It is an invisible killer.
Yes, sir.
Please continue. I just said it is an invisible killer, like you said.
So it is said that it reduces the life expectancy also.
Yes.
The air pollution. So how do we account for that, sir?
Can you repeat the question, please?
So it is said that air pollution reduces the life expectancy. If I'm not wrong, the figure they say in 2019, it reduced the life expectancy of Indian children by 1.5 years.
Right. So definitely because of the associated illnesses it causes, like respiratory system, if it affects, if it affects the cardiovascular system, it affects the neurological system, it decreases the immunity, and therefore the life expectancy is bound to come down in children who are affected by air pollution, then as compared to those who are less affected or not affected by air pollution. COVID-19 studies also show that the children and adults who were affected by air pollution earlier, there was higher morbidity and mortality in those people, including children. So air pollution was a risk factor to the outcome of COVID-19 infection. It weakens the immune system. That is the main problem. It impairs the lungs, basically, and make them more susceptible to infections and diseases. So we cannot live more than 3 minutes or 5 minutes without taking a breath. It is so important that the air we breathe should be as pure as possible, and only then we will be able to give our best, perform best to our ability of whatever we are doing at what particular age.
So sir, as you said, we should have as clean air as possible. And we are all talking about the air pollution resulting in the decreased health outcomes. So obviously the next question is, what are the causes of air pollution? Because nobody wants air to be polluted, but then how does air get polluted?
Air gets polluted by wherever there is construction and road dust. The particulate matter on the soil is in the air, gets airbound. Emissions from the few vehicles on the road, trains, in the air, in water, the ship, airplanes, all these use fossil fuel, and fossil fuel are very dangerous. We have found that they all are sources of the chemicals and the particulate matter in the air that pollutes. Biomass burning, the burning of residual crop is very harmful. The cow dung, use of cow dung and wood and charcoal as fuel for cooking is very harmful. The industries, the emissions are there. Open waste burning is a cause of air pollution. Public transportation, which is not clean, which is on fossil fuel, is a source of pollution. Then making of bricks and all that, the kilns and where manufacturing of bricks and all that takes place, they are done open, they are in the open, and the air gets polluted. So these are power plants which are coal generated or generated by the fossil fuels. They have a high level of emissions which are released into the air, and ultimately the entire air gets polluted. So these are the major source of air pollutions.
So then the obvious next question is, what should be our duties? We can curb this air pollution. Like there, as Minal sir said, there are so many policies, national, international. So apart from that, at Indian level, what will you advise?
One thing is that see, we at least in middle and higher income group, and even in the important road intersections, the air quality index is displayed. It is in 6 major parts. It is from 0 to 50, 51 to 100, 101 to 150, 151 to 200, 201 to 300, and 300 to 500. So up till 150, 0 to 50 is the best, where no protection is required and nobody is at risk. 51 to 100 people with respiratory diseases like asthma, COPD, bronchitis, they become at risk. They should not venture out. Then if it worsens further from 100 to 150, it may again affect those who are more sensitive to the air pollutants and the emissions and the particulate matter. Above 150, it starts affecting the general population, and people should step out only with the N95 mask, which protects at least against the particulate matter up to 2.5 mm, PM 2.5 we say, and more than 200 is an emergency situation where we should not venture out. More than 300 to 500 is an emergency situation where we do not know what happens, and sometimes it happens in Delhi and an alert is sounded to stay indoors, but we do not have air packed indoors also. And thing is that we have to do something about it. There is a thing called energy ladder, which the WHO and the Environment Protection Agency had proposed earlier. The base of the ladder was crop waste and dung. Then came the wood, then charcoal and coal, kerosene, liquid petroleum gas, and natural gas. And on the top of the ladder was electricity. So they had proposed that we should gradually step up the ladder. But now gradual stepping up point has, I think, gone. Now we have to use, instead of a ladder, we have to go use an escalator and go from the bottom rung to the top, use electricity, and that electricity also should be a clean electricity which has been generated by solar power or green energy, what we call, not by the charcoal or fossil fuel run generators. So the ultimate thing is till then we can use natural gas, petroleum and natural gas, and finally shift to the clean electricity. We have to do away with the fossil fuels, kerosene, charcoal, wood, crop, dung, and this what we call it gobar ka thaple and all that. They are a strict no-no. And then we can invest in energy efficient power generation like windmills, solar power, improve domestic industry and municipal waste management. Segregation should be good so that recycling is done efficiently without polluting the air. The public transport should be run on a green electricity which has no emissions and which is produced without emitting anything like solar energy. We have to plant more trees. More and more trees have to be planted so that the air gets cleaned. And we should try to use less of vehicles, more of walking cycling. We should stop using personal vehicles. We should use carpools where 4 or 5 people together can go in an electric run vehicle or a CNG run vehicle at the moment till better fuel is available. And we can use we should use public transport which are run on clean fuel. These are the things we can do. Tree planting is very important. Electric vehicles now have come in. The cost is also going down, and the government is committed to bring the cost down. We should use cycles to work. If we have got personal vehicles, at least 1 or 2 days we should not use them. Use different modes of transport which are better. Then inside the house we should have electricity which is clean electricity, especially from solar panels. And yes, public transport is the best thing.
Obviously, like we should use this fuel and energy efficiently, both indoor as well as outdoor. So
Yes.
one of the things you said during COVID time, those people were exposed to air pollution because they're weak, they succumb more. But our general experience was during COVID times, many children they didn't come either in OPD or indoors. So the disease rate was quite low and it was attributed to low pollution. But simultaneously, development work was halted. So with this, development is correlated to air pollution, correlated to disease. So how to make a balance between development should go on and the pollution level and the disease burden. To reduce the disease burden, we can't halt the development. What is your advice?
See, my mention about COVID-19 was that during COVID, when the COVID started, the people who were already exposed to air pollution had higher morbidity and mortality. During COVID times, the outdoor air pollution improved very much because there was no transports. The roads were absolutely empty, especially except the emergency vehicles. The trains had stopped, the buses had stopped, the airplanes had stopped, the ships had stopped. So practically outdoor air pollution, the factories had stopped working. So outdoor air became so clean that everything was visible. From places like Punjab and all, people used to see could see the tip of the Himalaya and the entire Himalayan range, which was never visible to them, and they thought it is a wonder. So COVID definitely explained a lot of things that which are possible. COVID showed us that taking care of the outdoor air pollution was possible if we limit the emissions, and the emissions are not harmful. The opposite may have happened in the household air pollution, but definitely people started using electricity more. The liquid petroleum was used more. Household smoking in the smoker's room must have increased, but definitely children with infections, respiratory illnesses, asthma, and they decreased drastically. And probably that was due to the decrease in outdoor air pollution, as well as due to decrease in transmission of viral illnesses. As the schools were closed and the children were indoors only and isolated from other children, so viral infections and bacterial infections came down drastically, and lung functions improved. And the children who had asthma earlier did not show symptoms. that might have been the cause of decrease in respiratory and other infections during COVID times.
So, with this is what you say, if suppose development work is should go on, so it should be environmental friendly, so that it should cause less of pollution, so that will affect the children health in a lesser amount. So now at the end, you mentioned in between, okay, one of the causes of air pollution is waste burning, but it's a common practice, especially in smaller towns. They gather all the fuels, the trash, and they burn it. So if it causes air pollution, what could be the other way to manage it?
The crop burning is a big problem in Punjab, Haryana, UP, and some areas of Rajasthan, where after taking out the top of the ripened cereal like wheat and rice and all that, the stalk and the roots remain, and the farmers don't have that much money to take them out and dump it somewhere and then send it away. So instead what they do is they burn the dry crop, what the remnant is, the crop burning. And that is a major source of pollution in the Delhi and the Noida area, the Gurgaon area. The most of the air pollution is due to vehicle emissions as well as the emissions from crop burning. IIT Kanpur has developed a bacteria which can be mixed with these dry crop in the soil, and it decomposes the crop and it makes it a manure. But it is also, it comes with a cost. Still the farmers go to the least expensive way of just lightening up the burning of the crop, and the whole crops burns in a day or two without any other effort. So we have to have some laws, we have to have some counseling to the opinion leaders in the farming sector that crop burning is not the good thing to do, and with little bit of punishment and all these things, I think we can move ahead. And if crop burning stops, the vehicles, we are seeing the government has got a definite policy of increasing the fuel prices. It has been told by Mr. Nitin Gadkari that we do not intend to bring down the fuel prices. We are going to continue hiking them up till people cannot afford fossil fuel. They have to shift on the electric vehicles. So India has got a commitment of starting electric vehicles from 2025 gradually, and by 2030 all the small vehicles will be electrical vehicles, and by 2050 fossil fuel will not be available for vehicles.
So, as you mentioned, either people should go for the very expensive fossil fuel, or they should go for electric vehicle, or they should go on walking or by cycle. So that will improve their physical activity too, apart from the exposure to air pollution.
Right.
Friends, new speaker, Dr. Palvi Mukhe ma'am, she was telling all over the cosmetology and all these things. One of the fact is air pollution leads to premature aging, and most of the time the person doesn't know he is exposed to premature aging. So now we are at the very last end of our discussion. What will you take home message to our audience?
Take home message one is to rapidly shift to, in the house we stop using any other form of energy except liquid petroleum gas or natural gas and electricity. No kerosene, no charcoal, no wood, no
fossil fuels.
Dung, dried cow, animal dung or crop waste. They should not be used. Solar energy, we should, those who can afford should start using solar panels and start using clean energy. Then we should walk and bicycle more. Stop using fossil fuel run vehicles gradually. And finally, we have to come to the electric vehicles. Crop burning has to stop. Construction areas, industries, they have to change their ways so that emissions do not escape into the open air. And that is the way forward.
Sure, sir. And it is mentioned that 59% of the air pollution is caused by the dust from the road construction and all, as you mentioned, the construction work. So, sir, heartfelt thanks from the organization Indian Economic Periodics Amravati Branch and on personal behalf of mine that you came over here, you stayed all the way through over here, and you guided the audience on a very sensitive and to a certain extent untouched, neglected aspect of air pollution in childhood. So thank you, sir. Thanks to the audience. And now over to Dr. Sagar, sir.
I would like to thank IIP Amravati branch, you personally, Dr. Satish Agarwal, and Dr. Sagar, Dr. Jayant, Dr. Naresh, Dr. Sunil, all the people of IIP Amravati for giving me a chance to be amongst you, talking to you, and I look forward to more of such meetings. Thank you so much.
Thank you, sir. Over to Sagar, sir.
Thank you, sir. Thank you for your eye-opener elaboration on air pollution. And thank you, sir, Satish, sir, for giving me also an opportunity to be here with you and with IIT Amravati and others. So this was an excellent talk. The two topics which actually came back to back, the plastic pollution and air pollution. I'd like both of you and other stalwarts of our IIP to take this topic to the national level of IIP, and such topics should be actually included, and child health, pollution and child health should be included in one of the, at least one of the sessions in our IIP's conferences, and there could be a small workshop about these issues, because actually this is a burning and issue, and we have seen that many pediatric patients, I stay in Nasik, so people who come from Mumbai and people who go to Mumbai, so I came across with both. So there are various problems which are faced by the children who stay in near Kalyan or in Thana and those who came to Nasik. So many of them, they are actually related to the pollutions. I remember one of my CR, Shivaji, he is now in Satara practices. He has to leave Mumbai because of his asthma. He was like in New Mumbai, and he was not getting, he was getting frequent asthmatic problems, so he has to leave that place. So such is the burning issues of the pollutions. So thank you, sir. Thank you, IIP Amravati. Thank you, Sadish, sir. And thank you all. Thank you.
Thank you so much.
Arpita, unmute yourself.
I'm sorry, sir. It was indeed a wonderful session. Thank you so much, Dr. Sagar Sonone, sir, respected Dr. Satish Agrawal, sir, and respected Dr. Alok Gupta, sir. And it guides us that let's be a part of solution and not a part of pollution now. So thank you so much, sir. The lecture was very impactful. Ahead with this, I would like to welcome and introduce our next chairperson, respected Dr. Jyoti Bob, ma'am. Ma'am is a tutor at Department of Biochemistry, PDMMC, Amravati. And with this, I welcome you, ma'am, and hand over this session to you. Thank you, ma'am.
Good afternoon. It's my pleasure to introduce Dr. Jayant Pandrikar, sir. He is MD Pediatrics, PGD AP, FICMR, pediatrician and adolescent physician. He is Director of Shushrut Maternity and Children Hospital, Amravati, Life Care, and Director of Ambadevi Sansthan Hospital, Amravati. He was President, Maharashtra State IAP 2020-2021. His tenure was excellent. So I welcome Dr. Jayant Pandrikar.
Thank you very much, Dr. Jyoti Boob Madam, for a nice introduction. At the outset, let me thank wholeheartedly the convener of this today's exclusively different CME, that is Health for All, and none other than I would like to thank and congratulate Dr. Satish Agrawal sir for organizing this particular CME. He has come up with a very entirely unique concept with the idea that we should have a comprehensive approach to the health, not only related to one pathy or one modality of treatment. So he has included all the pathies in today's CME. Mainly, he has talked about the preventive, promotive, and curative aspect of the health. I must thank IIP Amravati President Dr. Naresh Tayade and Secretary Dr. Sushil Rajput for inviting me also. Then now coming to the today's topic. Basically, today's CME is organized for the to celebrate our WHO Day. That is the theme of WHO Day was our planet, our health. So if you look at the health, what is the definition of health? We all know it's a complete well-being of mental, social, physical well-being, not just being the absence of disease or infirmity. So when Dr. Satish sir asked me to talk, this is the theme of the today's CME. So you select a topic accordingly. And I being an adolescent pediatrician, he said you select topic something from adolescent pediatrician, but the theme is this. Then I thought that what topic can be selected for this? When we talk of health, we know it's a physical health, it's a mental health, it's the social health. And the previous speakers have talked very nicely on various aspects of physical health and social health. Just now, the respected Dr. Alok Gupta sir and Satish sir had a very nice discussion on this the social aspect of our health, which is very, very important. Then I thought that I should pick up a topic related to mental health, especially in adolescents, because we all know. Excuse me. Now we all know that the health issues in adolescents, they are less of a physical but more of a mental, social, psychological, and emotional issues. So then I thought of taking up the topic which is related to the mental health issues of the teens. So what are the mental health issues of the teens or adolescents? We all know adolescent is a very delicate age of period of transition from childhood to adulthood, mainly between the 11 to 20 years of the age. And it's a very delicate age. Everyone goes through this delicate age, and a lot of hormonal turmoil is occurring in body, and the adolescent responds to that. At the same time, he's exposed to so many newer things in the life, and he has to adjust accordingly. And in doing so, he is more likely to get the emotional, mental, psychological, and social health issues than the physical health issues. That's why I thought I should talk on this particular mental health aspect of the children. Looking at the mental health aspect, there's a long list, like depression is there, bipolar disorder is there, eating disorders are there, sleep disorders are there. So what all things are important is for this adolescent health is mainly the peer pressure. It is because this peer pressure, it is more what you call more factor causing to lead this all emotional and the behavioral and other problems. So today's my topic is the peer pressure in the teens and adolescents. Let me give some time to share my screen. Well, so my topic is peer pressure in the teens. We all know there are so many pressure in adolescents, like peer pressure, family pressure is there. Aisa hona chahiye, ye hona chahiye, like that. Then we have gender pressure. No, 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 you are boy, you are girl, you can come, you should come before 8 o'clock in the evening at home. So there is gender pressure. So such type of pressures are there. Then there's a media pressure. Yeah, this is the most important topic. Recently, one question was asked by respected Dr. S.K. Punshi sir regarding this media effect on the adolescents. So really, media is causing a lot of changes, a lot of pressure in adolescents. That I'll discuss later. Then the adolescent has to face a lot of societal pressure. There are a lot of societal expectation. No, no, now you are grown up. The society expects something from him. So these pressures are there. And of course, study pressure is because the 10th and 12th, which are the most important academic turning points of every adolescent, they come during this period only. So there are so many pressures, lot of pressures which adolescent faces. Now coming to peer pressure. What is peer pressure? Definition wise, it's the ability of the people from the same social rank or age to influence another person's decision-making process. It's not somebody's directly pressurizing you, but it's the some pressure which causes the influences on the one person's decision making process. That is what is called as peer pressures. Before proceeding, let us discuss the who are peers. Peers are not that they are from the same age, but they can be from the contemporary age. They can be from the same group. Like say for example, if there is a cricket team, the cricket team may have a student from 8th standard, may have a child from 11th standard also. So they can be having same social group, having social, having some same aim. They are working in a team. So these all groups they are called as the peers. So the peers can have not only the same age, but they are having the some same aim with which they are working with. So the adolescent can have various groups, like he has peer groups in the class, he has peer groups in the what you call it, it's a team, he has peer group in the nearby home. So there are different age groups or different groups he can have. Now, what is peer relationship? We all know friendship is very important. If I ask to talk in Marathi, is the आपल्या सवंगड्यांचा प्रभाव, सवंगड्यांचा अभाव, सवंगड्यांचा स्वभाव आणि सवंगड्याचा दबाव. Exactly what does it mean? This means that we do require peers, we do require friends, because without friends we cannot survive. Now, what is peer influence? Influence is always considered to be in a positive way. Say if a child or the adolescent or teen gets influenced by someone's good act, that is what is called as peer influence. And many times this happens in everyone's life. Now, what is peer pressure? In peer pressure is something what we discussed just now. There's something which is changing the decision-making capacity or abilities of that person, which is getting pressurized. That is what is called as peer pressure. Now, there are different types of pressure: positive pressure, negative peer pressure, good peer pressure, bad peer pressure, then the spoken peer pressure, unspoken peer pressure, direct, indirect. So there are different theoretical classifications of peer pressure. Now, what are the facts about peer friendship? We all know that teens have often multiple layers of groups and friends. And the peer friendship is always dynamic. On one time they have this peer group, on some time they have another peer friends. Because I'll discuss why this happens. What is the neurophysiology of this, that I'll discuss when we discuss later on. So basically, the overall adolescent age group is a age of experimentation and the exploration. Child is developing. He is transitioning from the adult childhood to adulthood. So he has to experiment something new thing. He has to experiment something, explore the new world. What is happening around him? He doesn't want to remain now with the mama ka bacha or papa ka bacha. It's not like that. He wants to show his own autonomy. No, he wants to establish his own identity. No, now I'm so and so. It's not that I'm someone's son or someone's daughter. He wants to show that now I'm autonomous. I should take some decision, and I should not follow every time my parents' decision. So this is what these are the primary developmental tasks of the peer age group, and mostly this is a time and place, or the peer group is a place for experimentation and exploration. Now, what are the role of peer relationship and its influence in adolescent development? No doubt, it's not that every time peer pressure is bad or peer influence is bad. It helps to develop the lot many skills in the adolescent. Most important is the conflict resolution skills. Say, for example, a 5-year, 6-year-old child, he fights with his friend, and then he comes back to parents saying that no, he's fighting with me like this. Please help me out. But an 11-year-old child, he cannot do that, because now he wants to show his own identity, his own autonomy. And so here, by tackling with such events, he is developing his own life skills, conflict resolution skills. And of course, peer is a place where he finds fun, excitement, it's a recreation. And no doubt, the peer groups, they give good advice, and they help to solve the problems of their peer groups, friends also. And this all gives them the stability, or it helps them to relieve the stress. And that's why peers are always more attached to the peer groups, or the students are more attached to peer groups than the friends or than the parents. Okay. Now, if you look at the statistics of the peer pressure, no one can say that I never had peer pressure. Every person who is born in this world have experienced this peer pressure either once in lifetime, or 100% they get suffered with the peer pressure, or they may get influenced by the peer pressure. In a study said that 98% of the street children and 78% of the school children, they are the victims of negative peer pressure. Then is the statistics. 96% of the children, they start smoking just because of peer pressure. 94% starts alcohol consumption or drug consumption almost because of peer pressure. Let me ask a single question. Has anybody gone for the first time to purchase the alcohol for himself or herself? Never. It is someone who has purchased for himself for the first time. Later on, he may get addicted and go and purchase for himself. But for the first time, everybody has received it from some friends or some peer pressure. So these are the statistics. Even the US study says that the 3.1 billion teen, they are the smokers, and of course they are all because of the negative peer pressure. They are exposed to these drugs, alcohol, or even the sexual acts. All these things are because of negative peer pressure. Now coming to the neural mechanism or the neurophysiology of the peer pressure. This is what mentioned by Wendy Trainer, identity shift effect. It mentions that social theories, the cognitive dissonance, it addresses the internal conflicts, whereas the social comparison, it addresses the external conflict. I'll try to make it more simpler. Basically, the limbic system is there in the adolescent, which is responsible for the emotional reactions, and the prefrontal cortex part of the brain, which is responsible to take the mature decisions. And unfortunately, what happens that the limbic system is very active right from the early adolescence till late adolescence. In the contrast to that, the prefrontal cortex is slowly developing, and it gets matured at the mid adolescence, or even beyond that, around late adolescence. And that's the very reason that every adolescent, early and mid adolescent child is more more potential to get pressurized by peer during this age group. He's psychologically, emotionally more labile or more vulnerable age group as compared to late adolescence. The very reason is development of prefrontal cortex always occurs very late as compared to the limbic system. And I can say limbic system prefrontal cortex पे हावी हो जाती है. So whatever the responses or whatever the reactions they give just at the level of limbic system, and they do not think at the level of prefrontal cortex. That's the very reason why this team, they are more vulnerable at this particular age, for as far as the psychological and the emotional reactions are concerned. Now, why teens are at a risk for peer pressure? Suppose if they feel कि अगर मैंने इसको ना बोल दिया, तो the whole peer group may reject me, And here he wants to get liked, he wants to get popular amongst the group. He do not want to hurt his peer friend. अगर मैंने नहीं उनके साथ गया तो शायद वो मुझे छोड़ देंगे या मेरा साथ छोड़ देंगे, मैं ग्रुप के बाहर हो जाऊंगा, like that. And that's why they are at more the risk. And of course, most of the teens in the group, they are not sure what exactly they want to do, because चलो 10 लोग ऐसा बोल रहे थे, बाकी के 2 लोग बोलते हम भी तुम्हारे साथ चलेंगे, like this. So they don't want exactly what to do. They don't know how to get out of the situation. They know कि नहीं अभी 5 लोगों का ग्रुप है, 3 लोग स्मोकिंग करने जा रहे हैं, 2 लोगों को लगता है कि यार it's not good thing, but they don't know how to get rid of it because they don't want to lose other 3 friends. Another thing is here they want to show to grown up. Yes, अगर कोई someone smokes and he's what do you call, they shows it with the some looks like he, and someone says that तू तो हीरो जैसा दिख रहा है यार, and then he gets what do you call positive feedback. नहीं मैं तो अच्छा दिख रहा हूँ, like that. So because of that he wants to show that he has grown up. Another thing is that he don't want to become sad, anxious, guilty or disappointed, and that's why even if he is to some extent prefrontal cortex says that no this is not good thing, but here the limbic system it overpowers it and he does the act which he is not supposed to do. Well, coming to the positive and negative peer pressure, very clearly negative, it is often dangerous. Any act which is often dangerous and it is against the school rules, home rules, personal values, social values, family values, these acts, they are called as, they are the examples of the negative peer pressure. Skipping for the school, vandalizing, smoking, involving drugs, involving in sexual act, bullying, and all those acts, they are the examples of the negative peer pressure. Now, coming to the positive peer pressure, exactly opposite to that, any act which is positive in a way, and it is here that it influences to do the in a right way, which is what you call as per the family rules, social rules, or personal values. So this is what is called as, these acts, they are called as the positive peer pressure acts. Say for example, studying and engaging in the some voluntary acts, engaging in some what you call community services. So these are the joining some sports team. So these are the various examples of the positive peer pressure. Well, this is the what picture we always say, because adolescents, they always want to remain with their group. They do not want to lose their friends. Now, how to identify the students? The traits putting students at higher risk. How to identify, or on the other side, I would say who should identify this negative peer pressure points. It's the teachers, it's the parents, and it's the peer himself and the teen himself. They should identify though that these are the red flag signs and I'm not doing the right things. So if the child is getting low self-esteem, he's having lack of confidence, he's having what you call uncertainty about what to do, he doesn't have any personal interest, he has lack of sleep, he's having some eating problems. His most important thing is that poor academic performance. Usually we all know adolescent or teen, they stay almost for 8 to 9 hours in the schools, and teacher can definitely pick, and most of the peer groups, they are in the school itself. So teachers are the best person who can pick up their such a red flag signs. Well, these are the, now who can help? I just told you that's the parents, the teachers, counselors, teen himself, and other friends, they can pick up it. Now, they should make students aware of this pressure which they are encountering. They should identify these are positive peer pressure, these are negative peer pressure, and they must explain that the child, no, the things which you are doing under your peer influence, this is not really good. Who can? Now, what exactly they should do? I'll give you an example. Say 10 students of the 10th standard, they are now is having a good peer group, and 8 of them say we'll bunk the classes and we'll go to now some what do you call that pub or pubs like that, and we'll enjoy the music. What happens here? The 2 students of this group, they may not be interested in going. They know now this is my 10th exam. I know I should not bunk the classes. This is the most important, crucial period of my life. I should not join with them. Going to pub is not the right age for me. He knows everything, but still he doesn't want to break the group. He doesn't want to lose the group. So he just goes with them. But what exactly he should do? How to get rid of this? He should first make a joke of it and change the subject. Nahin, yaar, apan wahan nahi jayenge. We'll go to playground or we'll do some other place. he should suggest some activity. We should play something and we should do some other activity. Then most important thing, he should develop and the assertive skills and say firmly, sorry, I cannot come with you. These skills must be taught to the students. If इससे भी possible नहीं होता है, then what he should do? He should leave that area. It's better. Gets help from someone you trust. At that time, he feels get all other 8 people, they are forcing him, they are pressurizing him. Then he should call someone else to help him out, either his friend or his parents or his elder brother or teacher. And he should vent out the things. कि मेरे साथ ऐसा ऐसा हो रहा है, I don't want to go with them, but they are forcing me. What can I do? Here, this close counselor, close family member may help him. Then he should utilize this decision-making skill, assertive skills, and develop rejecting skills and listening skills. Friends, we all know relationship is just like water. It has no size, no shape, no place, no taste, but of course, it's very essential for the life, and that's why no one wants to lose the friendship. Bullying, I'll just skip, is one of the negative peer pressure. Media pressure is one of the negative peer pressure. Then the problematic internet use, this also peer pressure nowadays we are getting. I'll just skip these slides. Okay, so when life puts you in tough situation, don't say why me, just say try me. So we must tell our students, we must tell our teens that you should try to find out the alternative solution in such cases. You should try to utilize your decision-making skills. Try to utilize your assertive skill. What are assertive skill? It's a type of communication which firmly, clearly says that he doesn't want to, or he doesn't want to do that thing, or he wants to do his own thing without hurting his others, others. That is what is called as assertive skills, and these skills must be developed in all teams. Strategies to the how to tackle with this. Of course, I'll skip those slides. Counseling of peer pressure is very important. I will take up 2 minutes because the teacher's role is very, very important, and teacher can make all the difference in the world of teens because they are with them almost for 8 to 9 hours. He's like a person who can immediately identify some changes in an adolescent or in a teen, and he should talk to him, he should communicate with him, he should have proper communication with the teen and find out whether he's getting pressurized by the other peers or not, and try to solve that things only mainly with the communication. And if needed, the teacher can take the help of the school counselors. Nowadays, most of the schools, they have school counselors. So if he feels that there are some dangerous red flag signs, he should seek the help of counselors. Now, what are dangerous red flag signs? If the child has very low self-esteem, he is depressed, and if there is a sense of worthlessness, helplessness, hopelessness, these are the 3 red signal, bad, dangerous signs. If such signs are seen, then immediately you should contact the psychologists, counselors, or psychiatrists, because otherwise this child may land into suicide and he'll end up his life. So before that, every teacher, parent, and his peer friends should identify these red flag signs. Yes, we must tell them that you should think for yourself, and it's always okay to say no to drug, to alcoholism, to the sex before the at this age. How to control peer pressure? The role of parents: they can identify negative signs, they can identify red flag signs. They must communicate with the child. They must boost up the self-confidence and image of the child, and of course, if required, they should seek the counselor's help. These are the very 3 important keys I always mention to the kids, that if you get such a situation, you should look for these 3 keys on the computer: control, alternate, and delete. At that time, you should control yourself that as a situation I have, what to do. Just keep calm and quiet. Try to use assertive skills. Try to communicate properly, and just leave that area. Second thing is, look for the alternate solution. If you find that this particular group is repeatedly pressurizing him, which is a negative peer pressure, which is causing harm to himself and harm to his family values, please try to find out alternate solution. And of course, if such a situation arises all of a sudden, then you must try to delete that situation, get out of the situation, leave that place, and find out some solutions. So these 3 keys are very, very important that one should follow. So just to conclude, peer pressure, one must try to identify whether it's influence or peer pressure. Influence is very good because always a positive, and peer pressure is mostly it's a negative. If it's good, positive, then it's always good. Then they try to identify the how to help the children. We must develop the building activities. We must develop the communication skills. We must develop the assertive skills. We must develop most of the life skills like decision making, creative thinking, critical thinking. All those life skills, they are very, very important, and every teen must be taught regarding these life skills right from the age of 7-8 years. And of course, one must update regarding the various new pressures, like nowadays this the internet use, the peer pressure or the media bullying is a new type of peer pressure. And in the last few years, last 2 years of COVID era, where every child was exposed to the media, and he was more get bullied because of this media or the problematic internet use. So this type of peer pressures, every time some new peer pressure is going to appear, and one must update accordingly for that. So once again, I thank the organizers. I thank Dr. Grawal sir. Thank you, chairperson, for giving me this opportunity. Thank you very much.
Thank you,
Dr. Jyoti,
Dr.
madam.
Pandrikar. Thank you, Dr. Pandrikar. It was an excellent talk. Now I welcome Dr. Sachin Pavade. He will speak on water conservation, need of the hour. He is MBBS.
I expect to see it. Prakash.
Sir.
Dr. Pavade sir. And we take the opportunity to acknowledge the presence of Dr. Vaishali Vyavhare madam, the observer for today's CME. And we put on record our thanks to Dr. Vyavhare sir, another observer for today's CME. Dr. Jyoti ma'am.
Hello.
I welcome Dr. Sachin Pavade sir. He'll speak on water conservation, need of the hour. He is MBBS DCH, gold medalist from Nagpur University. He is attached to Gandhi Vidyalaya, RV, Shivaji Science College, Amravati, and Government Medical College, Nagpur. He is running Vatsalya Pavade Nursing Home at Varda. He is founder president of Vaidkiya Jan Jagruti Manch, Varda. He has done phenomenal work in various medical and social fields. Welcome, Dr. Sachin Pavade, sir.
Thank you very much, sir. I am thankful to all of you, and particularly Dr. Agrawal, sir, for giving me this opportunity to speak on the topic like water on this academic platform. Mr. Prakash, where I will get my PPT?
Yes, sir.
Thank you very much. Can I scroll this?
Sir, please scroll.
Slides both आहेत का? Sachin, are you able to do it? Dr. Sachin? But slides move होत नाहीत.
सर लॉग आउट झाले
आउट करून परत शेअर करून बघ.
Hello.
Yes, you are audible and visible also.
Yes, actually नेट गया था मेरा. Sorry. Mr. Prakash, मेरा स्क्रीन अपना ये PPT आ गया क्या presentation पे?
हो सर. हो.
Can I scroll on this device because I have changed the device now?
Just a second, sir. Just a second.
For the information of the audience, although it is not written in Dr. Sachin's CV, he is an activist for water conservation. He has done a tremendous work. He is a very good social activist for this water conservation.
Thank you, sir. Thank you for the introduction. Thank you very much.
सर नेम शो नाही होता.
नेम शो होईल ना सचिन पावडे नावाने. हा आता नेम शो नाही होत नाही. नाही येत आहे माझं नाव.
नाही सर.
डॉक्टर सचिन पावडे नावाने येईल ना. आहे ना स्क्रीन.
प्रकाश सरांचं नाव दिसतंय स्क्रीनवर.
हो मी रिमोट कंट्रोल देतोय तर सरांचं नाव तिथे सर्च नाही होत आहे. सगळे दिसत आहे.
अच्छा एक काम करा तुम्ही स्क्रोल केलं चालेल.
तुम्ही मला सर नेक्स्ट मध्ये जर मी स्लाइड्स
Yes.
Okay.
Yes. Am I audible and visible?
Yes, sir.
Thank you. So first of all, I am very much thankful to all of you and particularly Agrawal sir for giving me this opportunity to speak on this topic. Totally non-academic topic, but very important topic in the particularly as Pandrikar said, sir said, ki relationship is like water, and it continue with that. It is odorless, tasteless, but it is very important. Water is very important for life also. Next slide, please. So you all of us know that 70% of water is covered. Earth is covered with water. Of that, 97% is saline, 2% is in the glaciers, and 1% is the river, lake, and groundwater. And that too, 0.6 of that 1%, 0.6% is the groundwater, and that groundwater is the very important water which is available for all of us everywhere. And you will be surprised that of that 0.6% of groundwater, we have already taken out about 0.3 to 0.4% of the groundwater from the ground through wells and bore wells. And that's why the remaining water that is in the ground is only 0.3 to 0.4%. Next slide. Next slide, please. So we should know the global sum of withdrawals of the water. All these things are very important when we discuss about water, because these are the things which we should consider when we think of saving the water. So the total water which we withdraw from the groundwater is 70% it is utilized for the agriculture, 19% is for the industrial use, and only 11% is for municipal. That means that we take from the municipality for our day-to-day activities. But when we think about groundwater, of this 70% water which is utilized for the agriculture or for the municipal, around 70 to 80% of the water for agriculture, it is utilized from groundwater, which we saw that the only 0.6% of that we use 80 to 90% water for, of this 70% for agriculture, and industries 19 may say around 5 to 6% it is utilized from the ground. And when we think about our municipal use or our personal use, we use in rural areas about 80 to 90% of the water of routine use, it is taken from groundwater, and in urban area it is 50 to 60% of the water we utilize as a groundwater. Next slide, please. So when we talk about India, we are very much fortunate that we have 2% of world's land and we have 4% of fresh water. It means as compared to land, as compared to world, we have double water as compared to our land. But at the same time, we have 16% of the population of the world and 10% of the cattle. Next slide. Next slide, please. So as a pediatrician, we all know that the infected water is one of the major source of loose motions and diarrheal diseases in children. And every 15 seconds, one death is due to the water related problem. And from that, we should know how important that water is. Next. Next slide, please. So water is life, and we should value the drop, and we should know the value of the drop. So to conserve the water, we should know the value of the every. Next. So when we think about the water, groundwater, and water cycle, that 0.6 from where that 0.6% of the water is in the ground comes. We all know that water falls on the ground, it gets percolated in the earth, and we get the groundwater. But we should know that the water we draw from our well or our जो हमने हमारे घर में कुआं रहता है, वो लेवल में वो बारिश के पानी के जाने को 1 साल लगता है. That we should all know कि the water which comes in July and August, we get in the next July and August. That's why after July, August, the water level they increases, and then after that, once the summer comes and our water हम ज़्यादा निकालते हैं, तो water level नीचे जाती है. So when we think about our common use well, what the water takes from to go that level, about 40-50 feet की water level well हमारे यहाँ रहती है, और वहाँ जाने के लिए बारिश के पानी को 1 साल लगता है. लेकिन when we think of the bore wells की जो 100 feet है, 200 feet है, now in Vidarbha we don't get water up to 400 and 500 feet also. So the water we are drawing from that 400, 500 feet, it takes around 100 years or 150 years to go at the level below 100 to 200 feet. So the water which we are drawing from our well or bore well, it is not the water which rainfall which we have received last year. It is the water which is there from around 100, 200, 300 years. और we can say कि हमारे जो पूर्वज थे उन्होंने वो पानी को वहां रहने दिया, इसलिए वो पानी हमारे यहाँ पे अवेलेबल है. लेकिन जो 1990 से जो बोरवेल की क्रांति हुई है, we have started using borewell water 100, 200, 300 feet, and industries they are using water from 1000 feet also. So that water is not a rain water, because rain water अगर वहां रहता था तो वो हर साल वहां पे आता था. It is the rain water which has been laid by our ancestor for us in the earth before 100, 200, 300 years, or it is not at all a rainwater. It is the water which is Earth's own water, which is required for Earth for maintaining its stability, for the other microorganisms living inside, for the so many stabilities of the Earth. That water is there. Next. Next slide, please. So when we think of a drop, every drop we should think of हमारे घर में एक टपकने वाला नल रहता है जो हमारी नींद रात में उठा देता है, और धीरे धीरे हमें वो बूंद की आवाज की आदत हो जाती है और हम आवाज में भी सो सकते हैं. तो that per drop, when a tap leaks one drop, it is around 2 lakhs liter per year. And when we think of 1 liter per minute, it is 1440 liters per day. That is 5,25,600 liter per year. And we all must know that when we start a tap, in a 1 minute, a single अपना household वाला जो tap है, it gives 8 to 9 liters of water in a 1 minute. So when you start or you on your tap in the bathroom or in your basin, you should always think that you are spending about 8 liters per minute. And when you calculate about in a year, you can calculate it is a very huge amount of water we are spending. So when we use water, we start up a tap, just think how much water you are using. Next. So now we are civilized people, as we say, but when you go in the back in the history in 1900 or 2500 BC, the people, they were more civilized than us. Next. There are a few examples I will show here. This is the one water reservoir in Harappan civilization. This was a big tank, and the rainwater these people used to store in this tank, and this fresh water they were using all over the year for all day-to-day activities, including agriculture use also. You must know, or we all know that all our civilizations, they are on the bank of the river, like Indus or major civilization in the world, they are on the bank of the river. Though the people were near the river, near the water, but they were not spoiling the river. They were not using much river water, but they all were using the rainwater which was collected over the year, and that water was utilized for their day-to-day activities. But what happened? The so-called civilized people like us, we are using river water, we are polluting river water, and we are taking the river water with us. We have built dams, created new pipelines, and we are taking out that river water to our society. So we should think whether they were civilized or we are civilized. Next. So this is a small tank, which is a very good example of groundwater. You all of must have seen the Sinhagad Fort, and this is the Devtaki over there. And you get that fort is very much on the top, but still water is percolating from the wall of the tank, to down. So how that water has come at that level, at higher level, at the Sinhagad, and this is the very good example of groundwater, and how groundwater gives which is a very huge topic. I cannot explain it completely here, but these are the few pictures here to sensitize all. Next. So now we all are in the era of rainwater harvesting. पिछले 2-3 साल से we are always हमको rainwater harvesting करना है, and I get so many calls. Then how? First we should think कि what is rainwater harvesting and what we can do. So there are few things we can do that we can start from now. That we should start saving the water. I have already told you the value of a single drop. So while using water, while starting your tap, you just think what is it necessary, how much it is necessary. And from your morning, from doing toothbrush, using toothbrush, getting yourself clean, and from your bath to washing clothes, every time when you use the tap, just think, is it necessary and how much I should use? You will be surprised to know that the water requirement of an urban population like us is about 150 liter per person per day. And of that, about 60% of the water we people are spending on toilet flushing. So whenever you flush the toilet, just just keep in mind that you are wasting about 60% of water which was allotted to you according to 150 liter per person per day. And when we think about the rural people, their water requirement is around 40 to 50 liter per person per day, and that is because the water the people use, that is only for drinking and for other work, and they use it by bucket and not by the null. Because in this era, when we ask the school students ki water kahan se aata hai, so they always ki hamare ghar mein pani nal se aata hai. And every urban people, they knows that water comes from the null, from the tap. But when you ask from the to the students from the rural area, rural school, they will always know कि उनकी मम्मी रोज सुबह उठती है, वो बकेट में पानी कुएं में डालती है, खींच के फिर उस घर में लाती है, and they know the drop of the value of the drop. And that's why the water requirement in the rural population is very less. It is 1/3 as compared to urban population. Next. So what we can do, we can save every drop. We should think of using every drop, and we can do rainwater harvesting. So what are the different modes of rainwater harvesting? We can do it on community level, and we can do it on the personal level. So for community level, you will have to participate in so many Shramadhan activities. They are going on. The importance of that activities is that either you go for Shramadhan, and when you dig a small trench and you work with the village people, they are working day and night for the water conservation project, then you will know how it is very difficult, how difficult it is to work in a temperature of 40 to 45 degree, taking that kudal powder in hand and digging the trench, and that for a single drop of water, then you will know how important that water is. So here we are in Wardha and Wardha district, we have started many activities. We are taking people for Shramadhan and making them more aware about water, and at the same time, we are helping the hands, the rural hands, which are doing water conservation work. Next. So this is our Hanuman Tikri. Here we have made about, this is trenches of about 2.2 kilometers, and it is not particularly about rainwater, but here we have a big water filtration plant which supplies water to about 16 gram panchayats, and the water which was wastewater from the water they supply to the villages, and the remaining water or a dirty water they used to allow it to flow from the roadside. And we made a project with the Wardha district government and district administration and Mahatma Gandhi Hindi University, and the water which was flowing by the side of the road, we made it flow through our, this is our Vijayam Hanuman Tikri, Vaidike Jana Jagruti Manch Hanuman Tikri. And these trenches we are seeing now, this water is flows through these trenches and it gets percolated. We have got the effect due to this water, percolation of water from these trenches, the water level in the nearby area, which was a dry zone, people don't, यहाँ पे जिनके plot थे उन्होंने घर छोड़ के चले गए. Now you will get about the water level here, you get about 50-60 feet. अगर आप जाएंगे तो you get drinking water to your well and bore well also, and that is the magic of this rainwater harvesting. Next. This is the, you can participate in plantation activities also. This is our Miyawaki project. We have about 15 to 16 Miyawaki forest over here. And the importance of Miyawaki forest in rainwater harvesting is, this Miyawaki forest, they harvest the water beneath that Miyawaki forest land. These are the self-sufficient forest. You get the height of about 10 feet. 10 years growth in only 3 years. This is a special type of technique. You have to do some soil preparation, and this type of forest, they require very little amount of water, but they conserve very much amount of water beneath the land. Next. So these are our farm ponds which we do in the villages, and these are our workers. They are helping to the villages. We are taking people from Wardha and nearby cities to these villages and ask them to work with these people. Next. So these are all community projects in which you can participate. If you are not, you cannot go personally to these villages. You can donate them some instrument like kudal powders and their routine. You can give some money for them for diesel because some JCBs and Pokelands are doing water harvesting work. These village people, they cannot contribute much, so we collect money from the people nearby, and we give them some 5 hours of Pokeland, 5 hours of JCBs, some diesel like that. Next. Next slide, please. So these are the water awareness education program we take in villages. We collect villagers and school students. We take them there in the particular site. They ask them how to work, how to tell them what is the importance of work, what is the importance of water. And through these awareness programs and people's Shramadhan projects, we would make very huge impact on the society and also on the groundwater level. You will be surprised to know that the people in our Wardha district, where the villages were very much drought affected villages, now they have adequate amount of drinking water, but at the same time, they take 2 crops in a year. Ideally, in this region where our all agriculture is dependent on the rainwater, there are some villages, they are now using this water from the tanks, from these farm tanks and from their wells, because their water level has increased. Now they are taking 2 crops in a year, and that's why at this, when they get their drinking water, at the same time it is helping their finances also. Next. So this is our water bank concept, which I just told you. You give us 30 rupees and we give 50,000 liter of water. Next slide, please. So when you dig 1 cubic meter of dale, it costs 27 rupees, and 1 cubic meter is equal to around 30 cubic feet, and 1 cubic meter feet area collects about 30 liter of water. Therefore, 1 cubic meter water will collect 1000 liter of water, and in one rainy season, this dale we make, it percolates water 5 times of its capacity, and this dale we make from this Shramadhan or through diesel work, it works for around 10 years. So with 30 rupees, you can harvest about 50,000 liter of water. And this concept was propagated in the community. And next slide. We got a huge response. Next slide, please. Prakash ji, next slide, please. So, next slide, please. Next. So, you can see this 60 crore liter of water was harvested in about our 240 villages in Wardha district through people's participation, through Shramadhan, and collection from the people. So these are all community projects, and our concern is that what we can do for the water. So these were the project we started on personal level. What I can do. So this project we started in Wardha and in me. So this type of Nanded pattern soap pits were created in Wardha city, and we make awareness through such type of leaflets. We got call from the people. We advise them how to do it technically, and this type of soap pits, around 500 soap pits were made in a period of 3 months. It was in the 2018, because last 18 and 19, because since last 2 years we were not able to go to people due to COVID reason. Next slide, please. Next slide, please. So this is the Nanded pattern Shoshkata. The water which goes from our basins, our tanks, we do such type of arrangement. This is the particular picture. Next, next, please. This is the picture of in my hospital. The water from which is not non-infected water going from the basins and bathrooms. We go through pipeline. We go to this soap pit. This is a big blue tank of 200 liters, and the area around that tank it is उसमें बहुत सारे पत्थर रेत वगैरह डाली है, और ये जो टैंक है इसके अपर सेगमेंट में we have made 4 holes, and the water it get first filled in that tank, and then it overflows. And when it overflowed, it get filtered through the media which is surrounded outside of that tank, and then it get percolated in the my well. So you have to take some precautions while making such type of shoshkattas, because it may you may get some infected water also. So such type of shoshkattas or soap pit, they should be made around 15 feet away from your water source, drinking water source. Next. And the magic of this soap pit is that in around 1970, 2017, there was no water in my hospital. I have to close my IPD for a few days. Then I used to take water tanker from Nagarpalika and then use it for the hospital. But now, since I have made such type of soap pits, I have no problem of water in my hospital. I have a 15-bedded indoor, but there are coolers. We are using water coolers, air coolers, but there is no problem of water since last 3 to 4 years. This is the way how you make it. It is a very different topic. I will have to cover fast because only 20 minutes are allotted. Next. And now the major concern is how we can utilize our roof water, because it's a very easiest water which is available. Water falls on our roof, and we want to percolate in our well or bore well. When we go traditionally, we make a soap pit like I show in the earlier slide. There is a dale of 8 by 8 by 8. you put some amount of stones inside, some wreath and some sand, some charcoal, and then you put that water on your terrace directly into the that soak pit. This the rainwater, you all know, it is a very clean and very good water, very easily available water. So when you make these soak pits for particularly rainwater, they should be nearer as to your water source. As I earlier told, the soak pit we make for wastewater, they should be around 15 to 20 feet away from your water source. But when we harvest rainwater, the soak pit should be as near as possible as to your water source. But many of the times we utilize our land, we make pavement on all around. अब हमारे सबके हॉस्पिटल के आजू बाजू में पूरे पेवमेंट्स लगे हैं, हमारे घर में भी हम थोड़ा सा लॉन लगाते हैं, बाकी we make it covered with all concrete. So and in big cities, you know what is the cost of 8 by 8 by 8 feet. So people are not ready to make soak pits, and when we percolate water to the soak pits, you should know only 30 to 40% of water it percolates in your water source, and around remaining 70% it goes to other water sources nearby. Though it is a very important activity, when we think when I am harvesting water from my terrace, it should 100% it should go to my water source, and I will not have to spend my land also. So we have made a filter. It is the picture you are seeing is a rainwater harvesting filter. It is an indigenous filter made by me and my group here. And next slide, please. So this is the assembly of pipes, and in this pipe we are using particularly gravitational force, mesh, pebbles, activated charcoals, and high density foam. You must be thinking, when rainwater is so much clean, what is the need of what is the need of cleaning and getting filtered? You all must be knowing that there are so many environmental pollutants like arsenic, fluoride, which are coming from the industries and from the environment, from our smokes from our vehicles. So these all things has to be filtered, because when we are putting in water in the water sources in the ground, these are the very clean sources, and when you pour some infected water in these deep water sources or aquifers, the whole aquifer will get spoiled. When you put water in your well, which is 30-40 feet, it is all right. You can clean that well, you can take out that water, you can put some bleaching powder and all. But when you are thinking of harvesting water in or putting the water in the bore well, the water should be very clean, because I have already told this is the very precious water which is there from 200-300 years, or it is lying over there, and when you are taking out it, you must put a clean and good water inside. So all these filtering media are needed there. Next slide. So this water goes from your roof to this filter, and then you can put directly in your well or borewell. The advantage of this filter is that you don't need any kind of land, any kind of trenches, any kind of dale over there, and it is a wall mounted filter. You can directly put on your wall and can transfer water to your borewell. It is easily cleanable. We have some project report also that we can provide you, and this we are providing to the people on no loss no profit basis. And you must be knowing that when you are having a slab or your terrace area of 1000 square feet, and in our Vidarbha region the annual rainfall is around 1100 millimeter or 1000 to 900 to 1100, you will be surprised that in a single rainy season you can harvest about 80 to 90,000 liter of water in a single season in this well or borewell. Next. Through this
So the time limit is exceeding.
Yes,
Excuse me.
I am completing it. So this is the filter we are using. This is the way we do it. Next slide, please. This filter we have got certified from the authorities. Next. These are few precautions you have to take. Next. Next, please. So I'm thankful to all of you for hearing patiently, though it is a very vast topic. It will take around, I speak on this topic about 2 to 3 hours, and but it is a very important topic. We are almost know, but at least we can do from today is we should start using water judiciously. We should start thinking of every drop when we use water, and from day one or they ask we should start doing some rainwater harvesting activities so we can preserve water for ourselves and for our generations to come, because by 2040 about 80% of the world's population will be having a very big issue of clean drinking water. Thank you very much.
Pavde sir, you made us aware that water conservation is need of us and need of our Mother Earth. Now, the next topic is Child Psychiatry in Pediatric Practice by Dr. Preetham Chandak. Speaker is Dr. Preetham Chandak. He is MBBS, MD Psychiatry. He is member of APA, member of EPA, member of ACAMH UK, and his fellowship in child and adolescent psychiatry from London. He has done diploma in child play therapy from London. He is clinical fellow, child and counselor, director and chief consultant, Synapse Mind Care and Child Development Center, Nagpur. So welcome Dr. Preetham Chandak.
I'm audible?
Yeah.
Just one sec. The screen is visible to everyone?
Yes, sir.
Yes, sir. Okay. So, very good afternoon again on a scorching sunny day in Vidarbha itself. So, myself, Dr. Preetham Chandak. First of all, I'd like to thank Team IMA for giving me this opportunity, and I'd like to congratulate them for conducting such a wonderful CME, because as we are growing as an evidence-based medicine, the licensing between different fields, different pathy is need of the hour, and definitely it is a wonderful that they have covered all the things like different pathies and everything. So definitely it is a wonderful opportunity to speak. So yes, coming to child psychiatry in pediatric practice. Again, as a child psychiatrist, we can say this 2 years of COVID has been a blessing in disguise for all of us. The way everyone has seen in their OPD how behavioral issues in the child has increased, repeated complaints from parents and everything. So definitely, considering the Sawa crore population in our India, definitely if we consider about the mental health statistics in child and adolescent population, nearly 50 million Indian children suffer from mental health disorders. And according to the WHO report, which has been published few months back, this number will going to increase. In fact, if we go about the overall mental health perspective in India also, whether it's child and adolescent, it has been shown that 50% of the mental health issues arise below the age of 14 years, and they are preventable. So again, early diagnosis, early evaluation, and early prevention stands the key over here. Looking at the different statistics which has been mentioned in various studies conducted across various institutions and at national level also, the overall prevalence of child and adolescent mental health issues are very huge. If we come on to the average of it also, so 12.5 to 16.5 is a very huge number. If we say by otherwise also, if we go by some other illnesses also, it far exceeds the number of mental health issues. And definitely every one of us, particularly the pediatrician population, are the first point of contact for any for any pediatric issue, whether it might be some physical and behavioral issues. So having that vision or seeing up from the things is really important. So definitely coming to the, I like to share some 2-3 cases over here that will give you a broader insight how important is managing the behavioral issues and how important this topic is becoming nowadays with the advancing overall the diagnosis, prognosis and everything. So the first case is a 10-year-old boy who was a known case of seizure disorder, well-maintained, seizure-free since last 1 year, was brought to a pediatrician with some typical complaints of extreme hyperactivity, not sitting at one place, roaming here and there in the house. He was having poor attention span, poor concentration, repeated complaints from the school teachers कि आपका बच्चा बैठता ही नहीं है, he is disturbing the whole class, he is not paying attention, he has incomplete books है और ये चीजें, with associated with irritability, hitting his younger sibling. कभी भी कॉलोनी में सर खेलने जाता है तो झगड़ा करके आता है, कॉलोनी वाले भी बच्चे के पेरेंट्स बोलते हैं कि आपके बच्चे को हमारे बच्चों के साथ खेलने मत दीजिए, एंड विद डिस्टर्ब स्लीप एंड एपेटाइट, नॉट able to sleep properly, mid-night awakening and everything. So looking at this picture, the pediatrician considered it कि ये तो यार clinical signs and symptoms of clear-cut ADHD लग रहे हैं with decreased attention span, hyperactivity, repeated complaints from the school, and he was started on methylphenidate, Inspiral. Again, as the things were progressing, after 20 days or 25 days, the parents again took the child to the pediatrician with complaints of कि सर इसमें आराम तो कुछ नहीं पड़ा है लेकिन बहुत ज़्यादा बढ़ गया है, and all these things were exacerbated like anything. So he was referred to me with all these chief complaints and the background history of everything. On detailed clinical evaluation and on detailed clinical history, when I took the history, it was found that when he was 8 years old, during an examination of his school and 15-20 days before that, he had some kind of depressive features as well. It was associated with school withdrawal, मुझे exam नहीं देनी है, repeatedly crying episodes. He was not interested in playing the things and everything. So definitely all these things were suggestive of a depressive episode in the past, and with this clinical history, the diagnosis changes on completely. So again, it was changed or revised to, it was a clear-cut case of a bipolar mood disorder with the child being currently in the manic phase. So again, it is an important thing so that every behavioral issue is not ADHD. Detailed clinical evaluation and history definitely helps in, because starting on a patient on stimulant definitely exacerbates the symptom if the patient is having mood disorder. Coming to the second case, which was referred to a pediatrician first, and a 12-year-old girl was brought with the complaints of school withdrawal. सर इसको स्कूल नहीं जाना है, इसका पढ़ाई में बिल्कुल मन नहीं लगता है, स्कूल से अगर सर आप इसके जो भी एग्जाम्स रिसेंटली हुए हैं, पहले तो बहुत अच्छी थी, अच्छे ग्रेड्स आते थे ऐसा स्कूल टीचर्स बोलते थे, लेकिन अब कंसिस्टेंटली लो ग्रेड्स आ रहे हैं, बाकी जो एक्टिविटीज है सर वो बहुत अच्छी है, उसको डांस करना पसंद है, उसका म्यूजिक क्लास हमने लगाया है, वहां जाती है, कॉलोनी के बाकी बच्चों के साथ खेलती है, लेकिन पढ़ाई के वक्त बोलो तो सर दिक्कतें होती है. The things it was associated with disturbed sleep and appetite. So again, the IQ assessment was advised by the pediatrician and came to be normal. Considering it as a case of depressive disorder, she was started on escitalopram, commonly prescribed 1-hexapro 5 milligram, with further no improvement in the symptoms, and the parents repeatedly coming with the same symptom and same etiology and same clinical signs. She was referred for detailed evaluation. on evaluation and understanding all the symptoms and everything, what we always follow a kind of a basic worksheet kind of pattern. So on basic evaluation, she was not able to read or comprehend a single paragraph from a storybook of Akbar Birbal. When she was asked to write few sentences about her school, there was clear-cut repeated mistakes in spelling of school, teacher, ground, friends. Yeah, she was not able to solve a normal math problem, which is expected. A 12-year-old studying in 6th standard should be able to do basic addition, subtraction, division, and mistakes in basic spelling, what everyone like beautiful, watermelon, and everything. So again, learning disability assessment was advised by me, and it was suggested.
Probably has lots of connectivity.
I think probably. Prakash, can you call him?
Yeah, we keep a call.
Okay, thank you.
It's really, there's lots of connections. It's really again. We wish we'll call Dr. Sachin Paul and Dr. Amin sir again. They got a very good material. And the topics are so nice and useful to us. Dr. Sachin, are you there?
Yes, sir. Yes, I am there. Yes, I am there.
And we didn't know that you can speak for 3 hours.
Yes, sir.
We didn't know that you can speak for 3 hours on the topic.
Yes, yes, yes. It is a very vast topic because rainwater harvesting, conservation, there are so many issues, and every topic needs about 1 to half an hour.
Dr. Minal sir, you had given some suggestion about the PVC pipe. Dr. Minal sir.
Yes.
Now, Amin sir, are you there?
Yeah, definitely.
You had given some suggestion in the chat box.
Yeah. I was just suggesting because even the PVC pipe, it adds to the pollution and plastic particles into the water.
It's a very good question, sir, you have asked, and we also, but actually nowadays people are very much concerned about cost also. I will tell you, this unit we are providing at the cost of 3,500 rupees. And if the people are not spending, we are giving them our design. It is a patented design in my name. We give it and ask them to make it and do it at least. Do something to harvest the water. And the second issue, as I already replied to you, but this GI pipe over the period they get corrosive. And the ferric level of the water it increases, which it goes above recommended limit. So many of the iron toxicities, fluoride toxicities, they are more in our region. So we use this PVC pipe. It is cheaper, and though it is not environment friendly, but it is the good source for this kind of units.
Yeah, plastics are always used because they are cheaper. So that is one.
Yeah. And in India, the cost
the GI pipes are concerned, they good quality of GI pipes usually takes around.
Yeah. But it will cost much.
Yeah, it costs much. Definitely, it costs much.
And that filter you have to open many times in a year. There is one cleaning wall, and you have to pour water through it so that your whole media gets clean.
Yes.
I think Dr. Chandak has joined. I will stop. Thank you.
The screen is visible everywhere.
Prakash will also screen.
Hello. I'm audible.
But we'll also screen. Screen is visible, but your voice is not so clear. Is there a connectivity issue?
I'm audible right now.
No, sir, there is a voice clutter. No, sir.
Just 1 second.
So the voice is breaking.
Yeah, just 1 second. Now,
No, sir.
yeah. Hello. Hello.
Yes, sir, you're audible right now.
Yeah, I'm audible.
Yes, sir.
Okay, okay. Extremely sorry for the technical glitch. So again, as I was describing, she was considered as a case of depressive disorder and was started on the above medicine, but with no improvement, she was referred to me on basic evaluation. What we did, she was Yeah, so on learning disability assessment was advised for the girl, and it was fine that she had disability in all the domains. Dyslexia was clearly evident, dysgraphia was seen, and dyscalculia. So the diagnosis was revised again to learning disability with secondary depressive features. Whenever we see this sort of cases, again, medications have a very less role in this sort of cases. It's more kind of a behavioral approach that we have to advise. It was a remedial education structural program was planned for her, and gradual improvement was perceived with almost no symptoms at the end of 3 months. So definitely judging everything on the basis of clinical symptoms or the symptomatology with the patients persists, we tend to miss majority of the things in that particular context, and that might lead to guarded prognosis or persistent in the symptom. Again, coming to a case, a 14-year-old boy from rural background was on regular follow-up with his local pediatrician and was brought repeatedly, like in every 15 days, every 20 days, with the complaints of की सर हा बसतच नाही बिलकुल बाजूच्या पोरांना त्रास देतो कधी कधी होटिंग मारतो त्यांना पाचवी येत नाही शिव्या पण देतो स्वतःची काळजी त्याला घेता येत नाही आणि कधी एकटाच बसून हसत राहतो सो विथ ऑल दीज थिंग्स इन बॅकग्राउंड पेशंट वॉज रेफर्ड to again higher center for pediatric consultation, and with this kind of features what was mentioned like extreme hyperactivity, not sitting at one place, and he was getting repeated complaints from the school and everything. Again, the diagnosis was kept as ADHD, and at this time he was tried on risperidone for almost a year, and there was no improvement in the child, and patient was further referred with aggravation of all those symptoms to me. After detailed history and clinical evaluation of the patient, he was advised to undergo clinical psychological testing, what we call as IQ assessment, as everyone is aware of, and the Rorschach test, which generally gives a overall idea about the behavioral aspect of the person, and as well as what are the things going on at the background as well. So the result of both the tests confirmed the provisional diagnosis which I had kept in my mind, that is, he was a case of IDD, which was mild. His IQ was something around 75 or 73, with early onset psychosis, and with the overall duration of his illness, like 4 to 5 years, he was considered as a case of chronic schizophrenia. The patient was shifted on clozapine and is currently well maintained on the same. Now, coming to his IDD part, vocational training was initiated because with mild IDD, it's difficult to continue his schooling and learning things. And currently, because he's currently under our therapy program, and currently he has achieved the level of at least doing his activities of daily living by self. So definitely all these things somewhere down the line highlight the issue that behavioral aspect again plays a very important role, and having just the overlooking of the symptoms and keeping the diagnosis at many times doesn't do a positive thing for the patient, rather than it lands up into harming him, and aggravation of symptoms are prominent in this kind of thing. So the take home message from all the things what I have mentioned is the spectrum of behavioral issues or the symptoms which the patient or the family members report doesn't every time means कि it is restricted to ADHD only, कि अगर चंचलता है एक जगह पे नहीं बैठता है तो अपन directly ADHD बोलते हैं, we start the treatment accordingly. This is not the case. There lies a big range or a big spectrum of underlying mental health issues, which majority of the time goes unnoticed, and that can hamper the overall future of the child. And again, long-standing cases can turn into a chronic case, and again the treatment and everything goes difficult. So as far as the behavioral issues are concerned, every one of us should be sensitized about the different aspects of behavioral problems or behavioral symptoms in the child. Early identification and most importantly, detailed clinical history forms the key over here. Timely referral and proper intervention can drastically change the prognosis and most importantly, reduce the caregiver burden. Like teaching a child with so much of hyperactivity, with irritability, great for 1 year, you can just consider the burden, the caregiver, and overall the shaming and everything which happens in the rural community. So definitely all these things play a very bigger role, and with the licensing facilities are available now, so we should always have other things in background, and we should again think of how we can improve the life of the patient and caregiver. So again, I'd like to thank Team IIP for giving me this opportunity and able to give me the platform to present my work in front of you. Thank you once again, and extremely sorry for the technical glitch. Over to you, ma'am.
Thank you so much, sir. The quote is like, it's never too late to work hard towards being healthiest you. So it has been proved right after your lecture. Now, I would request Dr.
Sir.
I would request, I'm sorry for this. I would request Dr. Bhupesh Bhon sir, who's MBBS DCH Director at Farizat Hospital, Amravati. Director at Farizat Hospital, Amravati, EB member IIT Maharashtra 2022 to 2023, ex-president IIT Amravati branch, organizing chairman of first Maha IAP sport. So I request Dr. Bhupesh Pon sir to please take the charge and introduce the panelists. Thank you.
Unmute yourself, Dr. Bhupesh. And if more than one devices there, mute them. Otherwise, there will be echo.
Hello, I am audible. Yeah. Hello, good afternoon, everyone. Thanks, Arpita, for the kind introduction. After I think it is the last session from today's CME. After listening all academic words and different thoughts and different subjects from all the eminent speakers, now we are going to discuss a panel discussion on perinatal care. As we know, for the future generation, for getting a bright future generation, there are important role from parents. And we know from Mahabharata that Abhimanyu has learned a lot from in utero. So like that, the after mother gynecologist obstetrician is the foremost important person who take the responsibility for getting a bright and successful future of life, and as well the pediatrician has a major role in that. So accordingly, today's subject is perinatal care. For that, we have four eminent panelists. Four panelists, two are obstetrician and two are pediatrician and neonatologist. Slide, second slide. Today's first panelist is Dr. Nilima Adak Thakre Madam. Madam is a practicing obstetrician and gynecologist at Amravati since 2008. Madam is the immediate past president Amravati Ubijaya Society in 21-22, where there was a corona pandemic, and Madam has done a lot of work and got prizes at state and national level. Madam is also Maharashtra State Coordinator of Foxy Gynecology Oncology Committee in 21-22. As well, she is the Treasurer State Conference 2020, Organizing Secretary in Zonal Conference AMOGS in 2016, Joint Treasurer State AMOGS Conference 2005 and Zonal Coordinator in 2016 and 18. Madam has received a prestigious Shaileja Chaudhary Award for Academic Excellence and Socially Active Member of Amravati Ubijaya Society in the year 2019. Madam was invited as a faculty at conference and CMEs and social awareness program in school and colleges. Madam has published different articles in Foxy and Emojias journals and souvenirs. Has special interest in obstetric and adolescent healthcare. She is a well-known popular gynecologist and obstetrician in Amravati. As well, she is a very good mother, wife, and a good friend. Our next panelist, Dr. Anita Bobde Madam. Madam is MBBS MD OBGY from GMC Nagpur. Currently, Madam is the Secretary of OBGY Society Amravati branch. And in current year, Madam has planned a different activities in association with IIP Amravati. Madam is consultant gynecologist at Top Care Hospital, Rathinagar, Amravati since last 20 years. Next, our eminent panelist, Dr. Abhay Rathod. He is MBBS DCH DNB. He has done his MBBS from GMC Nagpur. DCH in PDMMC Amravati, DNB KEM Pune under the guidance of Dr. Umesh Vaidya sir. He has worked as a senior registrar at Ratna Hospital Pune under Dr. Sandeep Kadam sir. He worked as a consultant pediatric intensivist and neonatologist at the famous Dr. Murthy Hospital Amravati for 6 years. And now currently he is the owner and director of First Child Kriti Care at Chandrapur. He is also a well-known personality for his fitness, passion for cycle, and his cricket. And our fourth panelist is Dr. Suraj Rathi. He is MBBS from GMC Nagpur, DCH Nair Hospital Mumbai, DNB from Cooper Hospital Mumbai. He is a consultant pediatrician in SNCU at District Hospital Amravati and pediatrician at Parijat Hospital Amravati. He has experience for more than 7 years in handling critical neonates and pediatric cases. He is surviving the baby less than 700 grams at SNCU Amravati. I welcome all the four panelists of IIT Amravati and for today's CME. Good evening, everyone, and good evening all the respected seniors which are present for today's CME. Now we will going to start the today's panel discussion. As we know, there are different cases and gynecology, obstetrician and pediatrician has play a major role before the delivery of the babies. So what are the case scenario where prenatal counseling by pediatrician is necessary in the thought of obstetrician? So I will like to ask Dr. Nilima Thakre madam, what
Thank
is
you,
the role in pediatrician?
Thank you, Dr. Bhupesh. At the outset, I would like to thank Team IAP, Dr. Satish Agrawal sir as a convener of this program, and Dr. Bhupesh Bund for involving me in this grand event today since morning. Coming to the question, in this era when we are practicing, it is very necessary that the pediatrician should be involved in each and every consultation. And basically, when prenatal counseling is needed, it should be done in cases when the mother has carried a baby which had congenital anomalies in the past. She has aborted a baby which was having some congenital anomalies. Then she had some undue miscarriages or IUDs, intrauterine demises, in her previous pregnancies, and what the reason was not known. Then she has she has given birth to a child who has suffered from some anomalies but were not detected in the antenatal period, and the child is still handicapped or suffering from it. When this mother, in both the three cases, when this mother is expecting a child or when she is already pregnant, she should, her gynecologist, it is a duty on the part that she should send her to a pediatrician so that she is properly counseled, and she should be she should very well know that will she carry such a baby again in her coming pregnancy. So the babies who are genetically suffered in the last mothers who had the babies who genetically suffered, then the handicapped babies, then undue miscarriages, intrauterine demise, all these mothers should be guided for the prenatal counseling. Then if the mother is suffering from some comorbidities like diabetes mellitus, hypothyroidism, or she's suffering from preeclampsia, toxemia, IUGR babies, very low birth weight baby she's carrying. Then regarding this also, when we are living in an era of CPA and medical legal cases are going so much high on all doctors. So in this era also, if the mother is found to have some signs of eclampsia, she's on some drugs, if she is hypothyroid, hyperthyroid, or she is suffering from diabetes mellitus, GDM, gestational diabetes mellitus, and the fetus is bound to get some problem after the birth or intranatally also. So such mothers should also be referred to the pediatrician for proper counseling. And what will be the outcome of the babies at the end, the mother should be properly been aware of, and better if the counseling is done by the neonatologist. So basically, these are the situations where we should refer the mother to for counseling. Anybody can add?
Yes, madam has told which diseases and which conditions obstetrician should refer the parents for pediatrician and counsel and take the information about the diseases or the morbid condition and the complication which we are getting. on this issue, Dr. Abhay, you will like to give some comments. Dr. Abhay?
Am I audible?
Yes, yes.
Thank you, Yogesh sir. I totally agree with Nilima madam, but basically you cannot deny, you cannot disagree with gynecologists anytime in your life because you're a pediatrician. You have to agree with the gynecologist always. But with the development, coming to the topic, I will just say the development of this prenatal ultrasound and fetal medicine, lots of things are going to we are catching up earlier. So right now the role of pediatrician was earlier, was after the birth, but now it has become earlier because the basic thing which is difficult after birth is to explain the parents. More or less the things which has happened during the antenatal period, there's a birth defect which is diagnosed, to explain them after the birth is difficult. Why pediatricians are needed before birth is that you have to develop. You cannot tell a parent after birth that आपका बच्चा ठीक नहीं है, suddenly इसको ये होने वाला है. There has to be prenatal counseling with pediatrician also, because it helps to develop a rapport or a trust with the parents that they know the pediatrician, and after the birth the baby is going to get taken proper care of in a proper NICU. You can explain prenatally only that your baby is going to have this kind of birth defects, this kind of problems, which we can handle this way or that way. You have to mentally prepare them for the coming problems basically. That's why we just wish, as a pediatrician, I wish if you are involved in a prenatal counseling beforehand, before birth, only major important thing is counseling. We cannot avoid the birth defects, but you can also involve a pediatric surgeon if there is a surgical defect. You can also involve a pediatric cardiologist if there is a cardiac defect, because they can explain it in a better way to the parents, and they are well prepared, because pregnancy is an emotional thing for mother. She's only focused on the baby. Gynecologist is totally busy in taking care of baby and the mother. At that time, when the pediatrician has the responsibility to do the counseling, so they can handle their parents, the father, who can take proper decisions after delivery. That's why I feel important somewhere and somehow pediatricians should be involved in prenatal counseling in such scenarios. Like if we have a scenario, if you have a preterm baby can develop many complications after birth. So at that time, many decisions are to be taken very fastly. So if we are able to explain the parents, because there are some pregnancies which are preterm which cannot be avoided, as gynecologist obstetrician might know. Some are inevitably, they are going to happen preterm. So that's why we have to explain the parents at that time. You have to take such decisions after birth. We have to just deliver the baby. Baby might have a respiratory distress, might have apnea, might require oxygen, might have to shift to NICU properly, might have to give surfactant, this kind of treatments which are not able to explain, which we will not be able to explain, because the golden hour, the timing, we know as a pediatrician, after the delivery of a preterm baby or any emergency, the baby has not died, decisions have to be taken very fast, very prompt, and very right away. You have to, with that time we don't have the time to discuss with the parents. That's why I feel in this condition, as madam said, pediatricians should be involved prenatally, so that the rapport and the communication is proper, and the decisions in for the baby can be taken very fastly and very abrupt. Thank you. That's what I want to say.
Yes, very rightly said, Abhay. Every child is precious and every mother is precious for everyone. And for that, the mental preparation is must. And our purpose of doing this counseling with pediatrician and obstetrician is mentally preparation, that the further complication for in parents, the social psychosocial behavior changes, that they suddenly see any complications. So we can avoid all these things, and we can go smoothly for further care. So it both the panels have broadly simply. Now, next question is our uh, early low birth weight babies. Those babies, we have the weight less than 1 kg. These are physiologically immature and extremely sensitive to the small changes. So we have to make the practice and follow the uniformity and protocols for treating these ELBW babies, so that we should get a better outcome and in presently and in future also. So I will like to ask what the prenatal consideration and consultations are necessary in case scenario of ELBW babies. Dr. Anita Bobde madam will highlight on this. Hello.
Ma'am, are you there?
Hello.
Yes, she's
Yes.
there.
Yes.
Hello.
Yes, madam, you are audible.
Thank you, Bhupesh Bond sir, Dr. Satish Agrawal sir, and team IIP. Nice question you have asked. Expectant mothers can significantly reduce the risk of having very low birth babies if they maintain good nutrition and proper prenatal care throughout the pregnancy. Two major causes for low birth weight in newborns are premature birth and IUGR. IUGR is a condition in which the fetus experiences poor growth in the womb, often due to poor maternal nutrition. So, the good news is only the very small percentage of newborns are born extremely birth weight babies. Causes of low birth weight is maternal age, extreme below 17, about 35, multiple pregnancies, poor nutrition, birth defects, maternal and fetal infections such as torch infections, and if the expectant mother is suffering from medical problems such as diabetes or high blood pressure, uterine and cervical abnormalities can also explain the low birth weight deliveries. So, the tips to lower your risk of having a lower baby: early prenatal care. I think rather than prenatal care, I will ask the patient to have preconceptional counseling. Am I audible?
Yes, yes.
Am I?
Yes, ma'am.
Preconceptional counseling and family planning, supplementation of folic acids, correction of any anemia. Hello, correction of any anemia, detection of any medical problems and its control and proper treatment before pregnancy. If there are, as told by Nilima madam, if there is history of bad obstetric history, then genetic counseling and all the other factors. We will ask the patient for significant lifestyle changes, and pre-existing medical illnesses should be kept under control. We will ask the patient for healthy weight gain and good nutrition. So the survival rate of a very low birth weight infants have improved significantly with more advanced neonatal care. Hello.
Yes, ma'am. Yes.
You're audible, ma'am. You're audible.
Okay. Recently, in Parisat Hospital, I have a very nice experience. I delivered a baby with cardiac problem. Prenatal counseling with Dr. Manisha. I shipped the baby to the Parisat Hospital with cardiac problem. They immediately consult the cardiologist, shipped the baby to the Nagpur, and the baby was healthy now, 3 months old. Yes, you remember, Bhupesh?
Yes,
This
yes,
patient
yes, madam.
with cardiac
Yes,
problem, aortic.
Yes, madam.
Very difficult case. She had lost her first baby. Second was IUD. First stillbirth, second iodine, third baby was having major cardiac problems. With the prenatal counseling, we saved that baby. Have you remembered this case?
Yes, sir.
Can you enlighten on this to the audience? How you have managed this case? Prenatal counseling and postnatally?
Yes,
Hello?
madam. Yes, madam. Yes. Actually, that case was handled by Dr. Kasturi madam, which was here consultant at Faizad Hospital. Madam has taken all the history about the previously pregnancies, and madam counseled regarding the present situation to the parents after birth. These issues came. And if this came and if we are there is some scenario ki we can manage here, not and these complications increases by hours also. So immediately we will take care in the here NICU, and if there is some operative changes or some intervention will require, that cannot happen immediately at Amravati. So we will ship that baby in Nagpur, and we'll treat before going the baby will end up in any failure. So in that case, parents came before the delivery of the baby, and with association with obstetrician and a pediatrician, they counsel they have increased they motivate them and increase their faith, and a baby can survive. So they get motivated. So they have done all these efforts after the birth immediately, because of they know everything before the delivery of the baby. Yes, ma'am. You want to add something?
No, just the good. Hello.
Yes, ma'am.
Hello.
Yes, ma'am. You are audible.
This thing is very much important. Prenatal
Yes.
counseling is very much important.
Now it is a parental education that madam has covered. In that way, also know the pediatrician view or determine the parental wishes when viability is questionable and defining the limits of parental choice. In some cases, we have to take the decision. So if we educate or we counsel or we give the information to the parents before delivery, so in that case, what will be the situation? What should we counsel to the parents before the delivery? So Dr. Abhay will highlights on this. Dr. Abhay?
Hello. Hello.
Yes, yes, you are audible.
We are talking about viability, right?
Yes.
Okay. So it's a very tricky for a pediatrician, gynecologist. Viability, actual definition, I'll go theoretically first. Theoretically, WHO defines viability as the baby, as the fetus who has attained 22 weeks of gestation or is at least 500 gram in weight or at least 25 grams in length, 25 centimeters in length. This is actual definition of viability. But now viability differs. This, you cannot generalize this statement to every baby or every fetus, because a definition of limits of viability are very tricky. It depends on social and medical conditions in which the infant or baby is born, even in which area or country it is born. Because it is surprising to know, in a developing country, a baby which is less than 28 weeks of gestation, still we have the mortality rate of around 90 to 95%. On contrary, in developed countries, babies with 20 to 25 weeks of gestation are now attaining the possibility of going home without morbidities around 90%. That's the difference. We are still at a mortality rate as a developing country with 90%. They are attaining the positivity of 90% of sending the babies of 20 to 25 weeks home. So with decreasing age, the mortality and the long-term and short-term morbidity of the infant increases basically. And more in preterms, basically, how do we define? I think there is no way to define what are the limits of viability. Either in a normal language, what we can say, if you want to define a baby which has gained a gestational age or a birth weight with which it is able to survive after coming out of the uterus, or a baby with a gestational age or birth weight which we has attained, and it can go, which has the possibility of more than 50% to go out to get discharged from the hospital. This is the way I'll simplify it. कि जो बेबी जो fetus होता है, that can survive on his own uterus के बाहर आने के बाद basically. But now the part is, viability is tricky and the decision is not yours. You cannot be God as a pediatrician or any doctor to tell the patient ये बच्चा बचेगा या नहीं बचेगा, because neonates are very tricky, very miraculous. We have seen in our practice neonates just coming out of any having a heavy stormy NICU stay for 2 and 3 months and coming out very nicely after that. So for that, here what viability and the parents' decision comes in the matter. What I feel, likewise, we just discussed in the previous question regarding prenatal counseling. If we have inevitable preterm delivery that is going to happen with certain patient, which is unfortunate, but is going to happen, we cannot help that. So that time we can explain the parents. That time we can explain the parents according to the age of gestation. What is the viability? It also depends what kind of intensive care, tertiary intensive care, NICU care you have. You have the setup or not. Can you arrange the setup for the baby as a pediatrician in terms of that baby's gestational age and weight? What is the antenatal USG ultrasound scans of the baby? What is the growing weight of the baby? What is antenatal weight of the baby? These kind of things we have to explain the parents in their voices. They have to take a decision afterwards, because I have seen what's most important. Last 10 years which I'm working, I work with Bhupesh sir also, many Murke sir in pediatrician. What most important is in treating a neonatal preterm patient which has a stay of around 1.5 months is counseling. You have to talk to the parents morning and evening, because they don't know what is going on in that glass door or glass cabin, because they are just peeping out the window and just asking to you. Right now in normal patients patient के relative उनके पास रहते हैं, they talk to the patient. In NICU is not like, and mother is already disturbed, मेरा baby मेरे साथ नहीं है, what is happening to him? Father is already disturbed, how to explain my wife is already difficult to explain anybody's wife, but father is already disturbed, how to explain the lady, my mother, she's already bothered. So that time our counseling helps, how to treat the neonatal patient helps. How can I explain a parent that should that baby survive or not? No, I will not explain a patient what is going to happen with that neonate. Right now I'm having a 650-gram baby. I have told the parents that I will tell you his condition every 12 hourly. I don't know what is going to happen tomorrow morning. I cannot be sure. The patient might bleed out the night, can go into respiratory failure at the night, can go into sudden shock. We just 660 grammer. And the thing which I always say, कि ये बच्चा 2 महीना 2.5 महीना छोटा है, the growth which mother can give in her womb for next 2.5 months, we are just trying to attain that in NICU, which is highly not possible. So that's why I have to explain the parent. Daily I'm going to tell you. And other major factor comes is very economical factors, which is NICU baby, treating a baby in NICU as a preterm is highly costly affair. It's not, I'm not blaming doctors for this, but it's costly. Setup is costly, the services are costly, the medicines are costly, and the baby requires that much all the time. So they have to pay, you have to work. Even the pediatrician or neonatologist works on the toes, he cannot sleep properly many a times, baby suddenly goes into apnea. You have to explain these all things. Most important thing in terms of parents decision is they should see the doctor daily. If they are seeing the doctor daily, if you're talking to them, you develop a rapport, you can explain to them, is the baby survival or not? You can explain to them there might be CNS problems, the baby is having convulsions, if there is a CNS bleed, if the baby is having whatever, you are giving too much of oxygen, baby is requiring oxygen, that's why you're giving too much of oxygen, baby may develop an ROP. If you explain to parents in this way, then it's very easy to treat a preterm child. You cannot keep their expectations very high, but don't discourage them, because if as a developing nation we start neglecting a baby that is a preterm is not viable, not as per the definition, but as per the standards or with the way we are treating it, then we will not be able. We'll have to try to make a baby of 26 week or 600 gram survive. If we do it, then only we'll be able to explain the parents. They will have belief in you that you can do it. And these kind of things can happen in India also. And why I'm talking about India, very few centers, like I worked in Amravati, I'm working in Chandrapur right now. The huge difference of working, but there are very good hospitals. But the thing is that you have to show them that this kind of baby can go home and survive. If you don't do it, if you don't explain to them this way, if you keep discouraging them, next time nobody will bring a 600 gram or 500 gram to your NICU. This happens in periphery, it happens. Ye bacha bach hi nahi sakta. So that's why I think the viability is a very tricky. You have to explain the parents, you have to explain them, but decision is theirs. They have to take the decision and decide should they want to continue the treatment or not. That's what I want to say on this.
Yes, Abhay rightly said. Don't discourage the parents. Actually, today's era, today's NICU practices, there are a lot of facilities are available, knowledge are available, and the babies, as I previously told, every baby is precious. Now, the risk of premature deliveries and incidence of premature deliveries with change in healthy lifestyle, we have got so many babies in that situation. So if we have to encourage parents and we have to tell the outcomes for premature babies, so to motivation and to give them the assurance that this baby can survive, no one can tell 100%, but all these situation and present era and these facilities. But the major part, we will do all these things after the birth of the baby. When baby came in NICU, obstetrician referred the baby in NICU, and they are also hoping the best for that baby. But when the early, extremely low birth weight babies and all these premature babies, when their stay are not 10 days or 15 days, it is more 2 months, 2.5 months. रफली वी आर सेइंग की जेवढे दिवस बाळाचे पोटातले शिल्लक राहिलेले आहेत तेवढे दिवस बाळाला लागणार आहेत. तर या प्रकारे when we are telling like that, so 2 months, 3 months is not a short period. But when there is, we see the difference while doing this practice in NICU, when obstetrician send us parents before delivery. In some cases, they know the baby will get delivered prematurely. There are some obstetric reasons. And relative came, and when we counsel them, they are mentally prepared for that when baby is delivered. And at that time, we have not to ask them what should we do further. But when we go directly, if baby has any incidents happen and baby is delivering at 27 weeks, and then we go for the call at delivery room and baby is delivered and baby is not right. So what should go further? What should we do? And we initially we intubate the baby and we think about the babies first, and then we ask the parents, बेबी रोया नहीं है, ऐसा ऐसा इतना वेट है, क्या करना है आपको, कहाँ शिफ्ट करना है. देन दे टेक द टाइम एंड दे टेल की वी विल आस्क, कोणाचे फादर सोबत नसतात, आम्ही फोन करतो आणि सांगतो. बट ऍट दॅट टाइम द गोल्डन अवर्स वी मिस इन दॅट केस. So for the better outcome of these premature babies, and neonatologist or pediatrician role is not for giving the babies surviving baby in NICU, but they think in the line there should not be the morbidity. Baby's future should be fine, and for that also this antenatal counseling and consultation with the pediatrician and obstetrician is very much important. So as I told, today's area, our NICU facilities are increased in every district places, and in taluka places also these facilities are at a higher level. But to increase the outcome of this baby and to reduce the morbidities, there should be extreme premature infant delivered in facilities where high risk obstetric services and level 3 or 4 NICU are available. In that case, we can definitely prevent the baby's morbidity, and NICU stay we can decrease. For that, safety of the maternal in utero transfer must be weighed against the risk of transfer sick early low birth weight babies. When babies are transported in ambulance after the baby from one obstetric hospital to NICU, at that time there are more risk of hypothermia and baby not getting properly oxygen. And if baby is intubated, we brought them with tambu bag, and at that case there should be chances of pneumothorax. And if this baby, baby is transported in utero where the facilities are available by side NICU, immediately baby get intubated and baby is on ventilator, and within 10 minutes he gets surfactant. Then these 10 minutes or 15 minutes are very much important for baby's outcome. There is prenatal administration of corticosteroid. Yes, definitely we are seeing discussing on this later. And antenatal magnesium sulfate, it is a neuroprotective. That is a new, I think, observation of following those premature babies for their neurodevelopment. Magnesium sulfate are giving. In the part of prenatal consultation, pediatrician should consult with parents, and preferably it is with obstetrician present. Mostly we are obstetrician are sending relative to pediatrician, and pediatrician giving the consultation and telling the future. But if both are in same chamber and they will counsel the parents, definitely it will helpful for the parents, and it will for better outcome of this premature baby. Parental guidance regarding the expected outcome, long NICU stay, risk of the death, and disability. These 4 things should parents know, because all these 4 factors will decide what should the parent will going to do. because expected outcome no one can tell 100%, but we can give positive thought, and we can help them for think out process. Yeah, we know the long NICU stay, because after the birth, when patient came and 2 days, 3 days, there one question is most common, kitne din lagenge. But if we counsel before delivery of baby, that will give you the peace while treating this baby. And risk of death, if I explained previously, they will now ask about this question. And disability, they know. So these factors definitely help while treating the babies in NICU. As my experience, long stay, I have treated one baby for 6 months. 6 months in NICU. That parents already concealed before delivery, because they are elderly primary. Mother was 42 years and father was 48 years, and they know they will not get the baby after that. This was the last chance. So obstetrician sent the parents to me, and I have told them, but that baby has lot of complication. It takes 6 months in NICU, and 6 months in NICU while counseling these parents, it's very difficult job. But that made easy by observation, because these parents, all the things I have told them before the delivery and during this baby, when पेरेंट्स अपने को क्वेश्चन पूछते नहीं है कि कितने दिन लगेंगे, अभी कैसा रहेगा, अभी ये होगा क्या. और अगर अपन स्मूथली पेशेंट ट्रीट कर रहे हैं और एक अदर क्वेश्चन पेरेंट्स के कम होते हैं, दे हैव गिवन अवर फेथ, देन डेफिनेटली इट विल हेल्प फॉर बेबीज आउटकम. So ultimately, that counseling part, consultation part, help the baby's outcome. Potential morbidity, we know there is a chances of sepsis, apnea, and all these things. ROP, it is one of the major while surviving this baby. That thing also we should explain the parents before or while during our prenatal consultations. That helps a lot while treating the babies. And according to the National Institute of Child Health and Human Development, why should the outcome of this baby is depend on age, that is on weeks, sex. Female childs are we know armor fighters, single or double. Have they received the corticosteroids? All these things are and baby's complication in NICU. That will help to the potential morbidity. And parents' desire, as the guideline says, less 23 weeks and 400 gram, this baby can be resuscitated, but the baby is more than 25 weeks, you should resuscitate in absence of other factor. And we have to tell the parents initially that things that will help and for the better outcome of the babies. And one single prenatal consultation with obstetrician, pediatrician, and has उसका कितना फायदा होता है, कितना mental stress कम होता है, that well known by pediatrician and obstetrician when immediately we go for the delivery of the premature 27 weeks baby. That difference we got and has a very good mental peace while treating this baby. I think everyone got this point, and for all treating or handling NICU this premature baby, I think every pediatrician expecting these things from obstetrician, and pediatrician doesn't know about which baby will going or which mother has delivering the premature, but with collaboration with obstetrician, that will help us a lot. Then next, we are going to survive this baby, premature baby, and all these complicated baby. We have done prenatal counseling and everything we have done. Then next part come to the breastfeeding, which we are seeing this problem also increasing. So do you think prenatal period is important to lay the foundation of successful breastfeeding? So I will like to ask Dr. Anita Bobde madam to tell on this.
Hello.
हाँ मैडम.
Antenatal breastfeeding education is must. She should know the importance of breastfeeding prior to baby arrives. Most of the time they have other misconceptions they are unable to feed, their figure will be changed. These misconceptions should be removed. And one reason women are unable to breastfeed has to do with lack of education and knowledge about how to breastfeed. Improving pregnant women's knowledge of breastfeeding may help them to breastfeed longer. Breastfeeding is important. During antenatal visits, we should examine the patient, see for the nipples, and during during this time, most of the patients, in last 20 years practice and in last 5 years practice, most of the patients have retracted nipple, because I asked them the reason why you are having the retracted nipple, because we are wearing Hello? Hello?
Yes, madam.
Hello?
Hello. Hi, madam. Continue.
Breastfeeding education includes guidance of mother for anticipated situation and signs of effective breastfeeding problems. The benefits of breastfeeding to mother, baby, and society. These points to be noted to the or given explained to the patient. Counseling should be done. Correct positioning to help the infant latch onto the breast effectively before she delivers. Specific needs in the early days of breastfeeding. Resources for help with problems and common fear, concern, and problems and myths should be discussed during antenatal period. It is the base period. After delivery, she is exhausted. So mental preparation is must. Her prenatal education is the lay for foundation successful breastfeeding. Over to Rupesh.
Yes, madam. Yes. Yeah, madam. You are rightly said. What is the importance of this? Mental preparation is a must for that. I will like to ask Dr. Abhay, is what you get the benefit of this foundation of successful breastfeeding in antenatal period?
Yes, rightly madam said, counseling is the most effective part. And why? Because there's a word called self-efficacy. What is self-efficacy? It is the belief in his own capacity that she can execute or do the things which is required, basically. And breastfeeding is an action which has to be learned. Mostly in primary women, they are really unaware of these things. Breastfeeding is the most interfering factor in infant's health. Monitoring mother's performance and giving her a feedback of her performance of breastfeeding has known to increase the efficacy in the mothers, and they have developed the interest in learning and increase the level of performance of their home. As we know, exclusive breastfeeding babies are free from infections, they don't have diarrhea, they develop good immunity, and they have good allergic, they have good GI status and all. They have many studies which have been done around Canada, in Iran, even in Wuhan, China, where they have taken around the data of 120, 150 primary paras women. They have made a two set, one was intervention set and one was control set. The intervention set were consulted antenatally 2 times a week regarding breastfeeding, and the control set was continuously monitored with that, and they were not counseled. It was taken as a cohort study and all. That what they found at the end of the day, the interventional group, which was counseled 2 times a week before ANC, sorry, before a delivery, they have higher success rate in initiating and continuing the breastfeeding. And most importantly, what madam rightly said, they have negative things. The women who were counseled were very positive regarding the breastfeeding problems and complications which are going to arise. Likewise, what we see right now, the women who don't get actually every obstetrician right now gives everybody is counseled about breastfeeding. The somehow the mother who's not registered doesn't get, and she has the first question always arises, pehle 2 divas doodh yet nahi. We know the 2 drops are also sufficient for the baby, but mother feels doodh yet nahi. That negativity is a science. That negative reinforcement, the relative says, the mother says, the grandmother, the lady with the mother says doodh yet nahi. That creates a more negative impact on the mother. If these mothers are antenatally counseled, perinatally counseled, that breastfeeding may develop these kind of complications. You may have low milk initially, but the milk is going to come. If as ma'am rightly said, if she's having anatomical problems like cracked nipples, sore nipples, this can be tackled easily. These are the problems which are treatable. They are not like that we cannot treat these problems. So if the counseling is done, purpose of that antenatal counseling is to help patient to better understand how they can tackle the simple thing, breastfeeding. But most importantly, this breastfeeding initiation, if it is done antenatally and the counseling is properly, most of the problems of a neonatalized are survived. It reduces NICU admissions also. Even if if the preterm baby is given express breast milk earlier as a tropic feed or in a benefit, they tend to grow faster. They are free from infections. The kids in NICU or the babies in NICU which are kept for longer period, we are not able to start feeds due to some problems, due to infection and all. They take more time to survive. They take more time to come out of it. So that's why I really feel counseling to prenatal counseling increases the breastfeeding and breastfeeding self-efficacy in the mother, even in the postpartum period if they are counseling and counseled antenatally also. So counseling with mother with previously failed breastfeeding also, if they are counseling, if the mother who's a gravid at 2 and she has been failed breastfeeding in the first pregnancy and all, even if we counsel that lady or the mother antenatally during the second pregnancy, the results are better, the effects are better, and the problem is solved for everyone, for obstetrician, for pediatrician, or the baby also.
Yes,
Thank you.
Abhay, rightly said. Counseling that is very much important in cases like that, the failure of breastfeeding in previous pregnancy. Mother's motivation, counseling, information about exclusive breastfeeding, identification and appropriate treatment for breast and nipple problem, utmost important to lay the foundation of healthy future generation. Next, we have done the counseling regarding the importance of breast milk. Then if the babies who are admitted in NICU for because of any reasons, then we want the mother's own milk. Then at that case, how the care and handling of express breast milk, are there any guidelines for expression and collection and storage? Dr. Anita Bobde, madam.
Hello.
Yes, madam.
Hygiene, maintenance of hygiene. We have to teach the patient about the hygiene and the storage and how to collect. These are the three important points. And how to express the milk. We have to teach. We will have to teach, not in beforehand. We have to give her practically how to express the milk. We have to wash hands and press the areola area behind the nipple. Do not pull the nipple. Press the areolar area. Express out the milk drop by drop in a sterile container. And it should be collected and storage for storage. Hello.
Yes,
Hello.
ma'am. Yes, madam. Hello, madam. Now you are mute.
Bobde madam, unmute yourself.
Hello.
Yes, madam. You are
Please. Hello.
Yes, ma'am. You're audible.
I am unable to see all of you. Hello.
Yes, madam. You are audible.
You are visible too also, madam.
Okay. Hello.
Yes, madam. Go ahead.
मॅडम परत अनम्यूट करा तुम्हाला स्वतःला.
Problem is there.
हा अनम्यूट करा मॅडम. हा आणि तुमचा आवाज येतोय, तुम्ही दिसत पण आहात, तुम्ही बोला मॅडम.
Hello.
हा बोला मॅडम.
Expression. When the lower bed babies are shifted. Hello.
हाँ मैडम बोला ना, कंटिन्यू करा.
It is a very practical point. We have to educate the patient regarding expression of milk, how to express, how to store, collect. Okay. First thing, we have to sterile the hands, sterile the nipple area, and wash your hands with the soap. and collect the express milk in a sterile bottles. And for a working woman or for sick woman, we can store it in a freezer. Breast milk can be stored at room temperature. Hello, hello.
You are audible, madam. You are audible. Now you are muted, madam. Please unmute yourself. Unmute kara, madam. Unmute kara, madam. Bobde, madam. Unmute kara.
Hello.
Hello.
Yes, madam. Go ahead.
And storage. The milk, express breast milk can be stored at room temperature and used for next 4 hours. It can be stored in fridge and can be used for 24 hours. It should be told to the patient. Collection, store, express milk and collection and storage. I have told. Next, you can most highlight it on Bhupesh.
Yes,
Hello.
ma'am. Yes. Yes, ma'am. Yeah, rightly said, madam. Actually, if obstetrician is involved in that process of initiation of breast milk and difficulties solved by the obstetrician, there will be a lot of burden reduced from pediatrician and neonatologist side. Now we will go further. As today's we are seeing there is increasing obesity and changing lifestyle. There are we seeing the more of patient in gestational diabetes mellitus. So, is there a use of corticosteroids in gestational diabetes mellitus for lung maturity at 35 to 36.6 weeks gestation? Should corticosteroid be given in GDM? Dr. Thakre, madam, will highlight on this.
Thank you, Bhupesh. Am I audible?
Yes.
Yeah. We all know that glucocorticoids are drugs which have multiple effects on both the carbohydrate, protein, and lipid metabolism. All the three metabolism are affected, and as well as the homeostasis of the body. They are also potent anti-inflammatory and immunosuppressive molecules. One common side effect we see when we give glucocorticoids or the corticosteroids is the rise in the hyperglycemic level of the person. These drugs are used in pregnancy to accelerate the lung maturity in preterm babies. And all the obstetricians, when they have the preterm, they see that the mother is going to deliver prematurely or she has to be delivered due to some comorbidities, they take the time to give the corticosteroids. That is this antenatal corticosteroid therapy or the ACS therapy. It has proven benefits for the neonatal survival in antenatal women with threatened preterm labor, many of whom may have coexisting diabetes also. So all women with threatened preterm should receive ACS, that is the antenatal corticosteroid therapy, as per the routine obstetric practice, irrespective of the diabetic status. Exceptions will include medical conditions that may worsen the condition due to steroids. So all the hyperglycemic mothers, that all the mothers who are suffering from glucocorticoids, all the mothers who are suffering from the GDM, they if they are prone to deliver earlier, that is premature delivery is suspected in these mothers, they should be given the corticosteroid therapy, but with a vigilant monitoring. Blood glucose estimation must be done prior to the administration of ACS, that is the antenatal corticosteroid therapy. Regular, frequent fetomaternal surveillance must be estimated on indoor basis for at least 5 days after the ACS administration has been done. Frequency and the nature of monitoring required will vary with the nature of the diabetes. Medical nutritional therapy should be reinforced. In many cases, we have to monitor their nutritional levels also in all patients who are receiving the ACS, irrespective of the prior glycemic status. Then the supplementary insulin should also be added if we find that after giving the ACS therapy, the sugar level has been risen. And using a proactive approach to minimize the negative impact of the hyperglycemia upon the mother and the fetus, we should make a vigilant monitoring of these patients and get them admitted after you administer them the ACS therapy. Moreover, these patients are undoubtedly to be admitted only because they are in premature labor pains, so they are with you only. And if these GDM mothers are going to deliver in near term, then we should calculate the level of means what are the treatments under which they are managed for the GDM, because many a times in GDM we see that they are sometimes on the medical nutritional therapy, sometimes the mother are receiving the oral hypoglycemics, and sometimes many a times they are on the insulin therapy. In three of the therapies, the we can give the antenatal corticosteroid to these mothers. And in glycemic status means if it is well controlled, glycemia is there, then we can give the ACS very vigilantly. Then if the medical nutritional, if the patient is on the medical nutritional therapy, then strict monitoring of the medical nutritional therapy should be done, and patient can be also kept on insulin for further 5 days. Basal insulin level should be measured for these patients, and the challenges in management of glycemia after ACS are well documented. They should be documented because this will help you to manage the patient in future. And we see that no means all the patients don't fit in all the solutions which are available to manage these patients. An individualized approach is necessary in these cases because of the wider inter-individual and intra-individual variability noted in degree and duration of hyperglycemia after the steroid injection. Because if I am giving a steroid injection to a one person, her sugar level may vary, and if I am giving the ACS therapy to other mother, the sugar levels may vary. So it is not that this is the protocol and we should do it like this. We have to monitor each and every patient because the patients may vary. And definitely all the studies, the NICE guidelines, and they all have said that with vigilant and caution, you should give the glucocorticoid therapy to all the mothers who are supposed to deliver or who may deliver in early prematurely or between the 35 to 36 weeks, as Dr. Bhupesh has said. So if I vary with any new guidelines, because I have this much of what I've read and what I know, as we follow the guidelines, NICE guidelines. If anything different in the pediatric side, I don't know. So pediatricians can highlight it.
Yes, ma'am. Dr. Suraj Rathi, can you comment for in pediatric point of view? Dr. Suraj Rathi.
सरांचे मायक्रोफोन कनेक्टेड नाही आहे बहुतेक.
As madam has told, actually hyperinsulinemia has been linked to impaired the lung maturation. As we know, there is increased risk of respiratory distress in newborn, and there are more complications of IDM just babies. There is lung maturation can be delayed up to 10 days as compared to the normal babies, and there are 3 times increased risk of transient tachypnea of newborn, respiratory distress syndrome, and pneumothorax. As babies are near term and their weight was more than 3 kg, and baby was TT, and this case we are seeing commonly, and this baby required the NICU stay. So in that way, regularly giving this corticosteroid before 34 weeks, but in GDM in 35 to 36 weeks definitely play some role with thinking of the observation point of view, mother's condition and other complications. In next is hypothyroidism, as it is one of the most commonly seen in mothers, and those who are known hypothyroid and on complete treatment previously before the pregnancy, the outcome of that baby was very good. But there should be recognized and unrecognized hypothyroidism of mother. So I will like ask to Dr. Thakre madam, there is comparison between unrecognized or untreated hypothyroidism versus treatment taken in perspective of maternal complication and neonatal outcome.
Am I audible?
Yes, ma'am.
In this few years, there are sudden rise of many patients who are suffering from thyroid disorders. Basically, we see the hypothyroid patients a lot in the antenatal period, and many a time the tests done in the first trimester are misguiding. So we should never follow the first trimester, first time done the free T4 TSH levels, because due to the beta HCG hormone, it affects the TSH and the T3 and the T4 metabolism. So this beta HCG will give us some deranged results in the first trimester, and so the test report should be repeated in the second trimester. And basically, when we see that if the levels for our antenatal patients or the patients who are infertile, we generally take that cutoff for TSH as less than 2.5. The level of TSH should be less than 2.5. Others above 2.5 may need, or we should keep a watch on these patients. And if antenatally we are getting the levels of more than 3, then we should start with a low dose of thyroid supplementation to all these mothers. And regarding the question asked that the well-treated mothers who are suffering from the thyroid disorders will definitely have good results than the mothers who are not treated during the antenatal period for all the thyroid disorders if they are suffering from. Because untreated maternal hypothyroidism can lead to preterm births, low birth weight, and respiratory distress in neonate. Enough evidences has accumulated over the years about the role of thyroxine in normal development of the fetal brain. The presence of these specific nuclear receptors and the thyroid hormone, which was found in the fetal brain at 8 weeks of gestation. Free T4 is found in the coelomic and the amniotic fluid. And so these all evidences suggest that it is very much important that these thyroid levels, which are deranged in the antenatal period, they should be managed at a proper time with proper drugs and with proper consultation also, because they will prevent the further problems in the neonates. And all well-treated hypothyroid patients, they generally develop good fetal outcomes, and they also are managed very well if they are treated properly, because we will never face the preterm premature delivery, the sudden abruption of the placenta, which are the common findings seen in the hypothyroid mothers. So proper in any antenatal visit, first antenatal visit, the ANC profile should consist of the thyroid levels of the patient, and they should be monitored in the second and the third trimester as well as. So these thyroid supplementation are not harmful for the babies. They should be properly managed, and after till birth also, and after delivery also, till the patient's levels get normal, because this will prevent the sudden storm after the delivery. And these patients who are on the drugs should very well manage till postpartum period also. Postpartumly, they should again undergo the revised testing of all the 3 levels, and accordingly they should be managed. Regarding the neonatal assessment and the treatment, the neonatal part will be covered by the
Yes, ma'am. There is definitely a difference between the treated and untreated hypothyroidism in mothers. Yeah. Next is what is the congenital hypothyroidism screening schedule in preterm and term neonates, that Dr. Suraj Rathi will highlight on this.
Hello.
Excuse me.
Yes, you are audible. Yes, ma'am.
Dr. Bhupesh, can I take a leave because I have an emergency patient?
Yes, ma'am. Yes, thank you, madam.
Thank you so much. And very much sorry that I am not attending it fully, because it's such a nice webinar and the panel is also going so well and all are talking so means by heart. Please listening Abhay after such a long time. It's so nice.
Nice to see you, ma'am.
Yes. And I'm very much sorry because the patient is waiting since long and the webinar got prolonged.
Yes, ma'am. You can leave.
Thank you so much.
Thanks a lot, Nilima madam from IP Amravati.
Yes, sir. Thank you, sir. Thank you. And I'm sorry, sir. I have to leave.
No, madam. That work is of primary importance.
Yes, sir. Yes, sir. Thank you.
Thank you, ma'am.
Hello.
Yes, Suraj.
Am I audible, sir?
Yes. Go ahead.
Congenital hypothyroidism nowadays is a hot topic because it is a easily treatable condition, and we all know the effect of hypothyroidism and on developing brain in a neonate. So generally in term babies, as TSH surge increases immediately after birth and peaks at 6 hours and gradually decreases at 24 hours of life, and within 72 hours of life it may get normalized. So we generally do at the time of birth as a cord TSH, or after 72 hours up to 7 days for TSH in term babies. But in preterm, due to the immaturity of hypothalamo-pituitary axis, there is a term called as delayed TSH surge, which may result in false negative result. And that means the child can be hypothyroid even though its TSH can be normal at 72 hours or at birth because of delayed TSH surge. In this case, we should at least do one thing, follow one thing, that we should do its TSH level with FT3, T4 at the time of discharge. Some studies recommended at the time of 2 weeks, or if it is borderline, then at 8 weeks and 12 weeks too. And TSH level considered as positive for the preterm neonate considered to be 10 to start the therapy.
Yes, Suraj.
This is the recent schedule what I have encountered.
Yeah, yeah, we also.
Because thyroid anti-thyroid therapy, timely intervention can lead to brain maturation faster and lead to decrease in the intellectual disability, and it is a easily treatable condition. So we can treat the we can save the, and intact survival is must nowadays. It's a new terminology in our practice, because if we give intact baby to the parent, that couple will be happiest in their life. There is
Yes,
no
congenital hyperthyroidism. Yes, Suraj. It is a preventable cause of intellectual disability, and timely initiation and treatment determine the long-term outcome of the baby. Then next, that new entity we are seeing, and this complicated baby we are looking in our NICU. What is the risk for COVID-19 in lactating mother in performing the breastfeeding? Is there any risk? Can Bobli madam highlight on this? Hello?
Am I audible?
Yes, madam. Yes.
The best source of nutrition for infants and protect them against illnesses. With the limited data so far, transmission of active COVID-19 virus that can cause infection through breast milk and breastfeeding has not been detected till now. The numerous benefits of breastfeeding, the potential risks of transmission and illness associated with COVID-19.
The voice is not clear.
Or confirmed COVID-19, she should take common steps to avoid spreading the virus to her baby and can breastfeed if they wish to do so. The mother is she should continue to breastfeed while taking care. Like, so far as the virus has not been found in breastfeeding, all mothers are advised to continue breastfeeding while practicing good hygiene during feeding. This includes wear the mask during feeding, wash hands before and after touching the baby, wipe and disinfect surfaces regularly. Mothers who get coronavirus shortly before giving birth and begin breastfeeding, and those who became infected while breastfeeding, will produce immune factors in their milk to protect their baby and enhance the baby's own immune system. This means that continuing to breastfeed is the best way to fight the virus and protect your baby. Take additional hygiene measures and continue to breastfeed if you fall sick. And when mothers are too ill to breastfeed, they should seek immediate medical advice. It may still be possible to express milk and ask a non-infected member of a family to feed the baby using a clean cup or spoon. Will be even more important to follow the 3 ways at all times to keep the baby uninfected. Use a cup and spoon to feed babies with express breast milk when too sick to breastfeed. Also, the WHO recommends that mothers with suspected or confirmed COVID-19 should be encouraged to initiate or continue to breastfeed. Mothers should be counseled that the benefits of breastfeeding substantially outweigh the potential risk for transmission. Mother and infant should be enabled to remain together while rooming in throughout the day and night, and to practice skin-to-skin contact, including kangaroo mother care, especially immediately after birth and during establishment of breastfeeding, whether they or infant have suspected or confirmed COVID-19. So breastfeeding is not, it is advocated. Hello?
Yes, ma'am.
You should, the patient should breastfeed the baby. It has a beneficial effect rather than discontinuing the breastfeeding.
Yes, yes. We got the message that we can give the breastfeeding. As the Dr. Suraj has done a lot of work during COVID area in NICU, you want to add something? Dr. Suraj?
Hello.
You want to add something?
Yes, sir. As Madam has rightly pointed out, we have seen many cases in second wave of ANC cases came in second wave. And first and foremost question of mother was, मी माझ्या बाळाला दूध पाजू शकते का? The answer to is absolutely yes, as Madam rightly pointed out, as it is the first vaccine to the baby. Even before the BCG, breast milk is the first vaccine to the baby, and we all seen the touch wood, severity of the pediatric COVID is much lesser than the or neonatal COVID for that matter is much lesser than the adult COVID due to the active thymus gland in the neonates. So breast milk also has immunoglobulin A, which helps in fighting against the infectious and replication of the COVID-19 viruses. In some studies it has been proven. So it is having beneficial effect rather than the harmful effect. And other
Yes.
disadvantage of discontinuing breastfeedings, that babies are more prone for pneumonias and diarrheas, we all know. So it is always beneficial to breastfeed, but mother should follow the strict precaution, that is she should wear mask properly, hygiene should be maintained with soap and water, hand should be clean, and if she sneezes or tissue paper should be used by mother.
Yeah, all these things are important for that, and that means there is no risk for giving the breastfeeding, and it is the first vaccine for the baby.
Yes.
Then what is MISN? That we are seeing the less baby in COVID positive actively, but there is one terminology, multisystem inflammatory syndrome in neonates. What are the clinical signs, symptoms that we are seeing in NICU baby? Dr. Abhay will highlight on this, and it is the last question of this presentation.
Thank you.
Dr. Abhay.
Thank you, Bhupesh sir. As we all know, COVID has given us many troubles. The MIS is one of that. MIS is multi-system inflammatory syndrome, which usually was found in many pediatric population. We already knew that severe acute respiratory syndrome was associated with MIS in children. However, very few cases were reported in neonates. But it was not like that. It was not in neonates. Actually, maternal SARS-CoV-2 or COVID antibodies have potential to transfer transplacentally and transfer the antibodies to the neonate, which causes immune dysregulation in newborns. Newborns have very immature immune system. That's why they are affected very badly. There are large cohort studies which have shown that these COVID antibodies can travel transplacentally. Actually, clinically, and there are no specific terminologies as of I know yet regarding MIS in neonates, basically. But somewhere it is defined as early MIS and late MIS. Early MIS in neonates is less than 24 hours, 72 hours, in which the mother is positive and the antibodies are transferred transplacentally to the newborns. Somewhere there is late MIS, which is more than 72 hours. This is neonate who has acquired COVID himself, not from the mother. And clinically, these kids present with fever. Fever is the fever is the presenting symptom most of the times. They may present as early as second or third day, along with respiratory distress. The encephalopathy, they have convulsions, they present in shock, they have multi-organ dysfunction, they have significant tachycardia. Term infants tend to show a milder disease, but preterm infants have a severe disease, and mostly with cardiac dysfunctioning. Usually, for this, you should have a high index of suspicion. You have to rule out other conditions which mimic like this disease, like birth asphyxia and all. So basically, to diagnose MIS in newborns, you should have the proper history. If you go lab wise, you have to go for a CBC. The inflammatory markers like CBCRP, procalcitonin, D-dimer are very high. You have to go for ferritin and IL-6 level if there is a cytokine storm. If you have symptoms of signs and symptoms of tachycardia, you have to go for cardiac markers like CKMB and troponin T. Also, there is evidence of COVID-2 antibodies in neonates. You have to test that. And same time, if the if the baby is antigen negative, that means he has MIS and which has been transferred from his mother. Is associated infection of maternal COVID infection. Even if the mother is not positive, she might have a contact history. There is a study which was done in 20 neonates in Kolhapur, which out of 20 neonates, 19 were COVID antibody positive. out of which only 10 mothers were COVID positive, but few of them had the history of recent contact with COVID positive. Either their relative was COVID positive or 50, half of the mothers were not symptomatic. So mother's severity of disease doesn't define the baby's severity. Only if the delivery and the infection time, the infection when the mother gets COVID positive and the time of the delivery interval, if it is more, baby tends to have a milder disease. These statements which I am saying has not been yet studied properly because there are very vague studies regarding MIS in neonates because the group study population is very small. Treatment wise, you have to go symptomatically only. You have to treat symptomatically. You should keep immunomodular therapy like IVIG for severe diseases. Usually steroid is the drug of choice. Initially should be started with methylprednisolone or prednisolone. Symptomatically fever you can use plain paracetamol suppositories. You have to treat the shock properly with inotropes. If there is a cardiac involvement, IVIG has shown to be having very good effects, good responses in babies with MISN. So basically, to summarize, MIS in neonates is an entity which has happened. Only the studies which have been done are very few because the recent we still don't know the long-term outcome of this disease because long-term studies are yet to come. Some very few studies has been done in India itself. There have been studies at multiple places, but the study population was very less. So MIS in neonates is an entity you have to have high index of suspicion. If you have the mother, if you have the history that mother is COVID positive and baby is going to deliver after that, you have to go for, and if baby presents to you with such kind of symptoms which I have told like fever and any respiratory complaints, you have to keep in mind the diagnosis of MIS in neonates. But at the same time, you have to rule out other entities which mimic like this, like sepsis and birth asphyxia and all. You have to rule out first that, then go for testing and treat the patient, treat the baby. Thank you, sir.
Yes, Abhay, you are rightly said. You have to exclude the other things because the clinical signs and symptoms are common like sepsis and all these things. But as from last 6 months, we are seeing this one baby from 10 in an NICU admission. They are not correlate with the normal things and their blood culture and septic skin are normal and baby is not behaving like the baby has tachycardia, tachypnea. At that time we have to suspect, and when we are doing the antibody came positive, and that baby, more of the maximum babies are presenting cardiac symptoms, and maximum babies are getting IVIG, and they are wonderful result on after giving the IVIG. So
one point I forgot to mention, sir. In the lab investigation, it is mentioned somewhere you have to go for early 2D echo in such babies because cardiac management is severe.
Yeah, those baby were not correlating our diagnosis, and the baby has suspecting this. When we are doing the 2D echo, there is something like pulmonary hypertension and some functional changes are already we are seeing, and the pro-BNP of that baby has highly raised. So we have to think about that in babies in NICU. This was the last question. Thank you to all panelists for giving the wonderful thoughts and their views on the questions and highlighting on the prenatal care. At last, I will like to give the thanks to the coordinator for giving the 15 minutes more for this presentation. And I will like to congratulate and my friend Dr. Naresh Taide for starting this wonderful CME. As he's a gem of academics, so he will do the work like that. I will also like to congratulate Secretary and Treasurer Sushil Rajput and Ruturaj Deshmukh. And at last, the man behind this, Dr. Satish Agrawal sir, who is encouraging all the new peoples and all the IPNs for that. Thank you very much.
Thank you, sir.
Thank you, sir.
Over to Arpita.
Thank you so much, sir. It was indeed a wonderful session. And after your session, like after the panel discussion, it was the most awaited and unique thing. It was very informative and very nicely explained. After your session, after your session, this statement has more value that when we hope for life without difficulties, we should remind ourselves that diamonds are sculpted beautifully only under pressure. So when there is no pressure, there are no diamonds. So now all the panelists, everyone is just a replica of diamonds. So here, if I'll go, hand over to Dr. Satish Agrawal, sir.
Thank you, Dr. Arpita, and really heartfelt thanks to you. You moderated the session so nicely. Your session right from the beginning until end. So what they call it as the thread which has taken all the pulse and made it a beautiful necklace. So you work like that. So my heartfelt thanks to you. Heartfelt thanks to all the panelists, the chairpersons, and mostly the audience. And all thanks to observers. And for formal thanks, now is the turn Secretary of IIT Amravati, Dr. Sushil Rajput, sir. Dr. Sushil, sir.
Good afternoon, sir, everyone. I am Dr. Sushil Rajput, Secretary on behalf of the IIT Amravati team. First of all, thanks to Dr. Satish Agrawal, sir. Because of him, this platform is growing not at the local level, but at the state and national level. On this platform, more and more young and dynamic personalities are getting opportunities from every faculty to present themselves in front of overgrowing audiences. We thanks today's special guest, IIM Amravati President Dr. Manish Tati sir and Senior Pediatrician Dr. Vijay Rathi sir for special appearance in today's session. We thanks to all the chairperson Dr. Gajanan Patil sir, Dr. Jyoti Bhup ma'am, Dr. Richa Wankhede ma'am, and Dr. Sagar Punami for chairing the session. We thanks to all the eminent speakers from different faculties, Dr. Trupti Javade ma'am, Kaustubh Deshmukh sir, Narendra sir, Manjushri Giri ma'am, Sachin Ajiwal sir, Amit Nimborkar sir, Samir Kedia sir, Pallavi Murke ma'am, Minal Amin, Alok Gupta sir, Pandrikar sir, Sachin Pavade sir, Tamchandak sir, Rupesh sir, Anita Bopre ma'am, Abhay Rathod sir, Nilima Thakre ma'am, and Dr. Suresh Thakre sir. Everyone, by their excellent and come to the point talk, has contributed to the make this CME successful. We also thanks today's session in charge Dr. Arpita, who beautifully shaped the CME like cherry on a cake. We thanks to Prakashji for all this backstage technical and clerical support. Finally, thanks to the audience for being with us and attending the CME patiently. It's already an afternoon and a high tea time. Enjoy with your family. Thank you everyone. And with everyone permissions, we end the session. Thank you.
Thank you, Dr. Sushil, sir. If anybody wants to express one's views, Dr. Prakashji, you may put out the recording. Now it's just informal chat. Prakashji, recording will be put off on YouTube as well as over here.
सर
Recording बंद कर देता.